oximetry system is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced INVOS 7100 system provides innovative, next-generation improvements over the INVOS 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module. Designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invo 7100 system provides innovative, next-generation improvements over the Invo's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module. Designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber.
Welcome back in TGIF. We have another outstanding group of speakers today you won't want to miss. We have them in blood management, professional development, and our infamous Shark Tank. This morning or this week, we've had approximately 600 registrants, not counting our exhibitors. We have presenters from 5 different countries around the world that has been representing Germany, Netherlands, Turkey, Belgium, and the US sharing their medical expertise. Again, I'd like to thank our committee members with Ty Walker, raise your hand, Ty, Bill Harris, Carla Mall, Kristen Irwin-Krause, and especially Brian Litch for trusting us and allowing us to organize this meeting for the 10th year. Also, a huge thank you for our coworkers back home that are taking up the slack for us so we're able to attend this meeting. Please visit our virtual booth exhibits and thank them for our continued support for our meeting. And they're 2 to 5 today, Eastern time. All you have to do is click on the link located in your booklet. And this evening from 5:15 to 6:30 p.m. Eastern time is our Shark Tank. It will be moderated by Ty Walker. So bring your drink of choice and your pizza and you won't be disappointed. This morning, Kristen Irwin-Krause will be our next moderator. Kristen is also an employee of Perfusion.com, working at Mercy Medical Center in Des Moines, Iowa. She is a Perfusion graduate of University of Iowa with a passion for blood management. Please join me in welcoming Kristen to moderate our next session of blood management.
Thanks, Susan. I'd like to introduce our first speaker this morning, who is Dr. Jonathan Waters. Dr. Waters currently serves as a professor in the departments of anesthesiology and bioengineering at the University of Pittsburgh. He is also the chief of the Division of Anesthesiology at Magee Women's Hospital at the University of Pittsburgh Medical Center, where he serves as the medical director of the Patient Blood Management Program. His areas of expertise include transfusion management, blood salvage, and obstetrics. Dr. Waters has over 150 peer-reviewed publications to his credit and has written 5 books on blood management. He has served on the editorial board of the journal Transpulsion and in various capacities for SABM, AABB, and on the Blood Management Technical Advisory Panel for the Joint Commission. Today, Dr. Waters will be speaking on the topic of maternal hemorrhage and the role of safe autotransfusion. Please welcome Dr. Waters.
Thank you, Kristen. I'm going to share my screen now. There we go. So this is the title of my talk today, is Autotransfusion and Obstetrics, a New Opportunity or a Liability? And I was thinking about this topic this morning, that over the 30 years that I've been an anesthesiologist, it's amazing how technology has evolved. And when I was a junior resident, we used to take our IV tubing and put it into a bucket of hot water in order to warm it. And now we have these fancy devices that can warm blood as it's being infused. And I think that the world of perfusion is evolving in the same way that heating of blood has evolved. And so I think one of the great opportunities for the perfusion community is in the high blood loss arenas, which are becoming smaller and smaller. And I think obstetrics and trauma are opportunities to evolve one's practice and develop an opportunity to make a few bucks. At any rate, this is me. As Kristen read off, I'm at the University of Pittsburgh. I'm in charge of our patient blood management program, which extends across 58 hospitals. And I'm also in charge of our bloodless medicine program, which, if you didn't know, the Jehovah's Witness Church was founded in Pittsburgh in 1872. So we have a very high concentration of patients here that demand bloodless medicine, which is kind of interesting because it teaches you really the extent at which you can push anemia. I've had 3 patients, all obstetrical patients, that dropped below a hemoglobin of 2, and all 3 of them survived. So these are my disclosures. So I'm a history buff. This is a picture of Blundell's blood gravitator, which was the first mechanism for transfusing patients. And it was done in the observation of a woman bleeding to death from obstetrical hemorrhage. And Blundell's blood gravitator was designed to basically have the father of the bleeding mom be the donor of the blood. And at the time, there was no citrate or no understanding of citrate anticoagulant. So the transfusion had to be direct, basically artery to vein transfusion, as is shown here. So maternal mortality is something that's very disturbing to the public health world because in the United States, this is the trend that is associated with maternal mortality in the United States. Back in 1990, there was a program at the CDC where there was an attempt to drop the maternal mortality rate to 3 per 100,000. Instead, we've gone the opposite direction to the point where it's almost 20 per 100,000. And in some populations in the United States, it's over 50 per 100,000. So we've got a problem. And a lot of it relates to hemorrhage, as is shown by this slide. This is some data from the CDC that shows the causes of death in childbirth. You can see hemorrhage is one of the largest categories, of death. But if you look at coagulation dysfunction, if you take this slide and you mix coagulation problems with hemorrhage, it all of a sudden 20% of the deaths during childbirth relate to coagulation dysfunction, either too much clotting or too little clotting. So this is an area, at least in obstetrics, that needs to be addressed. Now, if you look at subsegments of the population related to maternal mortality, you see that certain parts of the United States have different rates of underlying causes of pregnancy-related deaths. And for these particular states, Colorado, Delaware, Georgia, Hawaii, Illinois, North Carolina, Ohio, South Carolina, Utah, and Virginia, hemorrhage is the leading cause of death. So here's some data from the California Maternal Quality Care Collaborative. where they identified obstetrical hemorrhage as being a leading cause of death. And what they found is that if you look at specific causes of why people died from what is shown here: cardiovascular disease, preeclampsia, hemorrhage, VTE, amniotic fluid embolism, basically failing to respond in a timely fashion is the leading cause of death in these circumstances. And so I'm going to try to address, at least later in my talk, how we go about identifying when women are bleeding excessively. So autotransfusion in the obstetrical world was first pioneered in 1874 when William Highmore published this paper in the Lancet, where he described observing a young woman bleed to death, basically as right after she had delivered a baby. And what he says in the bottom of this, this manuscript was that wouldn't it be nice if we could collect that blood, you know, that she had shed, and basically filter it. And at this time they were filtering with gauze, which sounds pretty sophisticated, and then re-injecting it. And perhaps this would be a way of saving these women's lives. So over the next 50 years, this was the primary mechanism for transfusing patients, was the unwashed autotransfusion of blood. And this is taken from a report from 1934. And this is before really the advent of blood banking, or modern blood banking as we know it, where they reported on 272 cases of unwashed autotransfusion. And most of these were basically ruptured ectopics, which was a leading cause of death in childbirth at this time. But they found that they could save a large percentage of these patients, except when they used old blood, which was greater than 3 days old. So there's a long-standing history for autotransfusion and obstetrics, and that's a point that I want to drive home, is that there has been an association of our modern autotransfusion washing devices with contraindication to use in obstetrics, but autotransfusion was really pioneered in obstetrics, so we need to get away from that contraindication. So in 1974, this device was pioneered. It's the Bentley autotransfusion system, which basically was intended to suck blood out of the surgical field, collect in the reservoir this globular device as shown here. And then there was a roller pump that was intended to pump the blood right back into the patient who was bleeding. Now, one of the problems with this particular device is that when the collection reservoir emptied, the roller pump wouldn't stop. So very rapidly from the advent of this device, there were reported deaths that resulted from air embolus, because the roller pump would continue regardless of whether the reservoir was full or empty. So this unwashed autotransfusion is still used in many parts of the world. These are a couple of companies that have devices that specifically are intended for unwashed autotransfusion. Sisu Global has what is basically just a giant syringe where you suck the blood out of the surgical field, and then you basically push the plunger of the giant syringe and force the blood right back into the patient. There is a filter within this device. And then the HemoClear is something very similar, though I think the filter technology with the HemoClear is a little more sophisticated. But again, this unwashed autotransfusion continues to be a leading source of red blood cells in much of the world. So back in the mid-70s, we developed these devices, the washing machine. This is Soren Electra, or Alexa, I'm blanking on the name, forgive me. But we got these washing machines back in the mid-70s, and at the time, the FDA asked Haemonetics, which was the first or the pioneer of the cell saver, they asked them to do safety studies on using their devices in obstetrics. And they decided that the cost of doing these studies was too great because the incidence of amniotic fluid embolism was so low that they would have to have a study that was powered with 4 million patients. I think 4 million. At any rate, they decided that they would make it easy for themselves, and they just labeled the devices as being contraindicated in obstetrics. And so that's the mechanism for the contraindication that many of us know about. So what we're fearful of in obstetrics is basically amniotic fluid contamination. And now I'm going to talk about that for the next few minutes. Is this really something that we should be fearful of? Now, amniotic fluid embolism has been given this name because on autopsy, women who have died from what looks like this embolic phenomena have amniotic fetal squamous cells in their pulmonary arteries. And the spectrum of amniotic fluid embolism covers what is shown here on this particular slide, with cardiopulmonary arrest being the final step. And so we definitely want to avoid this if we can. We don't want to be infusing amniotic fluid that might lead to this embolic phenomena unnecessarily. But here's kind of the heart of the problem: is we really don't know what causes this embolic phenomena. But we do know, that the mortality rate is significant. 60 to 80% of women that have this particular problem die. And of those that do survive, they are not neurologically intact. I've only faced one of these in my career, and I gave escalating doses of epinephrine in order to resuscitate her, and then she ended up going into DIC and bleeding to the tune of about 28 units of red cells. So this is a bad thing to face if you're taking care of one of these patients. So as I mentioned, the sample size to study this particular problem, I think I misquoted. I said 4 million, it's only 2 million. Still unwieldy study size in order to test whether or not it's truly safe to use this autotransfusion technology in the obstetrical world. So we really need to ask ourselves, whether or not there's surrogates of figuring out whether or not it's safe to use autotransfusion in obstetrics. And so when I started doing so, I asked myself these questions. Can I remove the biochemical contaminants? Can I remove the cellular contaminants? And can I remove bacterial contaminants from the blood that I'm reinfusing? And so we'll start with biochemical contaminants. And this is a study that was done back in the late 90s that looked at the primary biochemical contaminant that's present from amniotic fluid. And amniotic fluid embolism has been attributed to result from tissue factor, which is thought to lead to the DIC that's seen following an amniotic fluid embolic event. And so you see on the far right hand side of the slide that tissue factor, the washout from a simple 1,000 ml wash is basically 100%. This investigator showed that there was no tissue factor activity after washing a unit of blood. And we know that most of the biochemical contaminants in an autotransfusion unit wash out in parallel, such as shown here by Dale Spizak, is that if you have one contaminant, it will wash out very similarly across the board, irregardless of what the contaminant is biochemically. So I think we can feel assured that we're removing the biochemical contaminants. What about the particulate contaminants? And that's where I think that these things come into play. This is a leukocyte depletion filter that is sold by Haemonetics. It formerly was sold by Paul, but the patents for this device have been sold to Haemonetics as the blood management company. And this particular filter has remarkable properties that I'll talk about later. But this is the effect that it will have on a unit of blood or blood that's been contaminated with amniotic fluid. So what you see here in this picture, and I don't know if you can see my, my cursor here, but what you have is these red things. These are fetal squamous cells from the fetus. And this is from blood that was collected with all the amniotic fluid. So there was blood with about 500 mLs of amniotic fluid that contaminated this blood. And these things, fetal squamous cells, this is what the pathologist that I work with on this particular study called amorphous gunk, technical. And then these black dots are leukocytes. And then in the distant background, like right here, are the red cells. The staining technique really doesn't show the red cells very well, but it does show you all of the other particulate contamination that has taken place with the collection of this blood and amniotic fluid. So this is what happens after washing. As you see, that amorphous gunk has gone away, but we still have the leukocytes. We still have these fetal squamous cells. And now this is a higher power magnification, and you see the red cells a little better here. And this is what happens after using a leukocyte depletion filter on these red cells, is that all of those particulate contaminants are gone, the leukocytes are gone. All we have is red cells, and these are the red cells at another degree of magnification. So we have nothing but red cells suspended in normal saline at the end of this processing. And so this is the results from this particular study that I published back in 2000. And I didn't think I could achieve 100% washout of all of the materials that were in the amniotic fluid or in the blood that we collected. And so what I did is I compared a maternal blood sample that I drew at the point of placental separation from the uterus. And I compared that to a post-wash, post-filtration sample, as is shown here. And what you see here is that all of the contaminants in this blood were removed by the washing and the filtration, with the only contaminant that was in higher concentrations than what was in the maternal blood was fetal hemoglobin here. So any treatment of RH incompatibilities between mother and baby should be addressed after the autotransfusion blood is administered, because it won't be totally effective if you do it before that point. So then moving on, bacterial contaminants is another source. The vagina has a high concentration of bacterial contamination. So if you have a mom that's delivering a baby either vaginally or has had her membranes ruptured for a prolonged period of time, there could be sizable amounts of bacteria that is in this blood. So what can we do about that? So this is from a study that I published when I was at the Cleveland Clinic. And what we did is we took expired units of blood and we contaminated them with these particular bacteria to the these particular degrees of colony-forming units. And the microbiologist that I worked with this study said this is massive contamination. So when the bacterial contamination was diluted, with a unit of blood that was about 300 mLs, these were the final concentrations of colony-forming units. And what you see here is what happens during the course of processing. You have a fairly sizable reduction just by washing the unit of blood. And this has been shown in a number of different studies, primarily in trauma, that just the simple washing process removes about 80% of the bacterial contamination. And then this is what happens following the filtration with one of these leukocyte depletion filters, so that we end up with basically almost 100% removal of bacteria, as is shown in the far right-hand column. And it seems to be dependent upon the specific bacteria, but this is pretty good. And what has been demonstrated in these trauma studies is that if you have stool contamination of the autotransfusion blood, the effect of any postoperative infectious complications are basically eliminated through the administration of IV antibiotics. So I think the same thing applies here in the obstetrical world. So before this paper got published, the editors of the journal Anesthesiology asked me to do a dose response curve to see what the effect of increasing degrees of bacterial contamination would provide in terms of the end product. So this data comes from just simply filtering contaminated blood. There was no washing that took place before the end results were shown here in the middle column. And just by the simple filtering of the blood, we were able to remove somewhere between 50 and 80% of the bacterial contamination, which is pretty remarkable. But the point being is that we want to minimize the amount of bacteria that's presented to the washing device and the filter, so that we start off with a relatively low degree of contamination, so that we have a smaller degree of contamination at the end of the processing. So this is the heart of one of the recommendations that I make with autotransfusion in obstetrics, is that the amniotic fluid should probably be detoured to a secondary suction system, so that we minimize the amount of contamination that goes into the autotransfusion device. So the other way to look at this is, what about the alternative? What kind of contamination would we see if we went to the blood bank and asked them for blood products that come from a donor? And this is some work that Rosalind Yamtovian published from Case Western Reserve in Cleveland, that she looked at platelet contamination and found that oftentimes platelets were contaminated with pretty sizable degrees of bacterial contamination, as is shown in the far left column. And this results from the skin plug that is incorporated into the blood product when the needle is placed into the donor's arm. So it's not, you're not avoiding, any bacterial exposure to the patient by simply giving up on autotransfusion and going to the blood bank. So at any rate, what kind of clinical data do we have to say that it's safe? And this is from a colleague of mine in Rome, Giancarlo Leombruno, who collected all the case reports of autotransfusion and obstetrics, and he came up with 1,600 cases where there were no adverse effects of autotransfusion and obstetrics. And that has resulted in all of these organizations recommending autotransfusion during obstetrical hemorrhage. And these are some pretty high-powered organizations such as the American College of Obstetrics and Gynecology, National Institute for Health and Clinical Excellence, the NICE group in the UK. So we need to start considering it for our patients in the United States. So when does it make sense to do autotransfusion during obstetrical hemorrhage? And this was a study that I published with one of my medical students. And we looked at the numbers of units that we were producing per obstetrical case. And we used this formula down here to calculate what I would call a packed red cell equivalent. Basically, measure the recovered blood volume, and our quality measurements demonstrated that the machine that we were using, the CoBRAT at the time, produced on average a hematocrit of 53%. And then the blood banking community has defined a unit of red cells as being 200 mLs, give or take 25 mLs. And so we were able to basically translate the amount of autotransfusion blood that we were able to collect into packed red blood cell equivalents. And this is basically a curve showing the numbers of units that we were able to collect from this particular study, or in this particular study of 884 cases of cell salvage being performed in obstetrical environments. And so these are the primary areas that we looked at: cesarean delivery, cesarean hysterectomy, bleeding post-cesarean delivery, which oftentimes is from uterine atony, and then vaginal delivery. And this is the number of cases that we were able to collect. And you can see in the parentheses is the percentage of patients where blood was actually given back. So when we were doing it just in a cesarean delivery, the percentage of patients that got their own blood back was fairly low. But in these other environments, such as cesarean hysterectomy, or where they're actively bleeding, there was a much greater production of blood. And here we basically reported on the numbers of units that we were able to deliver back to the patient. So it was almost 2 units during cesarean hysterectomies, which is easily cost effective. So one of the things that we've proceeded to do is, from this work, I started noticing that my obstetricians were asking my autotransfusion technicians to collect blood from patients that had vaginal bleeding. So we've now collected 64 patients that have had vaginal blood collected and reinfused. And this is some of the demographic data that comes from these deliveries. And this is some more data. You can see that the QBL, which is the quantitative blood loss that's become very popular in the obstetrical world, is not insignificant. 2 liters of blood loss during one of these vaginal hemorrhages is pretty significant. And we were able to transfuse back to the patient about almost 400 mLs of this blood. So we've started working with Jim Trickett, who is a perfusionist who has invented this device, the HemoSaver. And Jim has been working with us to utilize these in all our labor and delivery rooms, so that when we start to see vaginal bleeding that is unusual, and vaginal bleeding that is unusual is any time that we have more than 500 mLs of blood loss. And so this device allows for the blood to be collected within the labor and delivery suite. And then it's easily drained into a cell salvage collection reservoir through the red port on the top of the device. So that's where we've evolved to, is we've started taking it into the vaginal delivery world. And it's interesting, I think the bacterial contamination that one might expect is probably overrated. And at least from the trauma data that I've reviewed, it seems to be okay as long as perioperative antibiotics are being administered. So now moving on to some practical aspects of making autotransfusion and obstetrics successful. This is one of the keys, is how do we collect this blood? First of all, when I was at the Cleveland Clinic, we had our labor suite that was in a building that was far removed from our main operating room where our cell salvage devices were located. So I used to keep a collection reservoir, a bag of citrate, and a suction line in each of my operating rooms, so that if somebody started bleeding unexpectedly, I could start collecting it while I called for a machine to be delivered. And so this simple standby system is what allowed me to collect the blood while I waited for the machine to arrive. Now, when should you utilize the autotransfusion system? This is kind of the default that we have determined here at McGee Women's Hospital, is that when 20 laparotomy pads have been utilized, that means that the blood loss is unnecessarily large. And so this is our trigger for bringing in the autotransfusion equipment, is when we go to the 5th pack. And so it's a clear-cut determinant of when we bring the devices in, which given that we have looked at this, statistically, nobody can really argue with you as to whether or not there's unusual bleeding that's going on, which oftentimes surgeons have their feelings hurt when you suggest that the bleeding is unnecessarily large. Now, with obstetrical hemorrhage, a lot of it is going to go on to lap pads. And so we advocate for piling all of our lap sponges onto our surgical scrub table, so that if in the course of the care of a patient, we determine that the bleeding is unnecessarily large, we can take those lap sponges and rinse them in a basin of saline. And so this is a lap sponge that came from a cesarean section. And you can see that it's fully soaked with blood. And in general, it's thought that to soak a lap sponge fully, it will suck up about 100 mLs of blood. So about 4 lap sponges are equivalent to 1 unit of packed red blood cells, if you're able to capture these red cells. And so rinsing them in a basin of saline, as is shown here, results in a lap sponge that looks like this. And we've done some work where we've looked at the removal of red cells from the lap sponges, and we can achieve about a 95% capture rate of red blood cells by simply rinsing these lap sponges. And I can state pretty unequivocally that 90% of the red cells that are lost during a cesarean section are going to be onto lap sponges. They're not going to be into the traditional suction canister. So moving on, I just want to talk a little bit about filtering, because I think this is how you can sell autotransfusion in environments that have historically been thought to be contraindicated, is that you can basically convince the surgeons that the filtration process is highly effective at removing any kind of contamination. So there's two types of biological filters, and you guys probably know this stuff better than I do. But there's screen filters and depth filters that are used in autotransfusion. In the traditional collection reservoir, as is shown here, there's a sleeve that contains a filter, typically 40 microns in size. And this is a screen filter, as is shown here. So a screen filter means that it works just like a window screen. It has pores that are smaller than 40 microns. And so particulates that are smaller than the pores will get through the screen. But particulates that are bigger than the pores will not. So it's just like a screen and a window, not letting mosquitoes into your room. This is just a slide showing some of these filters that we have available to us. On the far left is an SQ40, which is a filter that is a screen filter. The SQ stands for square. The 40 is the micron size that it'll let through. The middle picture is a Lipogard filter that's been designed to remove particulate, or rather lipids, globules, such as found when you're doing autotransfusion in hip replacement surgery, where they're ramming devices into the femur. This is fairly effective at removing the lipids. And then the far right is a Leucogard filter, which works in a little different fashion than the SQ40 or the Lipogard, in that it's a depth filter and not a screen filter. And so this is the particles that will be removed by each of these devices or each of these filters. And you can see the characteristics of them. So I mentioned the depth filter, the Leucogard. This is a Leucogard filter, and the depth filter means that the blood flows in through the arrow on the right. It goes through a depth of filter material, and then it exits through what is shown on the arrow on the left. So it has to migrate through a depth of the filter material, which is polyethylene fibers, as is shown here. And as the blood migrates through this filter, it goes from a low density polyethylene fiber, as is shown on the left, to a high density fiber concentration on the right as the blood flows through the filter material. So there's a large depth of material that these red cells have to flow through. And red cells are designed to basically be distensible. So they're able to migrate through this filter material, but other contaminants such as fetal squamous cells or bacteria are not able to. And just some understanding of the size, these depth filters are not filtering via the screen size. They're filtering based on adhesion onto the filter material. So you can see that a red blood cell has a 5 micron size, whereas most of the bacteria that we demonstrated are filtered out by these filters are much smaller. So clearly the mechanism for filtration is different than a typical screen filter. And these are some of the physical characteristics that these filters work by. Most is adhesion via the surface charge of a red cell, which is different than all of our other body cells. So some of the things that we need to keep in mind when we're doing autotransfusion and obstetrics is that the bag containing the red cells, in order to get it through one of these leukocyte depletion filters, needs to be pressurized to about 300 millimeters of mercury in order for the flow rate to be adequate. If you do it by gravity, it's going to take too long and everybody's going to give up on you. The other thing is that recognizing that these filters get plugged up with particulates. And so they should be changed out about every 500 mLs of blood that are run through them. So some of the limitations of this filtration is the particle load, as we talked about earlier. You want to minimize the particle load as much as possible. If you have too big a load, you're going to be able to remove 99% of the load. But if you have 10 to the 7th, 99% means that you're left with 10 to the 5th at the end. So you want to minimize what you're presenting to the filter. So now there's been a couple of case reports that relate to these leukocyte depletion filters in obstetrics. This is one of these case reports where they reported on severe hypotension that they attributed to the leukocyte depletion filter. I would argue that this is not related to the leukocyte depletion filters because in the blood banking world, they've shown that when you're using leukocyte depletion filters, it generally requires there be a use of ACE inhibitors by the patient before you have this hypotensive reaction. And ACE inhibitors are going to be extremely unlikely to be seen in an obstetrical patient. But anyway, I personally think that any cases of hypotension that may result are probably more likely related to misoprostol, which is a hormone that's placed rectally or vaginally to induce labor. And then this particular drug can be present in the surgical field if you're doing a cesarean hysterectomy, if it's been placed within the last 24 hours. So if you have a severe hypotensive response after re-administration, think more along the lines of unusual drugs being in the blood product. And this is one of those drugs that might be there. So I have ended my presentation, and I'll be happy to answer any questions at this point if you have them.
Thank you so much, Dr. Waters. That was really interesting. I know that that is something that at my home institution, we've started exploring a little bit. There are some questions in the chat regarding different wash settings or bowl speed and how that might impact improvement in final product. You have any thoughts on that?
Well, I mean, the faster you process, the less concentrated your red cells will be, and the less washout that you'll achieve. But I think in general, if you just follow the manufacturer's recommendations, you'll be fine. I don't think there's any magic to speeding up or slowing it down.
Okay, so you didn't do anything special where you slowed your speed or
No,
did anything along that line?
I mean, we've used the CoBRAT for pretty much the 884 patients that we reported on. We've subsequently converted to the Sorin device, but I don't think it really matters. The technology is all pretty much unchanged since 1975, other than we've lost some ability to flex the bowl, so to speak, where we would change the centrifuge speeds, which I used to love to do, but these newer devices don't give you the ease of doing so.
Yeah, I think some of them have different settings than others for sure. Kind of going along with that, did you typically just use like a regular bowl size that was available in your institution for cardiac surgery, or were you trying to use a pediatric bowl size?
We have typically used a smaller bowl size in our obstetrical world, 135 ml bowl, because the blood loss from obstetrics is generally pretty slow, unless you manage to nick an ovarian artery or something like that. but I think the smaller bowl sizes are probably lend themselves better to an obstetrical environment.
Right. From the perspective of perfusionists who might want to bring this to the obstetrics world or suggest this, what, I guess, pushback have you seen, or what challenges can we be prepared to overcome? I mean, I could obviously address the amniotic fluid concern.
Well, the amniotic fluid concern is definitely the pushback that you get from the obstetricians and probably the anesthesiologists also. There's also the concern about bacterial contamination, but I think both can be addressed with the leukocyte depletion filters. If you can assure those particular physicians that you're removing 99% of these contaminants, they will, at least in my hospital, which is, we're the busiest obstetrical hospital in the state of Pennsylvania. We do about 10 deliveries a year, and we have, I think, 172 obstetricians that work in our facility. They all pretty readily agreed to autotransfusion use when I assured them that the filters were what would remove anything that was of concern. So it was a pretty easy sell with the filtration. And I think, you know, the other big environment that we have poor take-up of autotransfusion is in trauma. And I think that's another environment that's worthy of doing more studies demonstrating safety. And I think that autotransfusion, as the surgical technology is advanced, where we're using a lot of robots, you know, the two big blood loss procedures are going to come down to obstetrics and trauma, and you can't deliver a baby minimally invasively. So it'll always be an opportunity, I think, for autotransfusion use. So, I mean, I think those two environments are places that we need to evolve towards.
I have a question. When you basically are putting these bags under pressure, are you transferring the blood from your autotransfusion into another bag and then putting pressure on it? Because more or less, you shouldn't be putting pressure from the guidelines and from the manufacturers not pressurizing the actual autotransfusion bag.
Yeah, so we're putting pressure. I mean, you can do it in two different ways. We transfer every unit of blood from the primary reinfusion bag to a secondary reinfusion bag, so that we can separate the machine from the patient.
Correct.
And, you know, air emboli result from people spiking the primary reinfusion bag and then pressurizing it, so that the air in that bag gets pressurized into the patient. And so by having processes and procedures that physically separate the blood from the machine, you can basically avoid that. And so what we do is we either pressurize the blood at the primary reinfusion bag into the secondary reinfusion bag, and we cut the connection between those two bags and hand the blood to the anesthesiologist as if it was a unit of blood from the blood bank. And so it's totally separate. Or we move the bag, or rather move the blood from the primary reinfusion bag into the secondary bag, separate that secondary bag from the primary bag, and then hand it to the anesthesiologist. And then we use the filter at that point when it's going into the patient. So either way, it's being filtered with the leukocyte depletion filter. Is that?
And in the trauma setting, do you have a reservoir kind of set up down with protocol, so that I know in a trauma situation, you're not going to have time for someone to just come in and start doing autotransfusion? Or you have a protocol where they're starting to collect the blood and then have someone come in as they're collecting the blood unit?
Yeah, our trauma surgeons are kind of finicky. We have only achieved success with solid organ injuries. We've not had much success with penetrating bowel injuries in terms of getting our trauma surgeons to use it. I've got a study going on right now that is kind of failing miserably to collect blood from penetrating abdominal trauma to try to demonstrate, that we can achieve a significant removal of bacteria. But the timing of trauma, a lot of it comes in the middle of the night, and having technicians there to be able to process the blood and collect blood samples for bacterial testing has been a logistical nightmare, so to speak. So we do have machines that are in our ER. And I also have machines in our labor suite so that we can implement it within about 60 seconds. It's very rapid that we transfusion care. But there are logistical obstacles, no question.
Dr. Waters, and if I missed part of this, I apologize, but some of the attendees have asked about your choice of anticoagulant in the different situations relative to citrate versus heparin versus anything else you might use. Your preference seems to be citrate in most situations. Can you comment on that, please?
Sure. You got basically three choices. You got heparin, you got citrate, and you got mixing heparin with citrate, as the options. The thing about heparin is if you spike a bag of normal saline with a needle to inject heparin into it, it can only be kept for 24 hours, at which point the FDA requires you to start doing bacterial testing. Whereas a manufactured bag of citrate that you've kept in its packaging, you can hang from your machine, rip off the packaging, and start processing almost immediately. So we use predominantly citrate for that reason, is the FDA has made it difficult. It is, there's a cost differential. The citrate goes for about $7 a bag, and I think the heparin is nickels. But the convenience of using citrate, where we don't have to do that bacterial testing, is why we use citrate.
Are you still using a 7-to-1 ratio that I remembered from way back, or has that changed?
Well, I think 15-to-1 is
15.
Yeah, but I think there's this perception from a lot of surgeons that the heparin is not washed out, and patients get coagulopathic, relates to inadequate washing. I think that's bullshit. I think we can wash out the vast majority of heparin or citrate, and you're better off erring on the side of more anticoagulant than too little, because if you develop a giant clot in your collection reservoir, then that blood's gone.
Well, then other than, citrate, correct me if I'm wrong, the reversal is obviously calcium. And the problem with citrate would be just your pH, and that would take a lot of citrate to cause your patient to be more acidotic.
Yeah, and people don't recognize that, the blood bank, the blood that you're getting from them is, anticoagulated with citrate. So you're going to get the same problem regardless. And, in a massive hemorrhage, you need to be monitoring calcium concentrations and replacing it as needed. I see that as being a relatively minor inconvenience during the course of a major hemorrhage. So.
I have a question. Go ahead, Brian.
I was just going to say, what would you say to a surgeon that kind of considers cell saver blood as dirty blood, or maybe not up to standards for some reason or another, and would rather give a unit of packed red cells than give the blood from the cell saver. How do how would you approach that?
Well, I think there's a number of ways to approach it. One is, like I talked about, is that blood from the blood bank is not necessarily sterile. Number two is that, the standard that the blood bank uses for the length of time that they store a unit of blood is that upon readministration, 75% of those cells are going to still be alive. Which means that 25% of the cells in that unit of blood are going to basically lead to free hemoglobin and red cell stroma being infused to the patient. And the red cell stroma is a potent instigator of DIC. The free hemoglobin plugs up the kidneys. So massive hemorrhage, where you're replacing blood with allogeneic blood is not so good for the patient either. And when you think about washing, a lot of people like to wash their allogeneic blood specifically for those reasons, to get rid of the aged red cells that are, basically that have died during the storage period of time. I don't know do you guys do that? Wash your allogeneic blood?
It's 8 hours.
I have for some institutions that I've worked at, yes.
Yeah. This is something that is limited in the amounts of research, but the reason that people do it is to get rid of the dead cells.
And you more or less with the blood banks, what you have to do is you have to have a written protocol, and they have to pass it through the blood bank so that you can do that procedure. So therefore, it isn't something that you can do by fly by night. You have to have something already in writing and approved by the pathologist in the blood bank area.
Yeah, I found, when I was at the Cleveland Clinic, which you guys, many of you met me when I was there, in the Moon Palace days. I used to do all the major vascular cases, all of the thoracoabdominal aneurysms and all of the aortic aneurysms. And I quickly noticed that when I transfused blood from the blood bank, my patients became coagulopathic way sooner than when I used their own blood that had been washed. And we achieved some pretty remarkable things with some of our surgeons in terms of the outcomes. We took one surgeon that I'll call Dr. Bleed-A-Lot, that used to do prostatectomies he would lose 3 liters of blood. And his average transfusion rate was 3 units of red cells. And we started doing autotransfusion and normal volemic hemodilution on his patients. And we went from 3 units of red cells to 0, despite the fact that his surgical technique hadn't improved. But his postoperative infection rates went from 40% to 0%. So that's another argument, in terms of, using a patient's own blood, is that there is a fair amount of data that demonstrates that allogeneic blood leads to infections. Now, the blood bank community will argue that, those kinds of impacts have gone away with leukocyte depletion, universal leukocyte depletion, but I still think stored red cells that don't have their normal shape and size, and where 25% of the cells are dead, that can't be good for a patient.
Are there plans for design for better more efficient leukocyte filters that can offer that can minimize the time of transfusion because of the resistance of the filters?
Well, I don't know if there's any plans to do that, but you can move a unit of blood through a leukocyte depletion filter in about 90 seconds if you pressurize it. If you don't pressurize it, it's going to take 20 minutes. So you really do need to put some pressure on that blood to get
And
it.
does pressurizing it lose the effectiveness of the removal of the leukocytes? Do you know?
If you overpressurize it, if you go beyond the recommendations of 300 millimeters of mercury, you can basically blast things through the filter. Yeah, so you need to be cautious there. So I think I've extended beyond my time. So
Well, thank you so much, Dr. Waters. It's very interesting, and I know it's so applicable for so many of us that are listening today. So thank you for taking your time to come speak with us.
thank you for having me.
Jane had to drive.
Next, we're going to be joined by Dr. Bruce Spies. Dr. Spies is currently the Associate Chair for Anesthesiology at the University of Florida School of Medicine in Gainesville, Florida. And
Shirley said
getting
that her
some background
doctor
noise
said that
here.
it was fine for her to have a glass of wine a night.
Is that better?
Yes. Dr. Spies is currently the Associate Chair for Anesthesiology at the University of Florida School of Medicine in Gainesville, Florida. He has previously held positions at Virginia Commonwealth University, the University of Washington, and Rush University. His wide expertise in the areas of blood research and patient blood management have included over 200 articles and more than 40 book chapters. Dr. Spies is also an accomplished speaker. Of special note to our audience, Dr. Spies was the first to author research studies regarding using thromboelastography for heart surgery. Today, Dr. Spies will be speaking on patient blood management and how it fits in the context of COVID-19. Please welcome Dr. Spies.
Good morning, all. I am trying to share my screen and it's just starting to come up here. So
Okay.
I'm not sure if you can see things. Hang on one second. Let me see if that is that coming up. Something's coming up.
Yep.
Okay.
And then I think you just need to go to the view.
There we go.
There you go.
All
That
right.
was great.
Oh, the panic of not having your computer do what it wants to do, or it doing what it wants to do, not doing what I want it to do. Thanks. It's great to be back with so many good friends. It's really tough to follow after Jonathan Waters. He's such a erudite, great statesman for patient blood management, and he and I overlap in so many different ways. Excuse me. But I'm thrilled to be here today to talk to you about a fascinating subject, and it's something that's not being put into the news much, and that has to do with blood transfusion and COVID-19. Excuse me. Let me have a sip of coffee. Hang on. There's so much to do with blood that once you start digging into it, it's frankly scary. I will touch on some things that I think I might be a bit outspoken on. And if there's ever been a time for us to really practice and dig into patient blood management, it's now. And I'll show you the reasons why I believe that. So we'll start off with a bit of an outline about pandemics, history and context. All of us are living through today's present day pandemic. We should always remember that the biggest deaths, the largest number of deaths in mankind's history have been from pandemics. Disease is what culls the population. Wars and stuff are far less of a problem than our pandemics. And if you think this is the last one we're going to have, I got some thoughts for you. It's going to come around again and again and again, and whether they come more frequently or not, we can argue about. We'll talk a little bit about some underlying science, some of the science for COVID. There's a lot you hear about on the, on the news media and stuff, but there's so much going on behind the scene, and frankly, there's an explosion in medical knowledge that's occurring that's been, I think, unseen in the history of mankind, and it's fascinating, and in many ways, it's great to be on that forefront. There's an explosion in ECMO usage. We can talk about that. That probably affects your specialty a fair amount. And and some of it's good and some of it's bad. The reliance on ECMO for COVID has, as I said, many ethical overlays, but what if all the ECMO machines in your hospital are tied up with COVID patients, and they're tied up for 6 weeks at a time or longer? What's the right thing to do? Is COVID hematogenously, boy, that's hard this early in the morning, hematogenously spread? Is it in the blood supply? I'm going to put it to you right now, it is. The blood bankers in the United States, at least, don't want to know that. They don't want you to know that. They don't want to talk about it. But if you go to some of the literature, it's out there. And then we can talk about pandemic models, what happens as pandemics take over the blood supply. And we can talk about immunosuppression with transfusion, COVID implications, on and on it goes. There are so many implications. So I'll digress off on a slight tangent with a few of my thoughts on the COVID virus. It's a clear and present danger. It's a moving target. These data, this slide I first made out in March, but look at the explosion, and these data are already old. And today's data are old compared to yesterday. And we get pretty fatigued, each of us, with news media fatigue of COVID, as I guess as Trump said, COVID. It's all we hear about. But it's really huge. And where you are depends a lot on your experience. COVID wards in New Jersey being put up as standalone hospitals. I don't know if we have any standalone field hospital situations going on in the United States right now. But with the explosion that's presently happening, it wouldn't surprise me if it does. And human frustration is rampant. It's not just our country; it's rampant worldwide. And people are doing strange things because of the frustration. And I will say that pandemics in the past have destabilized nations. They destabilize governments. They destabilize economies. It's not just you and I on the medical care front, but there's every part of society goes through it. So you might think viruses were an evolutionary step towards bacteria, et cetera. But if you really dig into it, they're a throwback. In other words, probably viruses could never exist on Earth until we had eukaryotic organisms with multiple cells. In other words, a virus is merely a piece of nucleic acid that's surrounded by protein and perhaps a lipid coat. It has to have a cell, and it really has to have multiple cells to be able to survive, replicate, and exist. So a virus has to have evolved sometime after bacteria and potentially after multicellular organisms came to exist on Earth. So it's not really a pre-bacterial little nucleic acid piece of material, because as I said, it can't replicate without having some other cell to function as a host. So it as a pest or as a vermin or as a it had to evolve sometime later on. Now, our little fella in one artist's rendering can look rather beautiful. It can also look like a water mine in some war zone. And we spent lots and lots of times in the lay press about these spike proteins that hang off, and we'll talk about those spike proteins in a bit. And that's how the virus actually attaches onto our pneumocytes and potentially other cell sites as it goes through the respiratory tree. But we have ACE receptors throughout our body, not just in our lungs, not just in our pulmonary circulation. So that may be a fairly ubiquitous way that it binds to cells. So a few factoids about infectious diseases. As I said, this has been the largest culling of the herd ever, is through infectious diseases. The first one we know about is in about 5000 BC in China, where an epidemic probably occurred because there are mass burials all over in China from that period. And it goes on and on and on. Obviously, we know a fair amount about the Middle Ages and plagues, but the first bubonic plague may have killed as many as 5 million people in the Roman Empire. And if you think about it, the Roman Empire at that time was only about 10 or 11 million people worldwide. So 5 million was, 50% of the population died. I attend on Thursdays a very unique think tank group of people working on the front end of COVID worldwide. And this think tank group last week discussed two of the unintended side effects. Maybe that's not the right word for it, but two of the unique observations that are occurring right now. Bubonic plague is back. Pneumonic plague is back, and it's back as a side effect of COVID. It's complex, but plague and tuberculosis are exploding worldwide, and it may be because of some of the things having to do with COVID. We could dive into that if you wanted to. And here's a bunch of the rest of the plagues that have gone all the way up until 2009, 2014, 16. Swine flu in 2009 and 10 was, we thought it would explode the way COVID did. It didn't, but still worldwide, 574,000 people worldwide died of H1N1 flu. And I'm going to show you some data where BARDA and the NIH and the FDA have used it to model what would happen had H1N1 flu exploded in the United States. Now, it's interesting they modeled that, but they never did anything with their model. And so they knew about it. They knew what was about to happen, but people just wrote academic papers and never did anything with it. And of course, Ebola's out there. Ebola's rearing its head again in the last 6 weeks or so in Western Africa. And then there's Zika, West Nile, MERS, SARS, and now COVID-19. SARS, MERS, and COVID-19 are all coronaviruses, all have this unique lipid coat that has the spikes and use the same methodology for entrance into cells. So we ought to learn some things out of that. But we also ought to learn some things out of our medical public behavior in terms of these most recent epidemics. And Zika and West Nile particularly for blood banking should be telling for us. We should have learned from them, but I'm not so sure we have. We live in a global world. I don't know how many of you have stepped on a plane recently. I just did because I'm up in Chicago right now seeing an elderly mother. But none of us have traveled much in the last year or so, year and a half. I certainly used to be, big international traveler. I'm not doing that, but still, even today with limited travel, we're still moving our viruses around the world, whether we like it or not. And you can say, well, where's the virus? Where is the virus? What is the real world picture? And you can say, here's the hot spots for the epidemic. But I'm going to tell you, this is a picture that's wrong. It's upside down. It's incomplete because we don't get information out of Africa, South America, Oceania, Southern Asia. We don't get reliable information and reports daily on, hey, how many people reported to hospital? What's the chance of doing a PCR in Zimbabwe to find out whether somebody has or does not have the COVID virus? Doesn't happen. Not going to happen. No, there's only three PCR machines in Africa. So what kind of information are we going to get? We don't really know what's going on. So the underlying science, it's really complex about the COVID virus. here's one of the fascinating things is, these glycoprotein binding sites that attach to the ACE surface are very important. That's been widely studied, but how it gets into the cell is something really important. That's actually something I'm working on. And that's a therapy that I'll show you at the end with using inhaled adenosine. We can stop that from happening. We can clog up the pore wherein the virus enters the cell by giving inhaled adenosine and stopping the process. I'll also tell you that at the end of the lecture, I'm going to talk about how we use inhaled adenosine to potentially prevent the iatrogenesis of us making the lung disease worse. So oxygen, gee, you guys care about oxygen. That's what perfusion's all about, is getting the oxygen to the patient and maintaining the circulation. So oxygen's really important, but too much oxygen kills you. I've given lectures before called oxygen, the vital toxin, and too much oxygen kills you. Just the right amount is good. Too little oxygen, you got hypoxia. But what do we do in COVID? We give patients oxygen because they're so systemically hypoxic. But when we enhance the oxygen delivery into their lungs, we short circuit the release of adenosine, which is the natural release of cells to hypoxia. And in doing so, by giving that oxygen, we make the inflammation worse. We may actually be creating the T cell cytokine explosion because of our own therapeutic desire on utilization of high inspired oxygen concentrations. And once the virus goes into the cell, it comes out of its little lipid membrane, and then it goes to work. It goes to work remanufacturing itself, and it takes over the cell's entire energy production. It steals ATP, and ATP, what's ATP? Adenosine triphosphate. And 40% of the COVID virus genome is adenosine. So we'll get more into that at the end. And adenosine, as I said, has a lot to do with this cytokine storm. I'm working on that. I'll show you some of the cool data of what we're trying to do. So COVID, you don't usually die from the virus. You don't die from the virus. You die from the runaway inflammation triggered by the virus. And you die from the runaway inflammation triggered by the virus, potentially with the overlay of the medical care team trying to take care of you by intubation, by giving more and more oxygen. And that feeds back into the T cell hyperinflation and this cytokine storm. We've been hearing about clotting, and I mean, we can dive into whether or not this Janssen pharmaceutical clot situation is real. We should be worried about it or not. And that's not the same situation as what's going on with the actual COVID patients. But the incidence of thromboembolism with COVID is tremendous. And given long enough period of time in the hospital with you and I caring for patients, every person will become hypercoagulable and a real risk for thrombosis. So the complications go on and on. ARDS, acute respiratory failure, kidney injury, septic shock, DIC. Jonathan Waters was just talking about DIC. We'll talk about DIC a little bit. DIC is poorly understood by most of us, poorly characterized, and a continuum of disease heading into disaster. But neurologic systems, strokes, a chronic neuritis goes on, and myocarditis. I happen to have been one of the physicians that cared for the basketball player who had the cardiac arrest in the NCAA game. severe myocarditis from COVID. Had COVID 2 weeks before, severe myocarditis. How do you get myocarditis? How do you get severe, long-standing neurologic defects if the virus is only in the lungs? The virus has to get to these other organs. So, for somebody who says, the virus doesn't go by the blood, well, wait a minute. Does it or doesn't it? It's in the breast milk. There are many reports of, lactating women who've just gone through childbirth, and the fetus comes out and is born with COVID. There are case reports now about whether those children do fine or not. They appear to be. They appear to not get the pneumonia that some of us old farts like me are likely to get. But they have been born with COVID virus. And it's in the breast milk and it's in the myocardium. And so how does it get there if it doesn't go through the bloodstream? It isn't just magic, so it's got to get there somehow. And what fascinates me is that if you go to the literature from the Far East, particularly the Chinese and the Koreans and now the Japanese are testing their blood supply. And they're finding COVID virus. They're finding COVID virus in their blood supply. Here are 4 patients out of 1,000. So they tested 1,000 donors. And these were asymptomatic donors in Wuhan. Okay, so Wuhan, we're all focused on Wuhan as being the epicenter, but these people were asymptomatic. Asymptomatic blood donors, 4 out of 1,000 tested positive for the messenger RNA virus in the bloodstream. And when I've talked to American blood bankers, they say, yeah, it's just the messenger RNA. We don't know if the virus is actually capable of replicating. And yeah, it's just the RNA. It's not the full virus. How do you know that? If your test is only to find this PCR sequence, how do you know whether it replicates or not? You want to take that chance? Well, in Korea, they actually have a case where it was positive in the blood, came from the donor, and actually caused symptoms and led to COVID infection in a patient who got the blood transfusion. Now, if you gave blood in the United States and it had COVID in it, how would you know? You'd have no idea. And if your patient came down with COVID, was in the hospital, let's say had heart surgery, you gave blood on the bypass machine, 5 days later they came down with COVID, what would you blame it on? Everything else in the hospital, some other exposure, some respiratory exposure, an exposure from either somebody who was visiting or from some of the healthcare workers. Nobody in the United States would blame or look for it in the blood supply. So we have not the foggiest idea either what we're doing or whether it's even possible. Yeah, it's possible. I mean, I just showed you it's possible. It's reported, it's out there. But the US blood banking system refuses to look for it. They refuse to look for it. So there's Europeans, the Europeans have said, well, we're actually worried about it, but we wish not to spend the money to do a PCR on every donor bit of blood that's drawn. And so we're just going to have you self-report. And if you've either had COVID or symptoms, 21 days until you can donate blood. Okay, that's one approach. But, self-discriminating or self-keeping you from donating may not be all that effective. And there so far are no US recommendations that I'm aware of, other than they ask you when you donate blood, have you had a fever, have you been sick? Obviously, they take your temperatures. But the US statement says you cannot get COVID from a blood transfusion because this is a respiratory virus. Because this is a respiratory virus, you cannot transmit it through the blood. But wait a minute, we just said that you can get myocarditis and you can get neurologic defects, and you can get it into the breast milk. So it goes through the bloodstream once you have the virus. And the classic one that I've been told to my face is this didn't happen with SARS, therefore it can't happen with COVID-19. Okay, was there ever a SARS patient who donated blood? No. Was there ever asymptomatic SARS? No, we got 40% of COVID-19 patients are asymptomatic carriers that nobody knows about. And China has already shown that you can donate that in the blood. So shouldn't we at least study it and know something about it? So there were only 35,000 confirmed SARS cases in the United States. And as I said, nobody was asymptomatic and nobody donated blood. That's not a very good argument for me that we shouldn't try to find out whether or not that actually works. So what did the US do in February, March, April, when things were exploding, even into June and July, when things were exploding in 2020, and we were all closing everything down and circling the wagons around our hospitals, and the blood supply in the United States crashed. I'm going to show you that in a couple of minutes. And who did we get to donate blood? Healthcare workers. Well, yeah, we donate blood a lot of the time anyways, because we're great altruistic people. But who was the highest risk group in the United States for coming down with COVID? Us. And who was the highest risk for being potentially asymptomatic carriers? Us. So, is this the brightest thing we could have done? Who's to know? But if you don't test and all you do is say a self-deferral for temperature and stuff, could there have been some contamination? So we really need to learn from history. And the history, unfortunately, with blood banking is not really spectacular in terms of fighting viruses. Every lecture I've ever been to by a blood banker says, one of the biggest risks is viruses. Okay, good. We know that, AIDS, hepatitis. But they always say, well, the biggest risk is the next emerging virus that we don't know about. Okay, now we've got an emerging virus we've just found out about, but now we're unwilling to go and look for it. They don't have a stellar history in terms of AIDS. For a number of years with the AIDS crisis, the blood banks worldwide told us that it couldn't be transmitted by blood transfusion. Of course, right now we know that's absolutely not true. And when it was traced in France to the utilization of factor VIII concentrates, it led to 20-some blood bankers in France being actually jailed for 20-year terms because of their failure to be willing to admit to, detect, and follow it. So let's go, and the same thing goes on for Zika and West Nile virus. So between January and June of 2020, there was a 70 to 85% drop in blood supply in the United States. Imagine what happens to your hospital if all of a sudden you are in a crisis where there's no blood. And I would imagine most of us during that time had notifications from our blood banks that said, hey, we're really short on blood today. Hey, we're really in trouble. There were 5,000 in March alone in the United States, 5,000 blood donation drives were suddenly canceled, eliminated, just plain didn't happen. Now, I can tell you that in the United States today, on any given day, we use between 30 to 40,000 units of blood. We have a 3-day supply. So that means the total available supply in the United States today, on Friday, the 16th, is about 150,000 units at best. That's the entire United States supply of blood in the United States. And if we lose donations like that, the well dries up very quickly. But here's the thing, that essentially all elective surgeries in the United States were canceled for a number of months, 3 to 4 months, and demand for blood dropped 40 to 60%, supply dropped 85%, but demand dropped 60%. But it was predicted in 2018 by the FDA that this would happen when a pandemic occurred. It was actually predicted. They did the study, and in doing the study and predicting it and putting it out there, and it's in the academic literature, I'll show it to you in a moment, nobody did anything about that. Nobody did any advanced planning, either in the blood banking community or in Homeland Security or in emergency management. And I, at the time, as it was happening, as I was reading these papers and was so astounded, I spoke to a couple of congressmen about it and said, what are we doing about this? And they were incensed, but gee, you know, looking at all your wonderful faces, it will not astound any one of you to know that things don't move fast in Washington, D.C. And frankly, nothing got done then and nothing got done now. And so I was at one point asked to write an editorial about some things having to do with blood substitutes. I wrote the editorial and called it "When Blood Is Not an Option, Medicine on the Brink. We cannot allow this to happen." But it was rejected because it was quote unquote too strong. It was too much in the face of everybody saying, hey, wait a minute, we're sitting on the edge of a precipice and we need to do something. That article was focused on the need for a blood substitute, an oxygen therapeutic. And you all know that I've spent a big part of my career working on that. And maybe it sounds self-serving that this is now a call for why we need a blood substitute. But get this, when the pandemic hit, we came this close to not having any blood available in the United States. What happens when we don't have any blood available in the United States? Can you do heart surgery? Can we take care of trauma? What happens to the lady who has that postpartum bleed? We're back in Africa. We're back in sub-Saharan Africa where you got nothing and you live or die. And that's where we were, and we have been sitting on the edge. And we're one next pandemic, we're one next explosion away from that happening at every given time. And so these are the studies that I bring up and I talk about. So the United States lives by a FedEx, UPS, DHL, just-in-time blood delivery. And I mean that literally and figuratively. In other words, we harvest from the supply, it gets put into a warehouse, that's your blood bank, comes out of there, and you know, the movement through that system as a system is great, as long as the system is never broken, as long as there's never a glitch in the system. And on 9/11, there was a glitch in the system. Yeah, the planes hit the towers and they hit the Pentagon and the nation shut down. We didn't use any blood to take care of any casualties because everybody was dead. But all of a sudden, and for the next 5 days, FedEx didn't fly. And there was a national blood shortage because there are 11 centers that do AIDS and hepatitis testing in the United States. There's like hundreds of blood centers, 750 some blood centers that collect blood, but they're all dependent upon the 11 centers to process that blood, and it has to be sent by FedEx, UPS, DHL to get to those places to be tested. And if you can't fly there, you can't get it, and all of that blood can't be tested and can't be used. So blood supply in the United States is based on a regional pattern of supporting blood centers that help and support each other and move blood around. And you can see that, the relative percentage of blood in these 4 different regions of the United States. So there were simulations. This was actually a simulation, interregional blood supply simulation to evaluate blood availability and support planning for emergency preparedness. And the idea is that if there's an event that happens, say in the West, that there can be backfeeding by by FedEx, et cetera, UPS, from the Midwest or the South. We can flood in blood supply from elsewhere in the United States if we need to flood into the center where the problems have existed. But what happens if it's a nationwide event? What happens if it's a nationwide event and it all happens suddenly? Or what happens if it happens slowly, indolently? So in this quote unquote silicon research, in other words, that's a computer modeled research, the FDA and the NIH took this model and said, what happens to the US blood supply and the movement of blood around if we have a pandemic? And let's model that pandemic on H1N1 flu that we just went through. And let's make certain assumptions. And from those certain assumptions, let's see what tumbles out to the fragility of the US blood supply. And, remember after 2008, when the financial crisis hit, they gave these tests to banks, the New York banks, to see how fragile US banking system was. This is the exact same test. How fragile is the US blood banking system? So they did it with two tests. One is a pandemic test, and the other one is one that would scare the crap out of any one of us. The detonation of a thermonuclear device, 20 kiloton thermonuclear device goes off in a US city. What happens to that? Which is worse? Which is worse, the pandemic or the explosion of a nuclear device in a major US city? I'm going to tell you, the pandemic is worse. So we're living through the worst of predicted events. And, right now the blood supply is okay because of a number of, frankly, just lucky things that have occurred. Not because of any great planning, but because of some lucky things that have occurred. So in their model, and I encourage anybody who really thinks this is cool, is read this paper. In their model, they modeled a pandemic lasting 13 to 20 weeks. That's pretty funny, isn't it, right now? Wouldn't we have loved the COVID pandemic to only be 13 to 20 weeks? We can't see the end in sight yet. We're celebrating that, we're all getting vaccinated, but are we really at the end of the pandemic? So they saw a 5% drop per week of blood supply in the United States. And they modeled about what that would do over these number of weeks, and then a 7% increase as they came out of the pandemic. And they modeled it, and what did they find? That over the duration of the pandemic, the 13 to 20 weeks, there would be a deficit of 550,000 units of blood in the United States. 550,000 units of blood in the United States. Now, remember, in the United States right now, we use about 13 to 15 million units of blood annually. And so one of the perhaps things that they didn't model into this was that surgery was going to cut and demand was going to cut. And because nobody's traveling on the roadways, trauma drops like 80%. And that's all of some of the things that we actually saw in reality. So they modeled it and came up with a 500,000 drop. Now here's what happens when a thermonuclear event happens in a major US city and they blow off a bomb, is that, lots of people die immediately. They get incinerated. They're now just atoms scattered to the wind. But the further out you are from the center of the disaster, the more severely injured you are, the closer in you are. And some people have burns, and all of us know that burns require large amounts of blood for care. And then there's people who will have secondary effects of radiation who need to go into the hospital, and miserable, horrible things. But the demand for blood out of that is in the several 100,000 units of blood, but it's isolated. And it could be backfilled from the rest of the country. And so the explosion of a nuclear device, say in Los Angeles or New York or something, is far less destructive than a constant pandemic. And so it's just fascinating to read this and say, okay, we knew about that. Why didn't somebody take that signal and say, we could be in a in a national shortage situation here, and they didn't. They just published a paper. Nobody did anything structurally to the blood banking system. And so there were inter-regional flow and dips and replenishments, and all these models came about. And so what we have seen is that we, at least at my hospital and in the state of Florida, we dipped into the red zones where we had, 10 or 20 units of red cells. In the University of Florida hospital, a hospital of 1,400 and some beds, we had 20 units of red cells on some given days. We were at 0 platelets many, many days. And there was all kinds of demand. And, who went and answered the demand was you and I, the healthcare workers, the workers who had the highest risk. And ostriches stuck their necks in the sand and said, well, we really don't want to know whether that can carry virus or not. Israel has a 15 to 30 day supply of blood stockpiled for mass casualties for their entire population. Who lives with war all the time? Israel. Britain has a 10 to 15 day supply stockpiled for mass casualties. They went through the Northern Ireland bombing situation, and they've been used to terrorist bombings through that, and they've built up their supply. U.S. supply is very tenuous. We sit on a 3-day supply. And there still today is no path forward for a blood substitute through the FDA. And in the last year, I've talked to multiple people in the FDA by phone, as well as congressmen, and they simply can't wrap their head around the fact that if we run out of blood, we've got nothing. And they just can't wrap their head around it. Going back, as I said, we don't have a very good record on what we do with viruses. West Nile virus, I remember West Nile virus in 2003 and 2004. It was raging. It was raging in the Midwest, largely along the Mississippi, the mosquito belt. Mosquito belt was where West Nile was. Now, West Nile virus is clearly contracted and is spread by blood spread. So the mosquito bites you, feeds on the blood, bites the next person, injects a little blood, bingo, you got the West Nile virus. But blood bankers refuse to look for West Nile virus, said it can't get into the blood supply. It's not a problem. We won't have it as a problem. And they refused to look for it. Eventually they did look for it. Eventually they made a PCR test, just like they do for AIDS and hepatitis. And what actually happened was that the national infectivity of reported cases of West Nile virus, as soon as the blood bank started to eliminate it from the blood bank, dropped by 60% the following year. So how much were the mosquitoes doing it and how much were we spreading it? Nobody knows, and nobody's still willing to even understand and look for it. So West Nile should be instructive to us that if you look for it, you might find it. And if you eliminate it, you might take care of a problem. So it ought to be instructive for us. But so using less blood, to me today, is extremely important for all of the reasons. One, we still have shortages of supply. It's certainly not a place to turn on the tap. Well, let me go back to West Nile for 1 second. In 2004, the FDA sent a notice to every physician in the United States, came as a letter. Was it CDC? I think it was CDC, not FDA. I remember getting the letter in my mailbox, and it said, we need to inform you that the United States blood supply is infected with West Nile virus. And in certain places in the United States, the chance of contracting West Nile virus is 1 in 400 units. Do not transfuse your patients unless it's medically life and death necessary. You know what happened to blood utilization in the United States during that period of time? Nothing. The physicians did not change the transfusion behavior, even with the CDC saying, Here we are in a life and death crisis and physicians still transfused. Here we are in a similar situation and patient blood management was never more needed. This is a call article that just came out. Harry Shander and a whole bunch of us signed on board to it to say, wake up, America. Wake up and do patient blood management at your medical center. There are still only 8 medical centers in the entire United States who are patient blood management certified to be certified centers by the Joint Commission. Many of us do bits and pieces of it, but to be a fully certified center, it needs a lot more. And the World Health Organization said that this is vitally important. Not only that, in the face of COVID, but overall, the World Health Organization has demanded that hospitals worldwide get involved with patient blood management. So let me go on with a few more things about treatment for COVID. The world has responded with vaccines, thank goodness. I breathe easier, I walk around easier. I actually get together with some friends right now without a mask, as long as we're all vaccinated. Isn't that a wonderful thing? There's hope for us in our future. And some treatments are working, maybe partially. The death rate has dropped, but not dramatically. I mean, when we first started out, the death rate was about 2.5% to 3% overall in good hospitals in major Western countries. The death rate right now is about 0.8% to 1.2%. So have we dramatically fixed everything with the treatments we've got? Remdesivir, convalescent plasma we'll talk about, but we fundamentally globally need a way to treat this, and we don't have it yet. There's a group of us studying the fact that in the United States, 94.6% of all proposed randomized trials for treatments for COVID are languishing and not being supported for trials. The ones that are going forward are being supported by major pharmaceutical houses, big money, big pharmacy, and many interesting ones that make all the scientific basis are just not going forward at all. So let's talk about convalescent plasma. I'm not going to touch on hydroxychloroquine. That's not a place I wish to go today. But let's talk about convalescent plasma. That has something to do with blood. It has something to do with blood banking. And it got a big splash that, and it actually got FDA emergency approval for utilization of convalescent plasma. Well, it's not a new idea. This was around in 2015 and before, that if you have a runaway viral infection, perhaps you could take the plasma from those patients who've survived the runaway infection, harvest them if they have high titers for antibodies, and use that plasma into somebody who is now infected. Okay, that makes a great story, but think about it. You're going to take 1 unit of plasma, 250 cc's, 220 cc's, and put it into Ty Walker and expect Ty Walker to suddenly get better because he got, because he got 5% or 4% of his total circulating blood volume and he got a few extra antibodies. And this comes out of the H1N1 flu and SARS, and it was trialed in SARS in a few limited studies. And they were very limited, they were biased, they were profoundly biased, and they weren't well controlled, but they did show a decrease in mortality. But if you're going to use convalescent plasma in those situations, it had to be early in the disease. So when COVID came around, everybody wanted convalescent plasma whenever and however and how badly ill you were. And I'll put it to you that if you're on a ventilator or you're going on to ECMO, the time for convalescent plasma has long since passed. And nobody knows about dosing, redosing, how much to give. And let me tell you, this well isn't very deep. In other words, the amount of convalescent plasma that we can harvest from the American public is not very much, and it's not a very useful therapy. So it's now, and this is work that was just recently published in the New England Journal, says that if it's going to be effective at all, it has to be utilized in first contact, first cases early on when the virus is just beginning to infect the patient. And that makes the sense that if you're going to target with an antibody to kill the virus, it needs to be upfront early on when the virus is just coming around, not later in the disease. So, think about the ethics, think about who gets this. It's a scarce resource and it's costly. It's thousands of dollars as a scarce resource to get it from your blood bank. And so, this again, early use, 250 cc of high titer plasma. And I don't really know how high a titer is a high titer to make it effective or not, but it's got to be early in the disease, not later in the disease. And it's not something that we can do for everybody. What have we got? How many millions of cases have we got in this country? How many hundreds of thousands of people are dead? And how much convalescent plasma has been utilized? Not more than tens of thousands of units. So it's not a utilizable technique. And what about ECMO? Okay, ECMO, again, a blood situation, a situation for you guys, something that affects your lives. I don't know how many of you here on today's call have put patients on ECMO with COVID, but I suspect you have. I have been involved with 4 lung transplants where the patient came into the operating room on ECMO, being kept alive by ECMO as a bridge to transplantation. We're the center that has done the largest number of post-COVID lung transplants in the world. And ECMO is our bridge to lung transplantation. And some people are on ECMO 6 to 8 weeks awaiting a lung transplant. And every one of the people I've done, of the 4 I've done, has been younger than 42 years old. So, these are people who were previously healthy, and ECMO kept them alive. But it's a very expensive treatment. It's very complex, and it's got tons of issues. Gee, how difficult is it to run ECMO when a patient's becoming ever more hypercoagulable? Does that make your life more difficult? Okay, so, and ECMO, there are only about 400 or some centers around the entire world that even have the capability of ECMO, let alone large numbers of ECMO. So ECMO is just not really a viable alternative for this disease whatsoever. And again, if you put somebody onto ECMO and it's going to be 6 to 8 weeks until they get a lung transplant, that's one less ECMO machine for somebody else who might need it for post-heart surgery or elsewhere. And, in South Asia, that's all of India, Pakistan, Bangladesh, Thailand, and Africa, there are 18 ECMO machines. What's the population there? So why even really talk about ECMO? So World Health Organization is trying to put some guidelines about when you use it and when you don't, but you damn well ought to have an ethical exit strategy. If you're going to go into a war, how are you going to get out of the war? You need to figure out what you're going to do to get people off of ECMO. Recovery from ECMO is possible, but it's extremely highly unlikely. So unless you tell the family and use it as a bridge to transplantation, I personally think you're fooling everybody and you're doing health service a very large misconduct. And if you're going to cannulate, I think you need to cannulate venous to arterial because the lungs can't support the blood flow. You can't do veno and expect that your cardiac output is going to be maintained normal. So you really do have to do that. And the hypercoagulability is poorly understood. And using daily heparin makes it get worse and worse. So a couple words about COVID hypercoagulability, and then I'll take some questions. It's yet to be fully characterized. Don't forget coagulation is the first part of inflammation. And when inflammation runs wild, it dumps gasoline on the fire of coagulation, and trying to put a fire out by smothering it in gasoline generally doesn't work very well. So it gets worse. And cellular debris, huge amounts of tissue factor, platelets upregulated, cytokines, ischemia, vasculature, adenosine flux, all have effects upon the hypercoagulability. And the hypercoagulability may be partially iatrogenic. Why is that? Because we're giving everybody heparin. And if we give everybody heparin, either low molecular weight or intravenous heparin, to try to prevent, we're actually creating hit antibodies. And there is now work underway that shows that hit antibodies are skyrocketing. And one of the questions is, do the antibodies being created to COVID have an overlay with hit antibodies to begin with? Or is this all iatrogenesis because we're using so much heparin in these patients? It's a situation I don't have the answer to, but the role of the anticoagulation in the COVID-19 world pandemic is fascinating. And it may be that, once again, we're not helping things, we're actually making them worse. And most of us here know who Ted Moore-Kenton is, and obviously he gets on his hit bandwagon, and he's written a wonderful article about it, and I encourage you to read it, to dissect into, which is it, chicken or egg? Which is it, the doctor or the patient that's causing the problem? And yeah, we need to do something, because otherwise these patients appear they're going to get hypercoagulable anyways. But us trying to treat it may get it worse. And over time, if we leave people long enough, they will all become hypercoagulable. And DIC is hypercoagulability run wild over time. In other words, if you produce enough thrombin, over time, you will eventually consume all of your products and you'll go into a DIC situation. So it's just a matter of time. The longer you stay in the ICU, the longer you're on ECMO, the longer you're getting heparin, the longer you're ventilated, the more likely you are to die of one of these disastrous side effects. And given long enough, every one of us will thrombose if we're had COVID and we go into the hospital. There's viscoelastic testing, TEGs, and now Quantras, and the hypercoagulability is profound. I know you guys are pretty good little TEG readers, and if you look down on the left side, look at that outer, the real TEG versus the normal, which is in a dotted line. That's one of the most hypercoagulable TEGs you could ever see, and you're going to see that with COVID patients in the ICUs. Profoundly hypercoagulable. The FDA actually made a call for it, that everybody who's got COVID ought to be followed by TEG and viscoelastic testing. Now, here's the thing, only 30% of hospitals in the United States do any viscoelastic testing for anything. And now the Quantra is being used. I don't know if you know what the Quantra is, but it's a new ultrasonic test to be able to look at coagulation as point of care. There's a bunch of papers coming out on it. It's FDA approved. And in Europe, it's being used in France. This is a case from France, and I'll put it to you on that dashboard on the left. Green is good. Things way over to the right are hypercoagulable. Things way over to the left are hypocoagulable. At least 4 of the readings here on this patient having to do PCS is platelet contribution to clot strength. FCS is fibrinogen concentration to clot strength. Clotting time is up there on above, which is like the R time of a TEG. This patient is severely hypercoagulable, as is this one in the Netherlands. So we're starting to see that this test can be utilized. Now the question comes in, if you see that, then what do? Still, nobody really knows what to do. I think I'm going to go through this 1 or 2 slides and say to you, we at UF, under my leadership, are trying to trial a human trial. We're trying to get a human trial of giving adenosine. Adenosine is the natural cell signaler that is released when hypoxia occurs in your cells. So HIF-1 alpha is a protein ubiquitous to every one of our cells. The 2019 Nobel Prize in Medicine was given to Greg Semenza and 2 other men for their discovery discovery of HIF-1 alpha and the understanding that this iron-based protein senses oxygen at our cells, and when it senses that a cell is hypoxic, it releases adenosine. Adenosine, of course, vasodilates the local vasculature, increases blood flow, but adenosine also is a profound downregulator of T cells and a profound downregulator of platelets. And so what happens when we get somebody who has got COVID? They've got COVID pneumonia. They come to our emergency room, we give them oxygen. And the minute we give them oxygen, we short circuit the body's natural response, which is to turn out adenosine. And the more oxygen we give them, the more we turn off the adenosine. And so the more we turn off the adenosine, the more the killer T cells, which are invading the pneumonia, are upregulated to keep invading. And you have you have collateral damage that these T cells that are invading now see cells that don't have adenosine, and they kill them too. And those are surviving pneumocytes are getting killed. So we're trying a human trial of inhaled adenosine over 5 to 7 days. We've cured 2 people with it. The Italians are seeing a 95% success rate in cure for severe COVID. And I think I'm going to stop there because I can give you a whole nother lecture just on our utilization of adenosine, but it's potentially a future trial for us that we might be able to use to treat our patients. The Italians had 13 or 14 patients who survived with adenosine treatment who would have otherwise died. We've had 2 that have done that. And I think I will just say beyond COVID-19, we need therapies for acute respiratory distress syndrome. Utilization of adenosine, we think in the future will be great for all ARDS, potentially post-heart surgery, post-transfusion, post-sepsis, post-trauma. And so we're looking at it for a long-term utilization. And I'd be glad to take any questions. I'm probably just about out of my time, but I'd be glad to take any questions if you want.
Dr. Spies, I know you aren't necessarily watching the chat, but people are really enjoying your talk for sure. In the chat, they have lots of questions.
Okay, so read me some questions because I'm not watching it.
So the common theme that kind of keeps coming up in a lot of the questions is, why are we not testing the blood supply? Or why do you think the FDA is not interested in looking into this?
So we didn't do it for AIDS. We didn't do it for West Nile virus. We didn't do it for Zika. Why didn't we do it for any of those things? You have to ask the question of, if you're going to put Standard Oil in charge of environmental protection, what kind of environmental protection are you going to get? If you're going to ask the blood bankers about, policing their own industry, and so who does Congress call if they want to know something about the blood supply? They call the American Red Cross. Who responds and says, what's important to the American Red Cross? It's and who sits on the FDA in the oversight groups? They're all blood bankers. So I don't really know. I guess I'm being kind of damning that I think we're just repeating history over and over again, and we're not really doing what we need to do, which is embracing patient blood management and looking with real in-depth view. I am sure that the amount of COVID-19 that's getting into our blood supply may be fairly small, but we ought to know about it. And it would probably cost a lot of money to do PCRs until we get a really, cheap test.
Well, thank you so much. I know that that was really informative, and I appreciate you coming and speaking with us today.
Any other questions? I
We're
know you
going to
guys
try
got
to
them.
move.
Yeah, you need to move on. I know. All righty. Thanks.
Thank you so much. Our next speaker today is going to be Brian White. And Brian has been the ECMO coordinator at Wellstar Regional Medical Center in Marietta, Georgia, since the program's inception in 2016. He is a perfusionist and nurse, and his background as such has led him to make numerous policy changes regarding perfusion billing, protamine dosing post-CPB, and charge reform, which he presented at the Sanibel Symposium in 2017. Today, he's going to be speaking with us about his experience with the Quest MPS console in conjunction with the Keniston blood cardioplegia method at his institution. Welcome, Brian.
Sorry, I should be unmuted now. There we go. Let's see here, making sure I am. Can you see everything okay? Excellent, good deal. So yeah, my name is good. Thank you for the introduction. Thank you everybody for everything you've done. I've really enjoyed it so far. I think there've been some excellent talks. Really enjoyed Dr. Stesis' talk just now. It's certainly something to think about, and I think it's a wonderful transition into what I'm going to talk about here, which has a lot to do with conserving blood, which clearly we need to do. Yeah, it's a little terrifying in a lot of ways, but I promise in the next anywhere from 45 minutes or so, I am not going to mention COVID-19, and I'm not going to mention anything having to do with the pandemic at all. It's going to be a bright, little happier talk when we talk about things perfusionists like to talk about, which is blood conservation and other things like that interest us more. And that has to do largely with cardioplegia today. Utilizing Quest MPS and the KBC method. What is that? Well, I'm going to get to that in just a second. I am at core nurse as well as perfusionist. That's where I started my career. I was a CBICU nurse primarily and ECMO specialist, which led me into perfusion and then led me into the rest of my career as well, and interest specifically in cardioplegia. You might have seen this. Let me make sure. Sorry. You might have seen this talk in the past given by my chief, Candace Palin. She has given this numerous times. It is a passion project of hers. She has been in it since the beginning and was co-creator of this formulation as well. And obviously her passion has revved off on me. When I was first out of school, I started with Wellstar Keniston Regional Medical Center. And this was a fascinating thing to me because I had never run any kind of cardioplegia like this in any of the rotations I did in school. Any of the formulations I was exposed to was never anything as efficient and succinct as this protocol. And it's been, revolutionary in my opinion, in terms of the support of the heart. So I am sponsored today by Quest Medical and acting as a Quest consultant. Just as a disclosure, this is my home away from home, which is many days, many more hours than actually being at home, as we all can, I'm sure, relate. Wellstar Keniston Regional Medical Center is in Marietta, Georgia, which is about 12 miles northwest of the center of Atlanta itself. So we'll talk about background behind KBC, the method itself, as well as communication, which is integral in this as well. So we'll talk about the motivation. Where did the motivation come to actually revamp the way, the way we give the cardioplegia? Obviously, there has been a long history of cardioplegia formulations, hundreds and hundreds at one point in time, which can obviously get super confusing, and it's why we do not have anywhere near that number at this point available. It was too much at that point. We wanted to find a better way to arrest the heart, preserve it, without causing any future damage, essentially, to the patient or myocardium. And with the KBC method, I believe we've achieved that, and we'll certainly cover our process and methodology as well. With communication, it is an absolute key, not just in cardioplegia, but obviously in cardiac surgery itself. But specifically, as you'll see in this protocol, it is key to assessing the patient itself and making sure that what we've delivered is adequate specifically for that exact patient. And that's part of the customization that we can offer through this as well. So we looked at Del Nido's primarily for guidelines. So Del Nido has been, I compared a lot to KBC, I think, in the past. And what we want to draw here is, in conclusion, is that it's not micro Del Nido, which some people refer to it as well. It's not, there are comparisons between the two, but it's very different in how it acts and the purpose of it. As we know, Del Nido is a pediatric primarily solution that was developed in the 90s. 1 part of blood, 4 parts crystalloid, potassium, bicarb, lidocaine, obviously for sustained arrest, magnesium, and mannitol. So first and foremost, when we were developing KBC, we wanted to get rid of the crystalloid. How do you do that? Well, you have to have a carrier. There's got to be some kind of carrier to give the blood itself. So enter, and we'll talk more about the MPS in just a second, enter the MPS to facilitate that in the form of microplegia. If we use a patient's blood itself as the carrier, then we eliminate the need for buffer in the form of sodium bicarb, which is also a little bit more contributing to crystalloid as well. We keep our lidocaine, obviously, for sustained arrest, and that tends to be a bit of a superstar in the form of a fast-acting sodium channel blocker for that long sustained arrest, adequate to give us the comfort that we have here. Obviously, magnesium as a natural calcium channel blocker, and mannitol, free radical scavenger, yes, but I really enjoy, and we'll see it in a slide in a second, given that it is the osmotic diuretic that it is, it can, reduce or elevate your blood plasma osmolality, pull a lot of fluid out of that tissue, and prevent that myocardial edema that can occur and can cause problems with the heart. So in our KBC solution itself, like I said before, it is simple. Simple is the absolute key here. It is an all blood formulation, referred to as microplegia as well. Potassium for arrest agent, obviously, we don't need a buffer. That is the key here. You use the patient's own blood as a buffer, which, again, going back to Dr. Spies's talk a few minutes ago, if you don't have to give extra crystalloid, an extra addition to the patient's circulating volume, and you use the patient's own blood, isn't that the best thing we could possibly use? It's both adds to conservation, adds to a whole host of things I won't even get into here, but it's super beneficial. Then our lidocaine, magnesium, and mannitol, and obviously lidocaine being superstar here, providing for that long arrest. So this is what I was talking about a little earlier with the interstitial edema. It's a bit of an older slide, but it still rings very, very true to me. I've given 4-to-1 blood before, did it multiple rotations in school. Nothing wrong with it at all. Certainly provides cardiac support, arrest, and preservation. But an issue that has been, as long as 4-to-1 has been around, is it can cause some interstitial edema. And specifically in the myocardium, we see that can reduce contractility. So enter your microplegia, especially in the form of KBC, you reduce a lot of that myocardial edema and increase your contractility. And then what happens after the cross-clamp comes off, obviously with some more things I'm going to talk about in a second, better contractility, less fibrillation, VTAC, and just a better cardiac outcome altogether. So we do this through our additive as well as potassium. As you might have guessed by now, KBC, if you didn't know already, stands for Keystone Blood Cardioplegia. And I'd be remiss if I didn't mention some of the presentations yesterday were excellent. I love seeing the cardioplegia talks, I think the neonate talk, as well as the cardioplegia talk with the different formulations were wonderful. I was taken aback when I can't remember the gentleman's name, the physician's name, wasn't aware of our KBC protocol. And I thought, wow, clearly we need to do more of these talks, spread it out more, make sure everybody's aware of this protocol. We love it. And it's quickly gaining speed. And I'll speak to that in just a second with the widespread usage of it. But with Keystone Blood Cardioplegia in our additive, we do use, again, mannitol, mag, lidocaine primarily. It is comprised of, and used to be 20%. We'll talk about that in just a second, but 20% mannitol, 30% mag, 2% lidocaine in a formulation that adds up to about 53 cc's of volume itself in a 60 cc syringe. It is prepared in-house by our pharmacy, pre-prepared syringes that do have a 7-day expiration and are refrigerated. You might ask yourself, that's a little odd because separately, none of those drugs have to be refrigerated. We refrigerate them primarily out of an abundance for caution. The additive of the drugs placed all together haven't been sufficiently studied over time to show interactions that can happen. So by refrigerating, we prevent, again, with an abundance of caution, any issues that could arise. So what happened? Use a little bit of difference here, if you guys might notice. A little while back, and I'd say this happened, I think it was around 6 months or so, the hospital changed, as many things changed with, I won't mention what occurred 6 months ago. I promised I wouldn't mention anything, but supply chains changed. Our 60 cc syringes that we had loved for so long changed to 50 cc syringes. The Pharmacy could not, unfortunately, accommodate filling a 53 cc syringe in a 50 cc syringe, so we had to adapt. Another thing that's wonderful about this protocol is it's extremely adaptable. We figured out all we needed to do is change our 20% mannitol to 25%. It delivers the same amount of drug, same exact, we didn't change magnesium or lidocaine, same drug that's given now in 46.6 cc's of blood, or 46.6 cc's of crystalloid in syringe. So very easily adaptable, not an issue. You know, it to me, it speaks to the adaptability of the protocol itself. So as an average, each case, we were giving about 51 cc's of actual crystalloid additive per surgery itself in cardioplegia form. I suspect it's just a tad bit less now, considering this slightly more concentrated version of it, but it would only be a few cc's less, but less per case. But even so, if we break that 50 cc mark, I think that's pretty impressive per case. That plus the potassium is pretty, it's, in my opinion, pretty impressive to be the only crystalloid that's given for the entire case. Let's see here. So enter the MPS. This is what facilitates our entire ability to do this. The MPS obviously can do a lot more. If you know, hopefully we'll be transitioning to the MPS 3 soon, but I'm not going to get into that. It's an amazing system. So is the MPS 2 as well. We customize everything in cardiac surgery, as everyone is well aware. We customize everything from the surgery itself to process, to the supplies, to everything else. So why not customize the actual cardioplegia we give specifically to the patient? And using KBC protocol along with the MPS provides that ability. It can provide any customization essentially for any cardioplegia formula virtually that you can think of, which is great if you are on a, excuse me, my computer there. If you're on a large cardiac team with multiple surgeons, perhaps some that are not interested in giving microplegia, I can't imagine why. But if they do, if they aren't, that is perfectly fine. You can customize it. You can get anything from your standard 401 to microplegia to anything in between. And it's also great for your redosing, which we'll get into here in a little bit as well. So with the MPS, we have two pockets. One that is primarily filled with our additive that we spoke about before, our Lidomag and mannitol. The other pocket that is filled with our arrest agent. It's always a 2 milliequivalent per milliliter arrest concentration. With our ratio control, this is what I was talking about earlier. You are able to, here you see a setting of all blood, which is what we give, obviously, as a carrier, but it's able to do anything from all blood to all crystalloid. And any ratio in between, which is another reason it provides such an amazing customization. And this functionality will maintain true throughout the MPS 3 as well. So in terms of methodology, what we wanted to really get into is how do we protect the adult heart? We have to change our formula. And obviously with Del Nido as kind of a guideline, we wanted to compare the pediatric heart to the actual adult heart as well. Del Nido is using a 1-to-4 ratio. We're going to use an all blood carrier ratio here. Del Nido's is primarily a single dose. We're going to take a 3-step methodology here in an induction dose, a dosing reassessment, and then a reanimation dose as well. So with that strategy in place, we always do in the reanimation dose, recommend that this is given in warm form as well. So with the induction dose, it is weight-based, 15 cc's per kilogram, which is pretty much the industry standard as well, adjusted for body weight. Based on our protocol, we do give a minimum of 1 liter and a maximum of 1.5 liters, and this is for any patient. So regardless of their weight, they will at the very least get a liter, and regardless of their weight, at the very most, 1.5. This is delivered cold with an arrest setting of 21 milliequivalents per liter and an additive setting with our new slightly more concentrated additive syringe of 18 cc's per liter as well. So the actual drug that is delivered in 1 liter of the cardioplegia that we give, obviously with blood as the carrier, is roughly about 2.5 grams of mannitol, 1.6 grams of mag sulfate, and 100 milligrams of lidocaine, in addition to the 21 milliequivalents of potassium that's given in that 1 liter. Obviously, it varies a bit if you give 1.5, but it's pretty easy to extrapolate the math from there. The thing to keep in mind, and a lot of questions that we get, and I welcome all the questions as soon as this is over, is What about lidocaine toxicity? Obviously, it's something you have to keep in mind. Lidocaine's metabolized fairly quickly through the liver, so hepatic function is something you keep in the back of your mind as well. But in terms of the actual toxicity, it's a little more difficult to get to a lidocaine toxicity than people think. If you look at the ACLS algorithm, the max lidocaine dose for during ACLS is actually 300 milligrams. So based on our KBC protocol itself, it wouldn't really even apply unless something has gone horribly awry, which hopefully not. Wouldn't even apply to get to any point that you have given 300 milligrams of lidocaine. And then, even if you did, for some strange reason, I've never been in a situation this would occur, need to actually give excessive amounts of the additive. Typically, enough time has elapsed at this point that you've metabolized this out of your system, so it's no longer an issue. Really, what I'm just trying to reiterate here is that there are a lot of fail-safes that are set up to provide that you can't to provide not reaching a toxic level of lidocaine. Again, in my years doing this, I've never seen it, and certainly with Candace as well. Ever since she started this protocol, it's not been an issue for us as well. So with our methodology, obviously it is a single dosing and long arresting formulation. Long arresting, I think, is the more important thing here. It provides, not just to make the job easier for the perfusionist and the surgeon, but it's a better, more efficient and less repetitive method of actually supporting the heart. Not that there's anything wrong with redosing every 20 minutes or so, but if we have a better way of doing it and a more efficient way of doing it with a single dose that can provide at least an hour of acquiescence, if not longer, then obviously, especially using an all carrier of blood, obviously that would be the more advantageous avenue to go on. It also provides your surgeon, honestly, peace of mind and the confidence to simply just get on with the case, because that's, at the end of the day, that's really what we all want. We want to be able to support the patient, have the surgeon do his or her thing, and we can all get out of there. That's, with the patient doing well, and that's really the key. I can tell you in my experience with it, even in my, my 5.5 years now as a perfusionist, it's exceptionally rare that redosing is needed. If all else is well, if the cross clamps place well, everything else is normal. Typically that single shot is all you need. Unless your cross clamp goes over that 1.5 to 2 hour time period, it's pretty rare to see activity or any issues with it. So in our dosing assessment, that is one of the most important things in KBC, to actually make the assessment and then individualize this actual protocol to everyone. We do an assessment at least every 60 minutes or with any actual EKG activity, which is pretty standard for any perfusionist, regardless of the cardioplegia that you are giving, to assess for EKG, assess for activity. So it's not a change in practice when switching to this methodology. It's simply a change in mindset in terms of time. If we want to give a redose, we evaluate two things. What is the patient's potassium level currently, because that's something that we can adjust in terms of delivery, and what is the estimated remaining cross clamp time. And this is kind of delving into communication a little early, and I'm going to get into this more, but to know at what point of the procedure you're in is exceptionally important here, because we don't want to redose this if you have 15 minutes and the cross clamp's coming off. Obviously, this is a long-acting formulation, and you redose and you have a good arrest for another 45 to 60 minutes, and the cross clamp comes off in 15, you got a problem. So to ask if we need to redose and go through our actual redosing assessment is of the utmost importance. So this is where the MPS honestly is integral, in my opinion. So in terms of a reanimation dose, we always give 400 cc's of warm blood itself, no potassium, and it is a variable additive setting based on our protocol. And I do want to mention as well, I'm going to give my email address at the end. I'm happy to share our institutional protocol with you all. I'm happy to send out an email to whomever would like the protocol itself. It's a great way of getting the information out, sharing, answering questions, and ultimately, if your institution is interested, getting you started with the actual usage of the KBC protocol itself. We always give a warm reanimation dose. We recommend it, obviously, for this protocol itself. It consists of 400 cc's warm blood antigrade at a temp range anywhere from 33 to 36 degrees Celsius. It's variable at its setting because our goal is ultimately not to give too much additional drug itself within that hour of cross-clamp removal time. If we have allowed an hour or more since the last dose or so to wear off, we will give a full dose setting of additive, which currently is if you look in the middle of the screen there, look to the left of the screen there, the additive says 21 milliliters per liter. That is the old concentration. Unfortunately, this hadn't been updated, this particular one. It is now 18 based on our new concentration. And that's just because we had to change it with the syringes. If it has been between that 30 to 60 minute window or so, then we reduce it to 9 milliliters per minute. Again, it's slight change instead of 10 just because of the concentration of the syringe. And then if it has been less than 30 minutes, believe it or not, we have at least one surgeon who is blindingly quick and does do some procedures. It's a good problem to have. Some procedures with less than a 30-minute cross-clamp time, then we do give zero additive straight warm blood since we flush the heart out at that point. So I was saying there. So delving into the world of communication, and I do want to touch on one thing before I move on. It's somewhat of an anecdotal piece of information. However, I think it's a little stronger than anecdotal just because of my experience, my colleagues' experiences, that has been a lot longer than myself. But based on this protocol with the warm reanimation dose, it's exceptionally rare at our institution and many of the institutions that institute KBC that we see any VF or VTAC after cross-clamp removal. And I strongly believe it's because of the microplegia and the additive drug and the way that we give it that prevents this irritation of the heart. And again, I think lidocaine is the superstar here. We usually see a brief period of sinus brady and then return to normal sinus. It's almost like that slow waking in the myocardium as opposed to the myocardium, it's like an alarm clock going off versus gentle birds singing on a spring morning. So communication, again, delving into that, incredibly important. Obviously, in any way, shape, or form in the OR, but specifically with KBC, as you need to make sure that you're constantly assessing the time, where you're at in the surgery and when that cross clamp is coming off. We've all been a part of confusion at some point or time in the OR, whether small, large, or in between, whether it's a process or procedure misstep or just the surgeon mumbling into the chest. Just kidding, really. So honestly, it's ironic. It reminds me of a story. I was in a band in college, so my hearing still pretty decent, but not quite as sharp as it once was. And we, had a surgeon at one point that would, he spoke fairly well, but he would look down at the chest, as many do when they talk. And I had trouble hearing him. And at one point, he just turned around and kind of looked at me during the procedure and said, "Do we need to get headsets?" And I kind of looked at him and said, "Actually, that wouldn't be a bad idea. I think I kind of like a radio headset to communicate. I think it would be fun." We did actually talk about that briefly, about doing that, but we never did. He was much more cognizant of both myself and a lot of and the rest of my colleagues, to, especially when it was something important, either turning up a vent or getting ready to run cardioplegia or reanimation, to make sure that he was not speaking down into the chest, that he was speaking clearly out and we could actually hear him. So again, it just that communication during and after the case improved it for everyone and the patient outcome as well, I believe. As perfusionists, obviously communication is part of our job. We provide the information first and foremost. Any noted EKG activity, what is your patient's potassium level? And in this case, we'll let the surgeon know if it's above 5.5, and we can modify our delivery of potassium in any subsequent doses as well. We also need to keep track of the last time since our last dose of cardioplegia, in addition to whether or not there's any EKG activity. Part of our protocol at an hour, if we are assessing for redose and we are still silent in a systolic, no issues at all, then the surgeon will proceed. We won't necessarily give another dose, and I'll go into that about comfort zones in just a second. We also help specifically to guide this additive in a rest setting in terms of assessing for redose as well, and the reanimation dose as well. We also have to ask the right questions. I think that's one of the most important things during a procedure, is not only to ask the questions, but ask the right ones, especially the ones that don't give you a glare from the surgeon or the first assistant, which we've all been there. Where are we in the procedure? I think that's incredibly important. I know there are a lot of institutions, I hope the majority of institutions, but you never know, that have camera access at this point. We do have camera access. It's incredibly integral in knowing exactly where the surgeon is, knowing the technique, knowing where you need to be before you even have to be there. You can still do it without. Many of my rotations do not have cameras. It teaches you a lot more, to be a lot more cognizant. But I think cameras have evolved the way that we interact with the surgical team, and I think it's a good thing. It's just like technology changing. We also have to confirm adequate distribution of the cardioplegia across the myocardium. And that's usually done first and foremost is, when you're giving your initial dose, how much is in when you see your arrest. That's very important. Something we communicate with the surgeons well. At what point do we see that arrest? That can kind of tell us, do we need a subsequent dose? And what else are we looking for as well? And then obviously, what's your delivery route? Are we going down the route? Are we going down 1 or 2 coronaries? And then very exceptionally rare at our institution do we actually give retrograde. And it's under very different circumstances, but that's different for everybody. So we are asking the right questions and communicating. So I was talking about comfort dosing just a little while ago. Comfort dosing is a real thing. I'm sure we've all experienced it. It takes a surgeon, one bad experience in one certain situation to think, I know there's no activity, I know there's nothing going on here, but I just want to give an extra dose just to make sure everything's happy and warm and fuzzy for everybody. But honestly, just like the picture says, outside of your comfort zone is where this magic actually happens. And that's the whole idea behind KBC, in that you can give a single dose, you can protect, arrest, and preserve the heart well, and it will come back. And I've seen it time after time after time, beautifully come back into sinus rhythm, no issues at all. And the surgeon did the entire procedure without having to redose, without having to even think in the back of their mind, did I provide proper protection for the heart? Am I going to have some ischemia or any other issues with it? And honestly, when you're waiting that full 60 minutes without redosing, if it's not part of your normal protocol and your normal comfort zone, then it's going to take some getting used to. No one at this point, no one on our team has any problem with that, because we've seen how it works. We've seen the adequacy of it as well. But if you're switching to this at a different institution, or you're using it part-time, it can be a little bit, can take a little while to get used to it. Totally normal, and that's perfectly fine. Again, if you're asked, before I move on, if you're asked to give that, comfort dose, go through the steps of the reassessment. Think about your potassium level, your additive, how much you've given, when the last time you've given it, and you can kind of see if it needs to be done, and if it needs to be done, what level you can give it. You can reduce your settings, which again is another wonderful thing about the MPS. So over 8 years now, and it's actually been a little longer than 8 years, and over 6,000 cardiac patients, and again, counting even more than that, we've provided KBC method with resounding success. We have compiled data as well, but at this point, what's difficult through technology, data compilation, and being a single center, we're really more interested in seeing other centers that have used it as well, seeing data from them to see, compare and contrast as well. Because at this point in our program, we don't have an interest in using a different formulation to compare and contrast. I mean, it's been so successful. We wouldn't want to run any kind of double blind or otherwise to compare the actual efficacy, simply because we're so passionate about what we're actually doing with it. It is our desired method for all cardiac patients. We don't stock any other formulation. We don't use any other formulation. It is for all comers. That is everything under the sun, from cabbages, valves, dissections, all sorts of combinations of procedures. And we've had resounding success from it. Again, it was actually interesting. My chief shared with me a few days ago, she got a message from a gentleman named Neo Tali. I hope I'm pronouncing that correctly. He's the director at Cassini Medical in South Africa, and at Charlotte Maxiki Johannesburg Academic Hospital, which is just over 1,000-bed hospital, as well as Groote Schuur Hospital in Cape Town, South Africa. They're instituting a KBC protocol. That is one of the farthest reaching places, I believe, that I've heard, and I think that my chief, Candace Palin, has heard as well, that's utilizing KBC protocol. There are numerous programs across Canada, hundreds of programs across the United States that are now utilizing KBC, which is exciting. I think it is kind of the new wave, the new mindset of how we can dose cardioplegia and move away from some of the methods of the past. Again, we don't use any other type of cardioplegia at Wellstar Kennesaw. excuse me, Wellstar Kennestone at all, and would encourage anyone interested in contacting me for information regarding this. And, I honestly think, the quote is very, very fitting. If you do what you love, you inspire and awaken the heart of others. And you do. And I think that's, it's something that has rubbed off from Candace Kalin, who was one of the originators of this and creators of this formula. To me, to myself, the rest of my team, we're all very passionate about this formulation itself. And I'd love to see it spread. And I think it's one of those career goals. If by the end of your career, this formulation has become, at least if not the new industry standard, a new industry standard with high rates of success, I mean, you can hang your career hat on that, in my opinion. So I'm happy to take any questions. Anybody who's interested at all, throw them at me. I'll answer them to the best of my ability.
Ryan, that was incredible. And I have had the opportunity to be up there with you guys and watch this. To me, it's the most outstanding. I don't think you touched. When I was up there, I think I saw about 40 to 50 patients being done. I don't think y'all cardioverted any of those patients at that point in time. I think they spontaneously, regained their rhythm. And the other thing, I think y'all were mainly, especially for coronaries, you're only giving antegrade. I don't think they were ever giving retrograde. It's just antegrade dose.
That's correct.
I mean, the simplicity of it and being patient specific to me was one of the most incredible cardioplegias I've ever seen. So thank y'all.
It's really what we love about it. Yeah, it's what we love about it, being able to customize every single patient, knowing that you're not necessarily given an identical dose to anyone. It's a wonderful feeling. And it makes you feel, for lack of a better description, makes you feel more useful as the clinician supporting that patient as well, knowing that you get to customize exactly what you're doing and how you're supporting that patient.
Brian, that was an excellent talk. Thank you for joining us and sharing. We have a few questions about the best way to sell and build confidence with this technique with a team that doesn't have any experience. Do you want to talk about how you were able to do that with your staff?
Absolutely. We did have wonderful physician support in starting this. However, in starting any kind of new protocol or program, it takes time. It takes acceptance. At the beginning of this, years ago, and I don't want to quote the incorrect years for this, it was before my time, but I do kind of know the history behind this. Years ago, there was duality in the program. We did use on certain procedures KBC in addition to other cardioplegia formulations, just to make sure we weren't missing something, and then eventually transition to full-time KBC. That is a way of selling it as well, especially if a program already is using the MPS. And I know there are a lot of programs out there that utilize the MPS that do not utilize KBC yet. Perfectly fine. That's another wonderful thing to speak about Quest Medical as well. And they've been an amazing partner with us throughout this entire thing, is that the sales point of the MPS is that you can do any formulation that's comfortable for that surgeon, and perhaps sell it to them by saying, why don't we try on, start with your valves, which are a little less controversial in terms of support. Start with your valves using KBC, see how they do. If you're happy with them over a period of time, then perhaps we can move on to cabbages. We can move on to dissection, any number of things from there. Happy to share any rudimentary data we have. Obviously, my chief, Candace Kalin, wants me to express as well that she is happy to directly speak with any physicians or staff about the protocol. I'm happy to talk with them. I hope our passion rubs off on them. We've even been known in the past to actually make site visits as well, to speak with the perfusionists, to go out to spread this information. I think that's a wonderful support method as well. And it just speaks to the passion that we have about this. And I mean, I really, if nothing else, and I think this kind of makes, makes our whole team kind of smile. When you are at an institution like Wellstar, which, I can't say enough positive things about them, and you're using this sort of formulation, it makes you not really want to go anywhere else. You feel really home in knowing that you are in a place that listens and responds to the information. And I can't tell you, in the years that I've been there, I've been able to affect change. Not only, I think in 2017, I made a presentation here at Sanibel that was about perfusion billing. And it was just kind of on a whim from my nursing background and how we did our acuity-based staff assignment. I changed how we did our acuity-based billing on per service provider, and working with the billing department in our hospital, changed the way we bill for perfusion services to mirror a little more how physicians have done it for years as well. So I mean that, and I actually spoke with Brian Litch a few weeks ago. Something we've been using for a couple of years now, and I'm compiling data on it now. Hopefully, maybe next year or the year after that, depending on when we get to it. I'll present an algorithm that I created that kind of works somewhat similar in the way the HMS from Medtronic that we've been utilizing for a little over 2.5 years now. That is for protamine redosing after surgery. That again, in the light of customization for cardioplegia, is completely customized to the patient themselves. So based on the formulas that we create, it's customized dosing of protamine for these patients, and we've had immense success. It is, like a lot of centers, we used to give that standard protamine dose without, any exception. Everybody gets the same, and now it's completely customized to the patient. I feel like the data is going to show reduced bleeding, more efficient reversal, all sorts of things. But I don't want to get on the sidetrack of what we're talking about here.
Brian, thank you so very much. This was very informational. And your cohorts with Candace and Bill O'Reilly and Debbie White, they've been on the chat answering a lot of our questions so far. So thank them too.
Good.
Also,
good.
And also I do have a good question from Maggie Sousa. She mentioned, can you talk a little bit about the fail-safes to prevent lidocaine toxicity?
Say again about the.
Can you talk a little bit about the fail-safes, or can you prevent lidocaine toxicity?
Sure.
Also,
So
Brian, can you describe lidocaine toxicity to us in your words? Thank you.
Sure, absolutely. So lidocaine toxicity itself, every institution is a little different in what they would actually deem as lidocaine toxicity in terms of the actual titer volumes in the bloodstream. It's a little more difficult to assess directly in cardiac surgery because it requires lab values analysis. It's usually done more in the ICU in terms of somebody who's on a lidocaine drip as an antiarrhythmic. In our situation, the fail-safe itself is the KBC protocol. The way that we give it in its single dose action, long-acting arrest, in and of itself essentially prevents you from giving too much. And the fact that in that 1 liter, you're giving 100 milligrams as an initial arrest, even if you give 1.5 liters at 150 milligrams as an initial arrest, it at full concentration, it will not provide any sort of toxicity, anywhere close to the level that would be a full bloodstream toxicity. Again, spread over the time because your liver is constantly metabolizing, and lidocaine is actually fairly rapidly metabolized in an otherwise healthy liver. Your body is constantly fighting against that toxicity level. And if you look at redosing assessments as well, our additive dose is never as high as the initial dose. So you're reducing the amount of lidocaine that you would give, even if you did need a subsequent dose after an hour, hour and a half, that sort of thing. And then on the reanimation dose, it's also based on how long it's been since you've given that drug. So every single assessment of redosing is done to think about how much drug that you've given. So it's a combination at that point of the lido, mag, and mannitol, but it's all in consideration of when you've given it, how much you've given so far. I would venture a guess, and I'd have to look the exact numbers, to say that it's exceptionally rare that we ever give over 200 milligrams of lidocaine in any surgery, depending on the length of it. I know I've done a couple calculations with lidocaine because early in my career, I was curious about that as well when I first started with them and learned about the protocol. I think for a total arch case we were on bypass for a little over 4 hours, I gave 225 milligrams of lidocaine. And that's, over 4 hours of a pump run where the perfusion was adequate. There was no hepatic issues otherwise. So we had some metabolism going on, as well as hemoconcentration and ultrafiltration. So in terms of that, I mean, when you think about, and, I like to compare it to thinking about lidocaine toxicity to the ACLS algorithm. And this is probably the nurse in me that does this. I love my background as a nurse because I think it's given me a lot of perspective on this. If you look at the ACLS algorithm, the max dose during an ACLS event is, I forget the exact milligrams per kilo, but I think the max dose is somewhere around for 100 kilogram person is 300 milligrams of Lido. and that's to prevent lidocaine toxicity. So lidocaine toxicity at that point happened at a higher dose than that, and it's specifically to treat your VTAC VFib, which, if you think about it, is what we see often after the cross clamp is removed. So in a way, that VFib or VTAC arrest is a form of that cardiogenic shock, whatever has induced it from the cardiac arrest that patient's getting at the time, versus the cardiac shock from bypass and a cross clamp being placed. So it's given much in the same way. I think in terms of lidocaine toxicity, and I've seen it happen to, I've had 1 or 2 patients in my nursing career that had lidocaine toxicity, and it occurred from, a lidocaine drip over a number of days and reduced hepatic function as well. All that long-winded to basically say it would be exceptionally rare, if not virtually impossible, when utilizing the KBC method and redosing assessments to actually reach a state of toxicity.
And what actual symptoms are you talking about to notice?
So sure. So in cardiac surgery, it would be, while on bypass, it would be pretty difficult to actually see any symptoms, but you do get prolonged QRS, definitely prolonged P time, PR time. In the ICU, it's a little more evident when you're on a lidocaine drip. When you get toxicity to some labs, prolonged P time is like is an initial thing. You can get a little bit of hypotension. That's typically from the change in EKG itself. And that's usually what indicates a lab draw to test for lidocaine toxicity. Again, in cardiac surgery, a little more difficult to diagnose directly. But honestly, if you regain normal sinus rhythm when the cross clamp is taken off and the heart begins to function and eject again, that's essentially a given signal right there that there's no issue with lidocaine toxicity in any way, shape, or form. And you do want a high concentration once the clamp is removed. After you've given your warm dose, you want that high concentration of lidocaine in the myocardial tissue to prevent those arrhythmias. And then after time, it is washed out and then metabolized by the body. So if you took a titer right after you came off bypass, you wouldn't be toxic by any way, shape, or form, but you would have a much higher level of lidocaine in your system for a short period of time. But again, that's kind of the idea. You want that to quell any of those VTAC or VFib episodes and prevent any cardioversion needs.
So the use of toxicity, the terminology really has to do almost 100% with the electrical system rather than any other sequelae throughout the body.
Absolutely.
Brian, what is the cost of the KBC versus traditional cardioplegia or anything else that you've used? A lot of people are curious if this is more expensive or if this is a cost savings.
So that is an excellent question. I don't have the exact numbers, but I can tell you I've seen them in the past, and I don't want to misquote. I don't want to guesstimate that, but I can tell you it's definitely less expensive, given the fact that they're separate drugs that are formulated. Traditionally, magnesium, mannitol, and lidocaine are not expensive drugs in and of themselves. They've been around for a long time. They're in generic form. No, there's no issue with that. So when they're combined by your pharmacist and compounded there and sent upstairs, as opposed to having to acquire separate formulations, actually pre-mixed bags from a distributor themselves, there's definitely cost savings. I can get that exact information from you. I guarantee you my chief candidate, Kaylin, has it compiled somewhere. She's got a million different data points on this as well. And perhaps that's something we can add in the future to this presentation as well, to be a little more comprehensive. But there definitely is a cost savings in the fact that it's simply so not to repeat a word, it's more a simplistic formulation itself with only a handful of drugs used to complete it. And honestly, I think it's another one of those things too. In speaking about the MPS, sometimes I've seen centers balk a bit at adopting MPS cardioplegia as well, because the MPS units are might be more expensive than giving traditional cardioplegia. But we have studies that have shown simply in the reduction of blood products, the utilization of KBC and MPS as well, the units themselves pay for themselves. And this is, with our program at the time bought 3 of them, all 3 of them paid for themselves in a single year in reduction of blood product utilization, which I think shows astronomical savings. Again, all these data points I can get from my chief as well. But yeah, overall, the formula is definitely less expensive. And what you're going to save the hospital over time can be extrapolated for years.
Brian, I might have missed this in your talk, but I just wanted to ask, if you vary anything up differently, like on a really long case, like if you've got a 4-5 hour pump run, really long cross clamp time, is there anything that you do differently there, with this particular protocol?
So we've seen cross clamps in excess of 2 hours with single doses. It's not a standard in our protocol to necessarily go that long. We do reassess after every 60 minutes to make sure there's still a silent heart, there's no activity. It does, again, it's about comfort dosing at that point. I have been in situations where we have redosed simply because of the way that a heart arrested. It might have had, a different situation, but at 60 minutes, if your heart is quiet, you don't necessarily need to, and we rarely do. For long cases, and this is to brag on my program, we don't have a lot of long cases. Our surgeons are actually, it's this wonderful thing. Our surgeons are exceptionally fast. Again, with total arches ranging from 3.5 to 4 hours or so. I think the longest pump run I've had in my years there was maybe 4 hours, right around 4 hours, just a little over 4 hours or so. With long cases, again, I would employ the protocol, the method itself, which is reassessing, redosing. You shouldn't need at any point in time, and again, things might change if you're looking into 6, 7, 8 hour pump run, you shouldn't need to give an initial dose setting at any point during the case before cross clamp removal. That single dose initial rest should be enough, and then giving subsequent doses based on how long it's been since you've given your last doses using the protocol should be adequate. Again, it depends on your potassium level, what your potassium setting would be, and it depends on how long it's been since you've given that additive drug as to what that setting would be as well.
So Brian, Debbie has told us online that she knows of no pediatrics that have been where KBC has been used. What's your thought about going ahead in the future with using it on pediatrics, or do you know of cases that have been utilized that maybe Debbie didn't?
I don't know of anything personally. I can certainly, this is a question I'll ask my chief as well, Candace Kalin. Given that there's such comparisons that can be drawn between our protocol and Del Nido itself, which is widely used for pediatrics as well, I think there is definitely a possibility. The only issue you could run into is it's an all blood given, all blood carrier. So volume can be an issue. Obviously, MUF could take care of that after cessation of bypass. But I think it is certainly something that could be given for pediatrics. It could lend itself quite easily for pediatrics, especially with the length of their cases that are often quite long. I think it's a modifiable protocol, and it could definitely be an option. But I don't know of anything specifically that's being used for pediatrics at this point.
Brian, thank you so much for coming and speaking with us today. And I know everyone really enjoyed your talk from looking at the chat. I think we're going to take a 10-minute break here, and then we will be back with our next speaker.
Excellent. Thank you very much.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invo 7100 system provides innovative, next-generation improvements over the Invo's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The Invo system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes.
We're on now, Brian? Okay. Welcome back, everybody. Sorry we're just a few minutes late, but we're getting going now on a beautiful talk coming up that I think all of you will be very interested in. As I often say, keynote speakers are that extra spice added to a scientific meeting to offer something different in improving our knowledge and our lives. I think we can all agree that this past year has been one of extraordinary change with incredible challenges, with each of us experiencing the pandemic in an individualistic way. Combining these life pressures to our already stressful profession can have lasting effects on our lives and for those around us that we love. I have asked my beautiful friend Candace, with her vast experiences, to speak with us on identifying the effects of this past year and possibly identifying coping mechanisms in our lives moving forward. Candace is a graduate of New York University and an International Coaching Federation certified coach with extensive training in evidence-based practice and cognitive behavioral coaching. She's the CEO of her company called The Soulful Journey, a coaching company dedicated to serving healthcare workers and those struggling with compassion fatigue, and is also a mental health coach with the famous Lyra Health, a leading mental health care benefits company. Please join me in welcoming our keynote speaker, Candace McAdams, with her presentation entitled The Importance of Mental Health Support in a Climate of Extreme Ambiguity. Candace.
Thank you so much, William, for that beautiful introduction. William is one of my absolute favorite people in the world, so I'm very honored that he gave me the opportunity to be here, and I thank the panel at Sanibel as well. This is something I really feel passionate about, the world of mental health. And I also really feel passionate in getting to know you and starting to understand what it is that you're going through, and to really share today. I'm excited. I have a very special place in my heart for you, not only just because we both are people are really dedicated to the welfare and well-being of others, but also because I've had the opportunity to see this as a patient. Back when I was at NYU and just had graduated the summer after, I was at the top of my game. I had 2 of the top acting agents in New York City. No immune system, and I was dying. And had it not been for a very, very special doctor named Dr. Wendy, I went in for a common cold, went the extra mile, spent an hour with me, and actually went ahead and did what I would have hemorrhaged in my sleep that night and died. That's the power of what you do. It is so remarkable, and I just want to applaud you and acknowledge you for all that you do, all work. I also am here because we need you guys to be okay. It is very, very back then as a patient, I saw so many things in the hospital, how tired you were, how exhausted you were, how you pushed through. After 2020, how that has only gotten worse. So I am here to share. And here I am. And that is a picture of me in my happy place. By then, I am not in my professional clothing. I'm in a t-shirt and jeans, but this is part of my workday every day. I make it part, I schedule it out every day in my work hour. Refill, to restore, to renew after a long day of clients. That was especially true during COVID. As the news reels came in, so did the anxieties, the depression, and even thoughts of suicide. I knew I couldn't hold the space for others if I was not okay myself. And my self-care okay. So today, my aim is, I'm here to spread awareness about the current mental health challenges in healthcare and put a spotlight on compassion fatigue. I'm here to empower you to take responsibility for all the wonderful qualities you have, to encourage you to thrive in your natural gift of compassion, to inspire you to practice of radical self-care and compassion. So doing your job becomes easier with time. Let's see if I can. So let's talk about compassion. What is compassion? Compassion embodies a tangible expression of concern for those who are suffering. If we look here, there's a picture of a little boy. I put that picture because that's something we're naturally born with. It's who we are. And then there are those who decide to spend their lives dedicated to a life of compassion. There are those who live a life in love and dedication to service for the well-being of our human family. And I know you guys have been learning and passionately learning about perfusion this week, but I just want you to stop for a minute and take that in. I want you to acknowledge yourselves and what you are doing with your lives. And dedication to the service for the well-being of our human family. It's pretty amazing stuff. When was the last time you acknowledged yourself? You should be doing it on the regular. Mother Teresa knew a couple things about compassion. She also knew a couple things about self-care. In fact, every 4 to 5 years, she had a mandatory time out for her nuns. She knew that she could not continue to have, can you guys hear me okay, by the way? Sorry. Can I get a thumbs up?
Yeah, Candace, you're sticking a whole lot up and down. We're trying to figure out what to do. I'm sorry. It's probably that connection there in the hotel. So we're not hearing you as clearly as we'd love to. Susan, do you have a suggestion for that? then maybe we could put her talk on at another time and find a better location.
Okay, yes, I think we should probably break for lunch. We will have a 10-minute exhibitor presentation now with specialty care. And I think the attendees are on for that. And then we will come back in let's see. We'll come back in 1 hour and start this again. How about right at 11 o'clock, we'll come back.
So say it again one more
time.
So say it again one more time, Susan, what the new plan is.
We're going to take lunch right now. We'll come back promptly at 11 o'clock to start with Candace again. And that's 11 o'clock Eastern time. And
it's actually past 11 o'clock. You mean 12 o'clock Eastern time?
12 o'clock
Eastern time. Yeah, I'm Central time. I'm trying to calculate all
Right.
this and plan it. Yeah. And come back at 12 o'clock and we will have our 10-minute break with specialty care right now during our lunch session. So we'll take a break right now.
We'll give it a chance to get this corrected.
Yeah.
So
We'll see you here in a little bit, Candace.
Okay, sure. Okay, should I call Will?
yeah, go ahead, switch. Yeah.
Status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling veins aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling veins work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 regional oximetry system is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced INVOS 7100 system provides innovative, next-generation improvements over the INVOS 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
Presentation, right?
Correct.
Okay.
We're live, so.
Okay. Hi, greetings, everybody. Again, sorry for the technical difficulties. I guess that's what happens on our virtual meetings and stuff, but thank you very much. We are going to have Candace come back on at that would be 12 o'clock Eastern time. She'll be back on. So if you want to, we have a 10-minute session with specialty care right now. Please welcome Sarah, Courtney, and Devin, and enjoy your lunch located outside the conference room area. And the coffee has been refilled for your convenience also for you to enjoy. So we're going to go ahead and welcome specialty care. Thank you very much for your support.
Great. Thank you so much for having us. It's a pleasure to be here. Susan said, my name is Sarah Ducheski. I'm our lead perfusion recruiter covering accounts in the Midwest and West. With me, I have Courtney Rosenblum. She's our senior recruiter and she covers our accounts in the South and the Northeast. And we have Devin Muniz, our area clinical manager, joining us today. Thank you, everybody. We'd like to get started and talk a little bit more about specialty care. We are the largest provider of perfusion services in the country. We support 1 in 8 of all open heart surgeries each year, with more than 500 perfusionists currently employed at specialty care. Over 1,100 hospitals are partners with us, and we participate in over 400,000 total procedures each year. We offer the best-in-class equipment and supplies the industry has to offer. We have 3 different service lines: perfusion, intraoperative neuromonitoring, and surgical services. In our perfusion service line, that is our largest service line, we have over 500 associates on board. Intraoperative neuromonitoring, we are the largest supplier of this in the United States, participating in over 110,000 procedures a year. And in surgical services, we provide support from a sterile processing perspective, autotransfusion, surgical assist, and minimally invasive surgical support. You know, with specialty care, we really focus on our people. Our people are our passion. We are dedicated and driven to making a difference in healthcare and also performing safer surgery. We have a really strong team culture, focusing on great working environments, strong manager and coworker relationships. We offer training and development programs for all of our associates, and we are nationwide in over 44 states, DC, and Puerto Rico. We have large accounts and big, smaller accounts in rural areas, urban centers. So really something for everybody, no matter what your needs are. We also have a really supportive infrastructure to provide guidance through any challenging cases. We have industry-leading data and research, and a lot of opportunities for career development, management opportunities. You can really carve out your path here, whatever that may be. And it's a place to call home. Our average employee tenure is over 8.5 years. Within our benefits, we offer a whole host of benefits, including medical, dental, and vision coverage, health savings account, 25 days of paid time off to start your first year, 401k savings plan with up to 7% match for the first, up to 50% match for the first 7%, student loan repayment to help pay back those student loans, tuition reimbursement if you're looking to advance your career, and also professional development stipends to attend conferences just like this one. All right, and Courtney's going to take it away.
Hi, everyone. I'm Courtney Rosenblum, Senior Perfusion Recruiter for Specialty Care. Thank you so much for joining us today. We are happy to be here. On the screen, you'll see our hot job opportunities located from north, south, east, and west. We have our northeast locations. We have Harrisburg, Pennsylvania. We have Harrisonburg, Virginia. We have locations in Indianapolis, Minnesota. We have Florida. We have locations in the West, in California, Thousand Oaks, Fresno, a lot of opportunities. And as Sarah had mentioned, we are located in, we have 1,200 locations, and we can find a position that works best for you. Next slide, please, Sarah. We are on every social media platform. So we welcome you to join us on Facebook, Instagram, Twitter, LinkedIn. We also have webinars and podcasts that offer a wealth of information. And we would love for you to join us. Make sure you share, like, and comment. And now we would like to share Devin Munoz with you. He is our guest speaker. He's our area clinical manager from Abilene. Welcome, Devin. Thank you.
Thank you. So I was asked to give a quick 2-minute testimonial on my time with specialty care. So I just wanted to share a little bit background about myself first. I went to SUNY from 2011 to 13. I then started working for the University of Texas at Houston from 13 to 16, and then joined specialty care as a staff perfusionist in February of 2016. I became the chief in September of 2016, and then area clinical manager in October of 2017. When I first started preparing for this testimonial, I decided to just briefly talk about 2 points that have greatly influenced my time with specialty care. Number one is that the leadership exemplifies authenticity, integrity, and transparency. From Sam Weinstein to Curdy Patel, Al Stammers, David Summerall, and even James Buck, my direct manager. Not only has communication been incredible, but even the tone and delivery of that communication has been unmatched. And then number two, identifying and developing your strengths as a perfusionist. From the very beginning, specialty care signaled their desire to invest and develop its employees. And I've seen this many times over and over within the company. I'm personally grateful for the mentors who've supported my transition into leadership and who continue to support growth. So I know that's quick and simple, but those two things really have made a big impact on my life with specialty care. So thank you.
Thank you, Devin.
Thank you, Devin. And then we have a quick video to share with everybody.
I don't believe we can hear the sound, so you may need to there's a sound sharing option on the screen. Upper right corner somewhere.
Okay. You're right. Okay. I will go back to that.
Today, high-quality care requires a degree of economic responsibility, and specialty care, with its unique blend of clinical expertise and economic and operational excellence, will deliver hospitals and surgeons to the optimal point where outstanding patient care and cost control intersect.
Specialty care knows what it takes to be an integral part of the OR team, delivering the highest quality outcomes.
For the last 3 decades, specialty care has focused on value and evidence-based delivery of healthcare long before there were buzzwords. We made patient-centric care and surgeon satisfaction a cornerstone of our company by ensuring our associates are the best available. Our perfusionists support 1 out of every 8 open heart surgeries at hundreds of hospitals across the U.S. We are by far and away the market leader for perfusion services. Our team is made up of the best and the brightest, and we never stop investing in them to make sure it stays that way.
Our associates are passionate in their career and equally passionate about having a balanced, fulfilled life. At Specialty Care, they get both. With more than 3 decades of experience, we've learned a lot. We use that learning to create a culture today that is dedicated to the success of our people and customers alike.
One of our company values is continuous improvement. It drives our philosophy of ongoing education and investing in the growth of our people. In this spirit, we created Specialty Care University. Whether on clinical rounds with a mentor, hands-on in our simulation OR, or in the classroom training, or through other educational programs, we set the bar for others to follow. We encourage career growth by providing tuition reimbursements and scholarships. We offer company-sponsored education materials, and we enable best practice and information sharing throughout the organization.
When you work at a hospital or other perfusion company, you're lucky if there are a few other perfusionists to bounce ideas off or learn from. And the staff probably doesn't really know what you do. It couldn't be more different at Specialty Care. You literally have hundreds of colleagues available to share ideas with and learn from what they're doing. And the team here is intimately familiar with your role as a perfusionist and the support you need to be successful. As a nationwide provider, there are opportunities for relocation if you like, and advancement potentials that others just don't have. It's no wonder perfusionists choose to work on the Specialty Care team. It's an environment like no other to build a career and help people.
Few organizations invest anywhere near the resources Specialty Care does to make certain our team is the best, and we're the best place for a perfusion career.
Specialty care is made up of recognized experts. Our team has been invited by the FDA to solve critical health challenges, like determining how heater coolers can cause life-threatening infections. We're highly sought after speakers and present and publish research at top medical societies and events, such as those held by the American Society of Extracorporeal Technology, the American Academy of Cardiovascular Perfusion, the Society of Thoracic Surgeons, and the American Association for Thoracic Surgery.
Whether your goal is to be recognized as one of the best perfusionists in the industry, publish and present advances in the field, take on a leadership role in management, or all of these, it's possible at Specialty Care. Our perfusionists benefit from the support of an advisory team of physicians, medical leaders, and doctorate-level biostatisticians who they can work with to research, present, and publish thought-leading studies that improve the care and economics relevant to the field of perfusion.
We perform over 120,000 perfusion-related procedures, including 1 in 8 of every heart surgery in the United States. That makes us by far the market leader. Why this is really important is that it allows us to collect data from those procedures to continuously grow SCOPE, the Specialty Care Operative Procedural Registry, which is the largest database of its kind. We analyze the data, using it to establish standards and best practices that improve outcomes and drive medical and economic advances. It also allows our customers to not only measure their own results, but to conduct peer comparisons that help them identify how they can improve. There's no other company, hospital, or health system with the same data and dedicated team available to provide insights and innovation that specialty care does in our fields of medicine.
What was the reason that we decided to join specialty care? And I can tell you that it was respect. They respect their clinicians, they respect employees, they respect their patients, and the staff. Specialty care is truly a world-class healthcare provider focusing on giving the best possible care to each patient 365 days a year, period.
If you're dedicated to being the best, providing patients the highest quality care, we want you on our team.
A team of expert clinicians that help deliver exceptional patient care is what specialty care has earned a reputation for, helping patients get back to their loved ones and live a healthier life.
All right. All right, and thank you all today for letting us attend. We had a wonderful time. We hope everybody's been enjoying the conference, and we look forward to connecting with you this afternoon in the virtual exhibit.
Fantastic. Thank you so very much.
Thanks, everyone.
I'm sorry. Go.
Good job, Devin.
He is wonderful.
Thank you very much. And thanks, Devin, also. Now we'll reconvene at 12 o'clock Eastern Time for Candace, our keynote speaker again. Thank you so much, Specialty Care. See you at the booth.
Thank you.
Thank you.
The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new INVO 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced INVO 7100 system provides innovative, next-generation improvements over the INVO's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVO system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVO 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVO 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the Lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invo 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invo 7100 system provides innovative, next-generation improvements over the Invo's 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The INVOS system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
Welcome back, everybody. I hope you had a good lunch. Well, what meeting wouldn't have some kind of technical problems, especially when it's virtual and you have tons of storms out here in the Southeast. But we think we have it rectified. And I'll make this really short in announcing our keynote speaker since I kind of did it earlier. Candace McAdams is a graduate of New York University and an International Coaching Federation certified coach and extensive training in evidence-based practice in cognitive behavioral coaching. She is a mental health coach with the famous Lyra Health, a leading mental health care benefits company. And I want to join her as a keynote speaker. Her presentation entitled The Importance of Mental Health Support in a Climate of Extreme Ambiguity. And boy, are we in one now. Candace, thank you.
I concur, William. Thank you all for your patience. And yes, ambiguity. What a beautiful topic for these times. Thank you for improvising with me. I'm glad to be back. And once again, I just want to reiterate how honored I am to be here. And I thank you for letting me be your guide through this experience as we sort of foray into the world of mental health in the healthcare system. I know your time is very valuable, so I'm going to move forward and just kind of jump in and say that I really, really admire what you do, and I have a very, very special place in my heart for all that it is you are, because we share a commonality and that we are really concerned about the welfare and making sure that others are okay. That is our commonality. I'm also really, really, really interested in the mental health of healthcare workers because I myself was a patient who was diagnosed with aplastic anemia right after I graduated NYU at an early age. And I was able to see some of the flaws in the healthcare system. I saw a lot of people that were burnout, tired, exhausted, had sort of lacked that feeling of apathy and compassion, which is actually what brought them to this profession. So I really, really want to make sure that everyone is okay out there. And that is what we're going to use this talk to really focus on today. And hopefully give you some tools that will make you feel better by the end. So as I jump in, I want to go ahead, hold on just one second. Just want to kind of reintroduce myself. I don't know what part you heard before, but that is me by the beach. That is my happy place. As you can see, I'm not in any professional gear. I'm in a jean and a t-shirt, but that is part of my profession. Every day after I have a long, exhausting day of working with clients and holding the space for others, I make sure that I go and rest by the beach, restore, renew, so that I can come back to my next day full of that self-compassion that I give to others. So what is my goal here today? Really what I want to do is go ahead and spread the awareness about the current mental health challenges in healthcare and put a spotlight on compassion fatigue. I want to empower you to take responsibility for all the wonderful qualities you have and encourage you to thrive in your natural gift of compassion. I want to inspire you to create a practice of radical self-care and self-compassion so doing your job becomes easier with time. So, what is compassion? When we define it, compassion embodies a tangible expression of concern for those who are suffering. I put a picture of a little boy there because that is just something we're born with. We have that natural gift. And then there are those like yourself who live a life that is dedicated to serving others. This is a definition here that we have. Those who live a life in love and dedication to the service for the well-being of our human family. Before, I was asking you to take 1 second to just acknowledge that that's what you've chosen to do with your life as a healthcare worker, to live a life in love and dedication to the service of the well-being of our human family. It's pretty amazing stuff. And I'm not sure when the last time it was that you were able to acknowledge yourself, but I think you should be doing it pretty regularly. So what's an unhealthy use of compassion? Well, you understand that it's impossible to give what you don't have. As part of your work, you make sure to put your own oxygen mask on first by practicing the routine of self-care. You regularly monitor your mental health, especially after any traumatic events. And you're able, as a result, to show up in all that you are, shift after shift, able to act critically and be there for others. What's an unhealthy use of compassion? Well, it's putting your needs on the back burner. It's pushing through exhaustion and mental fatigue in order to be there for another, and not asking for help when you're struggling. The results of this, we're starting to find, is that it affects your ability to provide safe, high quality care, and most likely leads to bigger problems down the line, which we'll talk about in a minute. 86.9% of emergency response personnel reported symptoms after exposure to highly distressing events with traumatized people. 86%. As Dr. Naomi Rachel Renman says, the expectation that we can be immersed in suffering and loss daily and not be affected is as unrealistic as expecting to walk through water and not get wet. Let's talk about the cost of compassion during COVID. These are the mental health statistics for healthcare workers in 2020. I want you to just sort of take a scan and notice some of the things people were experiencing: frustration, exhaustion, anxiety, trouble sleeping. You may find yourself in here, and if you have, you'll realize by these numbers, you are not alone. In 2020, 39% of healthcare workers did not feel they were getting the emotional support they needed. Why is that? This is where I got very curious about your industry. And I started to learn that there's some stigmas behind getting mental health. Many in the profession view asking for help as a weakness. Many healthcare workers hold themselves to high standards. There's a highly competitive nature, and they feel seeking mental health care is a weakness, and people are not openly talking about the struggles they face. There's also an impractical standards of being the picture of health. Healthcare workers commonly enter the healthcare industry with a calling to care for others and might feel unqualified to effectively care for others if they need treatment for themselves. Healthcare workers are expected to be the picture of health, so they often have a hard time admitting that something may be wrong with them. I like to use an analogy with this in the way that we need to kind of start to shift the paradigm. If you were driving an Aston Martin, you would not want to have to take that to a mechanic who is driving a broke down car. So we have to make self-care a priority. Pushing through is not the solution, and we need to kind of turn that paradigm around so it works better for all of us. There's also a fear of judgment and discrimination. Oftentimes healthcare workers fear discrimination in licensures, or that seeking care will damage their professional reputation, or that peers or colleagues might see them differently. And most likely those peers or colleagues are going through the same things that you are. That's why conversations are really important. And over time, what ends up happening to people is this psychological duress of not being able to sit with emotions, feel emotions, allow for emotions, or not being able to manage the thoughts, not being able to take care of yourself, starts to really change the cognitive perspective of the caregiver. And such things as intimacy, trust, safety, self-esteem, and control. And often we interchange that with the word compassion fatigue. So what is compassion fatigue? Compassion fatigue was a term coined by Dr. Charles Figley that highlights the physical and mental exhaustion and emotional withdrawal experienced by those who care for sick or traumatized people. It often involves an intense state of tension or excessive preoccupation with cognitive, physical, psychological, and emotional pain and suffering of trauma survivors. What it tends to develop is an apathy or indifference towards the suffering of others as a result of the overexposure to trauma. In other words, you're not really being yourself. So who does it affect? It can affect a lot of people in the emergency response, such as fire workers. We also have it in some of our police officers, as we've noticed, FBI, that sort of thing. It also can affect psychologists, coaches like me, veterinarians, and It can even affect you. Here are some of the symptoms that we need to look out for, although there's many more that I'd love to share with you in a document later so that you can continually look out for them. But here's some of the main ones. Being exhausted and feeling depleted. I want you to just kind of ask yourself if any of this has happened to you in your course of working in the field you have. Difficulty concentrating or sleeping. Reduced ability to feel sympathy or empathy, that's a big one. Anger and irritability. Dread of working with certain patients. A heightened sense of anxiety. And problems with intimacy or personal relationships, even trouble parenting. Here's some compassion fatigue breakdown. All three are actually under the title of compassion fatigue. But compassion fatigue can be both cumulative and can happen fast. And if it's identified, it can be managed early and has a faster recovery than, let's say, burnout. The distinction in burnout is it's a cumulative process. It happens slowly over time. And it's marked by just an exhaustion and withdrawal that's mainly has to do with increased workload and institutional stress. It's not trauma related. To go back to trauma related, there's also secondary trauma. So it's the emotional and psychological effects experienced through indirect exposure to the details of the traumatic experiences of others. So you could be in a room and hear a sobbing parent when they've lost their child and still be affected. So it's important to note that if you're surrounded in that sort of environment. You can also just hear a story from somebody of a really kind of traumatic event and really be affected. That happens a lot in my profession. How to prevent compassion fatigue. So this is where I come in with my coaching and expertise because I've made self-care a huge priority in my daily life. One of the first things is just very simple, but taking good care of your body. Obviously in healthcare, we promote that. So it's eating healthy, exercising, treating yourself, not grabbing that extra cup of coffee, but water is one of the best caffeines actually we can have. Exercising, really taking yourself out and getting yourself a nice massage after a really long shift, just restoring your body. The second I really want to kind of highlight is emotions. Emotions, I call them emotions because they need some way to be expressed. They need, in other words, they need an outlet. I would just imagine that most of you have a very good friend, and if that good friend was to come knocking at your door today and said, "I'm not okay," you most likely wouldn't shut the door in their face and turn them away. It's the same with your emotions. They are usually trying to tell you something and get through to you. So I would say treat your emotions as you would a best friend. Journal, meditate, spend time in nature. Get to begin to ask yourself, like, how am I feeling? Check in on the regular. And if that's not accessible to you or not something you're accustomed to doing, talk to a therapist or a coach. We'll help you be able to get in there and really start to access emotions if there's something you're used to kind of shutting off or shutting down. Also, practicing self-care and healthy boundaries. So really learning to say no to something, to say yes to yourself. If you're just not feeling good, it's okay to not be okay. And it's okay to take some time for yourself. And I think that is one of the main things that needs to start to shift in the healthcare industry, because it's not happening enough from what at least my research and what talking to others. I'd also recommend leaning into your support system. So just really talking to colleagues. I can't stress how important it is that you all start a conversation. My other job is in film, and I will never forget the day that we had the Me Too movement start. And it was a wonderful time for me because we felt it was such a toxic environment, the film industry, and just to have so many people start to talk about their experiences was extremely healing. I don't know if you would know about the doctor that committed suicide in New York, but that sort of started a Twitter conversation and a social media conversation. And a lot of people started to talk about the problems in mental health care, and that's how this stuff gets started. So talk openly and encourage and foster an environment where that's okay to do. Get a compassion tribe of people who understand. So colleagues, friends, people that are around you that understand. It's okay to also have your group of people that don't understand, but they're just really nurturing and kind of ground you and pull you away and pull you out of your work. But main thing is get support. So compassion that does not include yourself is incomplete, says Buddha. And he was around a long time ago, and it still holds true today. The other thing that I want to note is in the beginning slide, I had a picture of Mother Teresa. She's really, really amazing. But she also, as I had said before, she really, really stressed the need for self-care and self-compassion. I think we need to listen to them. So also, how do you help others? If you notice somebody else is struggling, something's not right, a colleague is just, they seem burnout, they seem tired, that same light that you normally see in their eyes, it's not okay. Check in, encourage an atmosphere in your workplace where it's okay not to be okay, like I said. Talk openly about your experience in your workplace and start building more programs. And talk to your managers, your bosses, the hospitals. There are programs out there. I have a friend who is in the ICU in New York City at Mount Sinai, and she said there's plenty of programs, but people are not doing them. So encourage your friends and your colleagues to get involved as much as possible and continue to seek more mental health information and encourage others to take a quality of life test. I am going to be sending out a actual link to a wonderful site that will link you up. This is the quality of life test is a great way to monitor if maybe compassion fatigue is setting in or burnout is on its way. And I want to kind of start to bring this home that really happy you is a happy life. And when I say that, what I'm really stressing is we are meant to feel good. I learned this very well going through and overcoming a very serious disease. During that time, I was able to really start to face the idea of mortality. And I was able to, as I laid there in my bed and started to ask, like, why am I here? What do I want my legacy to do? If I survive another year, what do I want to be remembered for? I started to ask those powerful questions that we do in coaching, long before I even knew what coaching was. And what slowly started to develop is I started to hear answers. I started to get to know myself from a deep level. And I started to connect with what makes me me. All the time when I'm in coaching, I really start to listen in to my clients. They come to me broken, scared, sad, depressed, full of anxiety. And slowly, as we start to work together, they start to reconnect with what's true about them. The truth is, we are joy, we are ease, we are resilient, we are resourceful, and we are able to get through anything. So when we're not feeling good, that's usually an indication that we actually need to come home to ourselves. Stress, for example, is an emotion that's just telling us there's another way to do this. We need to check in with the self. Once we do that, the rest of our life starts to reflect in a different way. So how do we do that? I have a couple of solutions from the coaching work that I've done. One is to really connect with the best version of yourself. I like to spend about 2.5 hours with my new clients on getting to know their core values. You don't have to get sick like I do and almost die to start to get to know the self. It's just really assessing what is it that I am? What have I always known myself to be? And who do I think I always will be? This is really a wonderful compass in times that are very stormy, where we don't feel like ourselves, We're able to go back in and check in with those values and say, what's missing? What values am I stepping on? What do I need to get back to? And what do I need to tune up? There's also the practice of self-compassion. I call it the goldenest rule, but learn to treat yourself as you would treat others. I think this is very true for this industry. It's really going inward first so that you can be the best to others outside. I also say accept yourself for being a human. Know that someone else somewhere in the world is going through the exact same thing as you are. I have clients every day come to me, and as they rant and rave and talk and express and get all of these things out, they feel like they're the only one in the world going through that. And I will tell you, as a coach who sees about 40 clients a week, that is not the case. We are all human, we all struggle, we all go through the same things. I've also traveled a lot. I've been around the world in 64 countries. We are all so similar and we all struggle the same. So just accept that you're human. If you're struggling, it's okay. Another thing that has really gotten people through COVID and is very, very important in life is to learn the things you can control and the things you can't. It's a good old serenity prayer if you haven't heard it before. It really does make a difference. Most of the things in your life are not in your control. If we were to worry about a pandemic coming, it didn't change the fact that the pandemic was going to come. It came. Worry doesn't really help in our process. It just creates burden. So it's better to, if you're really struggling, write a list of the things that are in your control and what you're not. And I always tell my clients, rip that paper in half, and the things you can't control, throw it in the garbage on a regular, and get focused on what you can. What you can control is your response to how out of control life is. How are you going to be with that? That's your responsibility. Your response is your responsibility and will always be, by the way. Also, never underestimate your resilience. You are way more powerful than you realize. And really, when you look back at your life and all of the times that have been hard, you've always made it through. I think often, I'm from California, and there was a lot of houses that burned down, obviously in Malibu. And a lot of people described relief. Well, my family is okay. And what they described was the most relief that they felt is that they had worried for 20 years that this would happen every time they left their house and thought their oven was on every time, and they no longer had to worry. We always march on. We're always able to get through. It's the mind, it's the anxiety, it's the disconnection from that part of us that knows that to be true, that tells us otherwise. Don't buy the story. Get back to the moment where all is good. And this is how we really do it. We start to practice mindfulness on the regular. If we notice, like I said, to bring up that story of a burning house in front of you, in that moment, as families are hugging their loved ones, everything is okay, even with a burning house. So I really encourage you to really find as many moments as you can, live as many moments. If something's happening and you're struggling in an operating room, just take a moment, get back. Everything is okay. And really, we've talked a lot about gratitude out there, but gratitude is one of the quickest ways to get us back to the moment. If you guys were just to take 1 minute right now, I'm going to give you 1 minute. I want you to just take stock of 5 things you're grateful for about this moment. Just breathe into that. Feels different, right? Keep doing that. It's good for you. And I'll leave with the final words that, you know, passion drives people to be great and to continue moving forward through tough times. And caring is an amazing power, but it comes with responsibility, mostly to yourself. So thank you so much for allowing me to share with you here today. Like I said, it's been an honor. And please, let's just go ahead and open up for some Q&A and start a conversation.
Thank you, Candace. Thank you, thank you, thank you. We had a lot of people online listening and comments were starting to come through. I have things that were just spinning out of my head, but you know, I know you, so I get a phone call every once in a while, and I get the free therapy every so often. Thank goodness. Or I don't think I'd still be here.
Oh, man.
But we can
I
open
have
up.
a question for you, or I guess just something to discuss about the emotional support systems at hospitals or departments. Sometime administer or opportunities to have just a group session talk. Is everybody able to get to those, or do they just have them in their certain groups or departments to be able to kind of talk about anything? And in those sessions, you know, you don't repeat anything that leaves everything stays in that room, so you can talk openly and stuff. I've been in a few of those following a disaster session or something like that might have happened. I think those are really, really helpful for everybody to kind of get back on track, and if you need some help from some other friends that you might not have known about.
I think those are terrific. I see online that, you know, a lot of people either wished their institutions would implement programs like that, or as somebody mentioned, oftentimes these programs that do exist in hospitals, we're not able to attend because of the busy clinical schedule. And we're like this small portion that hospital management kind of forgets, you know, because we're in the OR, so we can't get to it. So some of the most stressful and time-consuming jobs in the hospital, those people can't get to them. That was some comments that were made in our chat question and answer.
I've got a question. As far as in a corporate, you know, with us having corporations all over the, you know, hospitals all over the U.S., is there anything we can incorporate in our monthly or weekly sessions or meetings that, you know, for just a brief part of our meetings that we could do with our employees as managers, just, you know, maybe a 5-minute segment on each one of those meetings that we could bring up to the table at that point in time?
Yeah, I would love to speak on that, Ty. I think that if you were able to do a check-in, even if it's an acknowledgement session of just acknowledging some sort of thing. I've noticed I work a lot in tech, and they have created sort of a wellness challenge to some of their employees, which has been really super effective. These employees would never, they work really long hours. They're having a really, really hard time giving themselves a timeout, but when it's mandatory, they do it. So it sort of becomes a real team building thing, but it's also a way to get your employees taking good care of themselves as well. So some sort of wellness challenge is a great way to do that. And it could be different exercises, that sort of thing. Yeah.
Do you find there's a gender difference? Maybe not on today's virtual talk because you don't have people in the audience, or you're not seeing the chat questions and answer. Is there a gender difference in people seeking help or acknowledging that they may have a problem and therefore seeking advice?
So no, actually no. I actually see a lot of the male population, and they're probably about equal in my world, like I said, of tech and some of the creatives I work with, which I think is fantastic. I often find a lot of women say, well, men are so unemotional, or they just are so stoic. And actually, That's not true. There's a lot going on. And I know this as a coach because they come to a place where they feel safe being able to be emotional. And that's just something I wish would change. I wish men were able to have those vulnerabilities and feel safe enough out in the world to be able to talk about it and not be viewed as sort of weak. Because it's just simply not true. We're all human beings. We all feel things. We all have anxieties. We all have stressors. And yeah, I see that equally across the board. And I'm really happy that a lot of men are coming to me because I think it's been very healing for them to be able to have a place to bring that because they just don't in the world a lot of times.
Are you seeing the problems different between men and women that you see?
That's a good question. Yeah, I think there's some role differences, right? The pressures they feel. I do see that men tend to take on a lot of pressure, hold it inside, and then that creates the generalized anxiety or the depression or the disconnection. They tend to bottle up more than women, I would say. And that's a really big problem over time, as we talked about today. You can't bottle this stuff up. So, yeah.
As a professional, how do you extract that then?
You know, it's a good question. I think the coaching model extracts that because we're really, as coaches, we are there to ask those powerful questions. And it's by asking those powerful questions that they start to listen within and kind of come up with their own answer. So it feels very safe. I love the spirit of curiosity in any conversations. We tend to communicate in sort of I or you or this or that. But curiosity, I'm just curious what's going on for you. People feel heard, they feel seen, and they immediately feel like they can trust you and open up. It's a really powerful tool to incorporate in your communication and something I do all the time as a coach. So I think that's sort of the key, right? It's just asking questions, which is great for you and your colleagues. You know, I noticed some things up. You're normally this way. What's going on over there? I'm kind of curious about what your experience is, right? They don't feel as threatened. How many times have you heard, I hate confrontation. I hate talking about my feelings, you know? So it's sort of a way to ease them into it. And there's a great guy that I love, Chris Voss. He's an FBI negotiator. I don't know if you've ever heard of him, but he uses a lot of the same techniques when he was working with terrorists that we do in coaching. And that was really just asking people about their own experience and repeating back to them what you're hearing, acknowledging what you're hearing is a great way to get people to open up to you. Yeah, pretty interesting stuff.
I know you touched on the burnout factor, but I've seen that a lot in our profession. Do you have any examples of things that you could do as a member of a group that's experiencing burnout to support other people that you're working with, even as you're kind of going through the same situation? Or what thoughts do you have?
Yeah, so burnout is going to, like, again, look a lot like it's under the umbrella of compassion fatigue. So if that's happening, I don't know if this answers your question. One of the reasons I want to provide the quality of life assessment is so that people can first identify. Burnout takes a little bit more time, it seems like, in at least the research I've done, to really heal and process, and it's environmental. So it kind of starts with institutions. It starts with the environment. If the environment's extremely toxic, for example, it's a systemic thing. It has to start to get changed within. So I would say when you're asking for solutions, is that kind of where you're going?
Well, I think I was specifically asking, you know, obviously people could probably seek help individually, but if you're all working together and you're all under that same type of pressure, is there anything specific you can do to support each other in light of the fact that you're all experiencing it as a group?
Yeah, I think it kind of goes back to Ty's original inquiry. And I think, you know, the challenge some of the things you were talking about with sort of like being able to talk amongst, like as a group, that team, I think that team feeling of we're in this together and we're going to get through this together and we're going to come out of this together, I think is important. Mindfulness practices, encouraging such things as, I'm not sure in a hospital environment, but meditation has been extremely useful in prison systems and school systems and all different types, even with police officers, it's been very effective. So we're finding that a lot of times just encouraging an environment where we take a time out together and we're in kind of a spirit of taking good care of ourselves, but we're doing that and by supporting each other in that. So group things are important. Also just probably doing, I know I have a lot of friends that are also in healthcare and nurses and that sort of thing, and they tend to go to a bar after a long couple of shifts. I would try and think of healthy activities outside of that. Let's all, I don't know, I'm from California, let's all go for a hike, or let's all do something that is not quite, I've earned from a stressful week 3 glasses of wine, because I don't know if that's necessarily solving the problem. It's kind of avoiding it. So I would just say kind of shifting over to something that is team building, just like in any profession. Yeah.
I have a question, like you mentioned mindfulness, like, can you explain mindfulness and what that means? I see that word like thrown around a lot. Like what is the concept of mindfulness?
Yeah, so it's sort of being able to watch your experiences and allow for them. You're sort of start to become an observer of what's happening. So that's kind of like, and mindfulness can happen doing anything. You could be cooking, you could be at the beach, you could be taking a bath, a lot of people, when they hear the word mindfulness, think that they have to sit and be quiet for 2 to 3 minutes, but it's really just kind of watching what your mind is doing, watching and observing your activities. It's watching and observing your emotions. And it's really just sitting and like allowing it to be what it is. And by allowing it to be what it is, you're able to sort of cultivate a feeling of presence. So for example, if we were kind of to get mindful about what we're doing now, we're on a Zoom call together and there's these squares that are happening and you guys have been up since really early. And so there's all these circumstances that we're just watching. We're not really judging it. And we're a little more on purpose. We're not on autopilot. We're starting to kind of pull ourselves out of the moment. out of the situation and the circumstance and back into just watching and observing, if that makes sense.
So that's like being in the moment, not thinking too far in the future, not thinking too far in the past, which I suck at. And I always have to remind myself to smell the roses. I guess that's a cliche. But it's so damn true. You gave us that 1 minute and I took it seriously, closed my eyes, and I thought about 5 things as you suggested that I should be thankful for. And I really felt relaxed after that 1 minute. It had nothing to do, with this meeting. It just had to do with, some family and, I'm making an income and whatever, just 5 things. And it really helped. I think my heart rate went down to 25, which is, I think, is a good thing. I don't know.
That's why your Apple Watch reminds you to like breathe every day, right?
Yeah, right. One thing though I want to bring up, and maybe you can respond to that, is a couple of people have brought up the importance of sleep, which we're often deprived of in this profession.
Yes. And so would you like me to speak on how important that is? Because I will say it is absolutely vital. That's one of our boundaries, by the way. We really have to, as we start to do work-life balance, we really have to learn to get sleep. I don't know about you, but when I don't sleep, I'm like Chicken Little. Do you guys remember Chicken Little? When he was like run around and be like, the sky is falling, everything becomes more dramatic, and it's not good. So yes, we all need sleep. It obviously compounds problems when we're not well and we're not getting sleep. And I think that probably happens quite a bit with you. I don't know, William, if you want to comment on that, but in your industry where you have to sort of be on call and get up in the middle of the night and perform under these extreme circumstances. So yeah, getting a regular routine if you possibly can. I know there's circumstances that you have to work with, but little things like not being on the phone, technology 30 minutes before bed, super big. That activity I told you about, acceptance before we go to sleep. A lot of times we can stress, like you said, William, we'll be back in the past of what's happened in the day, or we'll be thinking about the future. I call them the alternate planets. If you think about the past, it's already happened. If you think about tomorrow, you don't know what's going to happen, AKA COVID, right? So we don't want to live there too much. If we're living in those planets too much, we are not experiencing the moment. So at night, doing that acceptance exercise I talk about, of just like kind of putting a line down a piece of paper and saying, okay, what can I do and what can I not do? That is huge for people. A lot of people got through COVID doing that and just realizing there's a few little things they can do. And one is getting sleep. So whatever it is, it's really important that you set the tone and the environment for sleep at night, turning down lights, soft. I love to take a bath at night. It's kind of sending a signal to my body. It's okay to rest however you can get there. Anything else you want to ask about sleep? We have a lot to say at Lyra about sleep, but there's a lot there. So I don't know if you.
Well, you know, we carry the anxiety in our jobs, in our environment, in our culture. And sometimes it's that anxiety that keeps us from sleeping. And I know you're pretty much a nature path, natural woman and all that, but I've resorted under a sleep specialist to some sleep, pharmacology every so often to try to relax me, because I know how important it is to get sleep and how dangerous it is to be without it for days, weeks, months. I mean, your immune system alone gets knocked about. So, I don't know if additives pharmacologically is a good thing or not. Certainly should be under the care of a physician, but it helped me along at certain times.
Mm-hmm. What did you notice? I'm kind of curious, just to use your example. What do you notice happen when you have trouble sleeping?
So I guess symptomology wise or symptom wise, I've just become more anxious and I'm not focusing in as well on what's important. My mind's just flying all over. I think probably when it got worse, I, maybe got sick more often, related to the immune system. Probably my relationship with family members or friends was hampered or deteriorated to a certain point. Mm-hmm. I don't know. I had a lot of problems, so I could go on and on, but hopefully I'm not alone.
You're not alone. You're not alone. And you just said something really key, and that's the mind, right? The mind is, I don't know if we have time, but I have a great analogy. How many minutes do I have here?
You have time, about 10 minutes.
Okay, good. I always like to, because I work in cognitive behavioral coaching as well, I always like to say that the thoughts, the emotions, and the actions all need to be in balance at all times. If the thoughts are getting too much of our time and space, other things are going to be compromised, including our actions. So I have this wonderful analogy of going on a road trip. What we really want is our aligned self, our true self, those values that I talk about checking in with. We want that part of you behind the wheel on the adventure of life, because life is an adventure. We do not know what tomorrow is going to happen. And there's different perspectives to look at it. That's how I choose to look at it. Next, in our passenger seat, we should have emotions, because emotions, remember, are our good friend. They have messages for us. They're trying to tell us something. Remember, stress is telling us there's a better way. So we want to listen to our emotions. We want to honor them. We want to allow for them. Here's the thing about the mind. As much as I'd love to kick it out of the car sometimes, believe me, The mind is, when it is triggered by ambiguity or change or something it doesn't know, what it does is, remember I talked about those two planets, the past and the future? It will go into super drive on a super highway up there between the past and the future, past and the future, past and the future, because what it's trying to do, and that's anxiety, basically, it's trying to control the ride. It's trying to avoid suffering. It doesn't want you to suffer. So it has a role, and that's kind role. It's trying to protect you. The problem with that is that it's seeing everything under a limitation. It's seeing it through this narrow window of how things can turn out. I want you guys to put your hand up to your eye. And I know this is a silly exercise, but just kind of close your eye for a second. There you go. So that's kind of how the mind sees things when you're in anxiety, okay? Now take your hand away. That's the possibility of things that could happen. It's endless possibilities. There's so many different ways it can work out. And the mind is just simply forgetting that. So we put the mind in the back seat on our adventure, okay? And the mind will try and be a backseat driver. As you're driving along, it'll try and tell you about the pothole that might come up, and that if we hit the pothole, we might get a flat tire. And if we get a flat tire, we might not be able to get help. And if we can't get help, and maybe we won't get food. And if we don't get food, we'll starve and we'll die to death. I mean, that's the mind when it's just on that rampage. It goes straight to the worst case scenario. And so we have to continually monitor the mind. That's what that mindfulness is about. It's really kind of like stepping away. What is the mind doing? What is it trying to control? What are these negative beliefs? What are the limitations it's setting up for me? And we have to kind of step back. And we have to get back, again, part of being in the driver's seat is learning also to turn up the radio. Like if you're on a road trip, you turn up the music, and the emotions are going to go right along with that. They're going to start to feel good. You're going to start to feel good. And eventually the mind is going to be like, I'm talking, but nobody's listening. Nobody cares. And it will start to quiet down. And mindfulness also is saying, oh, look at that mountain. Look at that tree. Look at that cool thing up there. The more you start to feel good, the mind will quiet down. So when we're not feeling good, it's kind of this simple. When we're not feeling good, our job is to get back to feeling good. Our job is to come home to ourselves. Now, for some people, that's not simple because they've been on this rampage for a long time. Sometimes they can't remember it, but they might remember when they're holding a little baby, or they're in the embrace of their love after a long day of work. They remember the good feeling. But really, we're supposed to feel that way all the time, believe it or not. That's our right. We can feel okay. And we forget that. We think that this human struggle is just supposed to be endless stress. It's not. That's why I say it's our responsibility how we respond to all this. And if we make self-care a priority, then we're going to feel better. And that's why I'm promoting it.
And how do you avoid, I mean, we're living in a media stressful world. Yes. I would say the media is probably the one thing that stresses us out more than anything. And I try to avoid it now. I looked at a documentary on social dilemma. It was a great documentary.
Great documentary, yes.
And
yeah,
it changed my whole mindset of what to talk about around people and what to take in from the media. So,
yeah. I work with a lot of these guys. I was so proud of what the people who stood up and the tech world is this very tight clique, and they just put their reputations right out there and said, we've got to make mandates because this is unhealthy. The suicide rates of teenagers, for example, it's not proving to be a good thing in some regards. So we do need to take breaks from it. I really do recommend, my partner is really big into the news. He loves the news. He grew up in a political household. He loves watching it. I tell him that's fine, but I don't, I sift through, and I have specific times for when I'm going to watch any media. I think the more we can listen to our own self, like if we're in a good place, I think we can handle it more. But if we're not feeling good, it just feeds all of that anxiety. It feeds that mind that's just like, everything's bad, everything's bad, everything's going to fall apart, it's going to be bad, it's going to be bad. And then you're listening to it and you're getting confirmation. Well, what do you think is going to happen? It's just increasing your stress and anxiety. If you come home to center, you feel good, you've had a nice, and then you just kind of want to find out what's happening in the world, of course. But the more centered and grounded you are, the more you're going to be able to sift through what's important to your experience, what's important and what matters, and what does feel right to you, and what can't, again, going back to the acceptance, what can you control and what can you not? Because a lot of times media is just like throwing in your face a bunch of stuff you can't control. And that, again, increases that anxiety. I mean, it all kind of, it just keeps intertwining all of these sort of ideas and principles that we as coaches are really stressing.
Candace, do you have an out that you would suggest if people had that 10 minutes out of their time just to have some free time that's relaxing? We've had some people ask on the chat line if you have an out that you use or one that you would recommend.
Sure. Yeah. Calm is really great. It works for some people. It doesn't. I also tell people, whatever your particular stressors are, YouTube is fantastic. And I know there's a lot of people on YouTube right now. So YouTube is fantastic for finding little 10-minute meditations as well. And most people can get YouTube on their phone. That's where I find my stuff. So if I'm needing calm, if I'm needing to, I'm feeling a little bit of anxiety, there's really great meditational music I'll sort of put on in the background. There are meditations specifically if you're feeling pressure or needing to sort of come home emotionally. There's a lot of information there, but I would say calm is a really great one if you want to do it at night before you go to sleep. A lot of people are finding their strength and their sleep improving. We also at Lyra have been working with an app called My Strength, which is really fantastic as well. It sort of has these programs of self-care and self-help programs, and there's even one on sleep. So it's called My Strength. That's another really good one to look at.
I think people have mentioned a couple times. I'm sorry, Susan, go ahead.
No, you mentioned not to use any media or anything, or answer your phone or work on anything 30 minutes before you go to bed. I think that's so hard for us to do. And I'm always being reminded of that. Turn that off. But it seems like there's always just one more email that you need to answer, one more text message that you need to answer. So I'm very negligent in that. So I got to keep reminding myself that too, but you just got to finish one more important thing that you need to do. So it's very, very tough, but I feel like I can take care of myself better if with the work-life ratio, if I eat properly, get enough sleep and exercise. You have to find time to exercise. It doesn't mean you have to go to the gym or anything, but just get out and walk, or play tennis, or find a buddy system to work out with, or whatever that you can do, bike ride or whatever, and yoga. I love that too, just to kind of calming, and not only for stretching and everything too, but it's very mind setting too. But one of our people too, Jody had mentioned here, she's been in the COVID ICU nonstop for at least a year now. And a lot of our coworkers have been doing this and seeing a lot of her patients die while caring for the ECMO patients. These people get really close to the family and to these patients too. And that's really been taking a toll on them and on their mental health in the last year. So, but I think these apps too, they would really be helpful for them.
Yeah, thanks for sharing that, Susan. It's so true. I have a dear friend that works in the ICU during COVID at Mount Sinai, the COVID unit. So my heart just goes out, and like you remembering that great quote, it's impossible to not be affected. It's absolutely impossible. So we really do have to take good care of ourselves. I also wanted to make a point about what you said. I think, what I was trying to say in the beginning of my speech, I was trying to rush it through, but I make a point of my work schedule, including my self-care. This is something that's huge for people. Schedule it in. Like, I think a lot of people say, well, that's my personal life and this is work. And they tend to put off their personal, like things like yoga. But if you make that part of your work day, that's been super, super effective for a lot of, especially my techies that work like 12-hour days, right? They'll just keep working. And it's so much better for you to really just make that, if you have a mandatory 5, like to go back to what me and Ty were talking about, if these work companies are making it mandatory, they would do it. So you should do the same for yourself. It's helpful to do so. Also just a boundary, right? Of like, it's 30 minutes before I go to bed, I'm going to turn that off. And that's it, because there will always be another. And that's what I always tell clients, there will always be another email. You have to set the boundary.
I mean, I'm in such a better mindset during the day because I get up routinely. I swim a mile in the mornings routinely. And it's so relaxing because, you're in that zone and you're in that water, and it's really kind of, you kind of block everything out. Even though your mind is still thinking during that period of time, you just kind of get in that zone. And so it really is relaxing.
Yeah.
If I don't do it, if I miss it, it kind of stresses me out because now I'm missing it for the next 4 days because of this meeting. But it's I know I'm going to get back to it as soon as it's over.
So Ty, basically you're confirming that it makes a difference, right?
Oh, absolutely, absolutely.
Yeah. And when you skip it, you start to notice a shift, and so that's why it just has, especially in what we do. That's why I say I scheduled that beach time. The water is water is very symbolic for our emotional world. So water is a great thing to be around. Take a bath, take a nice hot shower, go sit by a body of water. It's a great way to feel invigorated and to fill our own cup. Nature is really important. Very, very important.
I'm wondering how watertight my laptop is. So during this meeting, the rest of me, I get in the bathtub. I'm not sure if that's okay or not, but think about it. Anyway, hey, Candace, a couple of people asked about a book, like self-help books, if you had any recommendation. And that's hard to do because there's so many self-help books out there. If you have a recommendation of something to read, even like, I don't know, on ego, Ectalt, but also I know Lara actually helps out organizations or corporations. I mean, you have Starbucks and I don't know, IBM and whatever that actually send their employees, set up times with you. I know that knowing you personally, but you also have your own company. So for people that wanted to maybe, privately get a hold of you, how would they do that?
Yeah, sure. I did have that on my original thing. I think that I will go ahead and get that information to Susan, maybe with the quality of life test and the things to look for in burnout, compassion fatigue, and secondary trauma. I'm going to send maybe a little informational packet along. I did have that at the end of my presentation, but I wanted to see your faces. So I will go ahead and have that. So if you could just look out for that would be great.
If I can announce it, it's the soulfuljourneycoaching.com. Is that correct?
Yes, the soulfuljourneycoaching.com. I'm Candace McAdams, so you can also look up my name and see me there too.
And we'll place that on the chat window too, Candace.
Yeah, let me put that there, actually. Let me go ahead and put the website and my contact information, just so you have that.
So I think we're probably about done, right? We have 2 minutes or we're done, right? Time-wise, everybody, since we had a different time zone. There's Dr. Yeah, who's that? That's Dr. Lynn. So Candace, thank you so much. Yes.
Thank you so much. Thanks for being here.
I know you don't see all the Q&A, but there's so many people that you've touched. The list just goes on and on and on about thank you. And what it does is it reminds us, even though we may have heard this before in some fashions, it reminds us to get back to ourselves.
Yeah.
And that right there for me is always a blessing. So thank you again for joining.
Yeah, thank you so much for having me. And I love that you just said that. If there's one person in this room that is inspired to come home to themselves, I've done something well here in this hour. So I really appreciate you spending time with me. And I really wish you a lot of luck on the rest of it. And just remember to take those mindful moments. You could start practicing this week when you get your little breaks just take a moment to come home to self. Okay. I wish you a lot of luck on the journey, guys. Thank you so much for having me.
Thank you.
Thank you, Candace.
Bye.
Very good. Oh, she was wonderful. I'm real excited to introduce our next speakers, as I've had the opportunity to work very closely with these two in the past. Our next speaker in our professional development session is a cardiac surgeon. He's associate professor at the University of Kansas School of Medicine here in Wichita, and is internationally recognized for the innovative practice and research in patient safety, high reliability,
It's 12 hours.
healthcare teamwork with active engagement of patients and families, and interpersonal professional education. His research utilizes social science methods with the social construction orientation to study just how healthcare can be intentionally transformed through collaborative approaches. In addition to his work in healthcare, Dr. Ulick has a lifelong interest in aviation, and he holds an airline transport pilot license and is a certified flight instructor. Please join me in welcoming Dr. Paul Ulig, and he's going to be talking to us moving from 1 star to 3 stars, the principles and processes available to any CV program.
Susan, thank you very much. And can y'all hear me okay? Wonderful. I am really honored to be part of this. And I did have the privilege of actually practicing with Susan for a number of years here in Wichita. And it's just been so fun to watch your career just rocket to way beyond 3 stars, Susan, and all the good that you and your colleagues are doing. And I'm honored to try to help with that today. I wanted to just take a minute about my own teaching philosophy. And that is, there would be one approach where, like, the teachers here and people are here and you're passing this information. And I it's not the way that I tend to think about it. And the other, when I teach with medical students, I call it the 3 blinks from now philosophy. They're going to blink once and they're going to be graduating, and they're going to blink another time, and they're going to be finishing their residency, and they're going to blink the 3rd time and they'll be giving this talk. And I love it that way. We are all colleagues. Any one of you could be giving this talk maybe today or maybe a few years from now, but this is about kind of shared learning. And so if you could think of it that way, that this is a little bit of some of our journey. It's been really interesting. Maybe some of those things will be useful to you. Maybe you'll be able to take those and make them like 10 times better. So that's kind of the way that I want to think about this. So I'm going to go ahead and share my screen here. And it's waking up, so I just wanted to make sure that you all can see that. Are you able to see that okay yet? If someone could give me verbal on that, that'd be great.
Yes, just show it to the viewing presenter view.
What's that?
Just show the presenter view.
Okay. Is it there yet?
Not yet.
Okay.
We just see your slides.
You can see them?
We just see the slides part.
Oh, you see the slide. Okay. That's all I want to show you. So I'll just talk away. I'd be happy to be behind the background. So let me just start the slideshow. So the title, as Susan said, is Moving from 1 star to 3 stars. And of course, that's referring to the STS database, principles and processes available to any CV surgery program. And I don't have anything to disclose regarding this, but many to thank. And for today, a ton of the gratitude goes to colleagues that I worked with when I was on the faculty at Dartmouth and directed the cardiac surgery program at Concord Hospital. Eric Riddell was a patient that we cared for, who then became just absolutely crucial member of our team as we went forward with many of the things that I'm going to describe today. Elise Kendall, one of several pharmacists there, Addie Camilio, a social worker who was really the heart and soul of many of the things that we're talking about. Jeff Brown, an extraordinary safety scientist who joined our team and just taught us so much. And here's a slightly younger version of me. And you see these smiles in all these people. Eric sadly passed away last year, and just so want to honor him and everything that we're talking about today. So I'm going to start by asking a question. I'm really interested in you thinking about something that you have personally learned how to do well and about how you learned how to do that. And what I'm showing you here is a couple little pieces of scrap steel that I stuck together with my little TIG welder as I'm learning how to weld. And if you look at it, it's actually not too bad a weld here, but you start looking, this is the little heat signature. You can see a really good welder, this would be smooth and even, but you see it kind of spreading out. I was getting really too hot as I was going here. Maybe some of you do woodworking and you're making a dovetail joint, or maybe you're learning how to plant a garden, or maybe you're growing a family, or you're learning how. A wonderful presentation just preceded this one. You're learning how to take care of yourself. I'm really interested in how people learn. And I wanted you just to think about something that really matters to you that you've learned how to do, and reflect about how you learned to do it. And I was giving a talk not terribly long ago about this, and I asked the audience to do that. And a person in the audience, the very front of the audience, delightful little lady who was probably in her later 80s, her hand shot up, and she was describing how she had learned how to knit. And this is what she said. She said, well, you just do something, you see how it turns out, you think about how you could do better, and you try again, and you just keep doing that. And it was so fun, and the audience just loved her, and I loved her description, because that's exactly how I've come to this middle point in welding. I just tried it, I looked at it, pondered how I could do it better, tried it again. And of course, you hear in this, PDSA cycles, all sorts of stuff. And I wanted to just show a little schematic that our research team calls the learning loop. There is some kind of work that you do, and then some type of observation. Doesn't have to be fancy, doesn't have to be measures or whatever, but some way. You're going to do it, you're going to look at it, you're going to ponder it, and you're going to think what you could do better, and then you're going to try it again. And this is what people do all the time. I'm a little kid and I'm going to touch this hot stove. Oh, I don't like that feeling. I'm never going to touch a hot stove again. And so over time, you see this growth of capabilities. And it really is this connection between action and reflection and change that produces this learning. And so I wanted to just hold that in mind, because we have a ton of learning like this at an individual level in healthcare. In fact, that's how mastery is achieved. You all probably know those little things that have kind of caught on in the last few years about mastery, 10,000 hours of practice. And what mastery really is acquiring rich tacit knowledge of something. Tacit knowledge is embodied knowledge. It's something that you can't go look in a book about. It's something that you acquire over time from doing things. You can't pass it along exactly. You can guide people in the acquisition of it, but it's something that you have to learn. I could read everything that there could be published about playing a violin, and I would not be able to play the violin until I went through those many, many hours of practicing and learning and thinking about it and trying it and doing it again. And so our little research team came up with this little thing that we have hovering over this individual person, this little field that shows this tacit knowledge that this expert violinist has acquired over time. And so the question is, how do teams learn? We all work in collaboration with others. I am of absolutely no use as a cardiac surgeon without the perfusionist, without the scrub tech, or scrub nurse, without the circulating nurse, without the anesthesiologist, and beyond that, without the ICU and post-op floor and everything else. We have to work together. And yet, how do teams acquire this same embodied tacit knowledge that individuals are learning all the time? And so, in order to think about that, I have just a little, thought situation for you, and it's a serious one. And I hope that it won't be too emotionally painful, because some may have gone through this, especially with the year that we've had. But I'd like you to imagine that you're in a hospital room, but not as a healthcare provider, but as a kind of a family member of someone that you love. As one of our nurse practitioners said, someone who is your everything. And it's the two of you in that room. You have that person that you love, and you are there, and something goes terribly wrong. And fortunately, in this hospital, you've been taught about how you can activate a rapid response or a cardiac arrest. And you see the button on the wall, and you push it. And in just a few minutes, you hear outside your door 3 different teams that have come to respond. And your only job in the world right now is to open that door and choose which team you want to come into the room. And I'm going to tell you about these teams. All of the teams have extraordinary individuals who have achieved mastery in their profession. Each team has 5 people. Each team has a physician, has a critical care nurse, has a respiratory therapist, has a pharmacist, and has a chaplain. And they're all just, impeccably individually trained. But I want to tell you about the difference in the teams. The first team, those 5, when they came in this morning, they found their counterpart. For example, the physician found the physician, and they took the code beeper from that person. The nurse took the code beeper from his colleague, and the pharmacist, and so forth. And the alert just came, and the beeper went off, and they have arrived outside your door ready to care for your loved one. That's team A. Team B, they've shown up, and they are also wonderfully individually trained. But in this particular case, this team, they started working together a week ago. In fact, they're going to work together for an entire month. Whereas Team A, tomorrow's team is going to be a totally different team. Team B, tomorrow's team is going to be the same people. And they've been together for 7 days, and it turns out they've had 1 cardiac arrest each day. So they've done this 7 times, and they're here ready to offer their services. Team C, exactly the same kind of situation in that they started a week ago, but here's the difference with that. When they showed up a week ago and picked up their beepers, they didn't just go about their ordinary work. They met in the simulation lab. The previous team signed out to them and talked about all of the arrests that they had been caring for the past month in the hospital. They prioritized those. They had organized a training program, and Team C went through basically rehearsals of all the types of cardiac arrests that the previous team had cared for. They also now have had 7 cardiac arrests over this past week, But after each one, they went back, they debriefed it together. They worked out in simulation all the things that they would do differently, and they are now outside your room. And so the question is, at this one most crucial moment in your loved one's life, which team would you like to have come in the door? Are you going to invite in Team A, Team B, or Team C? And the question is it a hard question? And I would say it's probably pretty easy to decide which team you want in. I would certainly want Team C to come in. And the question is why? And the answer is because there have been conditions that have been created that Team C has not only their individual skills, but also has kind of the collective learning that is possible if conditions are right for them. So what I'm going to suggest, and kind of the basis of a lot of the research and the talk that I'm giving today, is that team level learning requires an infrastructure that is missing in most clinical environments. We've got plenty of workflow, in almost every place where I've been. But in terms of how that workflow is structured, what the team is like, whether today's team is tomorrow's team, and then whether there is any kind of structure for that team together as a team to say, hey, how do we do? Let's think about that. Let's see what we can change, and then let's modify this learning loop. This infrastructure for team level learning is kind of what we're talking about today. And I'm going to suggest to you it's something that you can build, and that if you do build it, you're probably going to be astonished at the improvement in your team outcomes that happen as you do so. So now I'm going to go back to Concord. This is this wonderful award that we received in 2002, so it's almost 20 years ago now. We received one of the inaugural Eisenberg Patient Safety Awards from the Joint Commission and the National Quality Forum for our work implementing this collaborative care model in Concord. So it was a community cardiac surgery program. I was on the faculty at Dartmouth, but outposted to the state capital of Concord to run this program. And we began asking ourselves, how could we make a question that we heard regularly go away? And that question was from our patients and families. Don't you people talk to each other? And of course, we were asked that question because it seemed to people like maybe we didn't. Of course, we did. We talked to each other every day and everywhere that we possibly could. And yet the net effect of it, because of the individual way that we worked, patients would say, well, you say maybe my surgery is going to be today, but the nurse said probably that's not possible because of this dissection coming in or something. And then they said, and all these, so everybody's kind of doing their best to give information to the patient family, but it's not really, aligned always. And so we tried to think, how could we make this better? And we did a series of things to try to improve that. And as we did, our outcomes started changing. This is our expected, which is this line, and this is our observed mortality over these series of cases. And we were really quite a good program. We were embedded in something that many of you know as the Northern New England Cardiovascular Disease Study Group. The program had been created by Dartmouth, and we were achieving what at that time were among the best outcomes in the country, exactly doing what was expected for us. And yet, as we made these changes in how we worked, this little triangle right here, this is living people that would have died if we had done what we were doing. And so I am so sorry for the talking head part of this. When I give these talks, I so much prefer to be interactive with you all. And I don't know quite how to do that, but we'll have a chance here in a little bit to maybe do that more. But if you're getting bored with any of this, I apologize for that. But just stick with me because I think it will be sort of interesting, but I just wanted to tell you that. So we got this award and we wrote this article, with the help of the Joint Commission folks and everything. And we were emphasizing our collaborative rounds, the different things that we were doing. And as people tried to copy those things, they did not usually get the same outcomes that we did. And so the question became like, okay, what are we missing? And so this really extraordinary thing happened is that we got some funding from the information system at the Mass General, information system department at the Mass General Hospital to study our collaborative care. And we created something that we called the Way Cool X team. It was a social science research team. Here's some of us, and here we are working and trying to understand. We observed, interviewed, and videotaped care teams working in traditional ways, and then across the spectrum of people working toward this collaborative care model. A safety scientist, a cognitive engineer, knowledge manager, you can see all the different folks that we were able to bring together. And from that came kind of a set of insights, a set of data. Here's an example of some of the things that our program was able to do. We were in this northern New England cardiovascular disease group with other hospitals across Maine, New Hampshire, Vermont, and some in northern Massachusetts. And all of us were trying to do some of the similar things. Like at that time, we were really trying to reduce our time to extubation postoperatively. Here are the other hospitals in that consortium. The blue is our collaborative program. And you can see that there was a reduction in time over this to extubation among this group. But here's what our little program was able to do. It was just like extraordinary. We kind of went to from pretty much where everybody was to pretty much extubating everybody in the operating room. It wasn't that we were any better than these people. It was that we had a collaborative infrastructure that they didn't have. Every week we sat down together and thought about how are we doing, what are our outcomes, how could we do even better. And in that context, we were able to do things that other programs just weren't able to do. And it also was exciting. It felt better. Here's a survey that one of our nursing graduate students did about quality of work life, sense of common purpose, personal collective power, active listening, responsibility for leadership. And you can see this shift compared to the traditional. And so I sometimes enjoy thinking about things outside of healthcare. And one of the things that I loved when I was a boy was my grandma. And she loved to make pies and different things. And so I went home as a college student and I watched her make a pie crust. And this is my handwriting. I carefully made a little recipe card watching my grandma. I don't know how many of you make pies or pie crusts, but if you look at this, you can see that this 19 or 20-year-old kid missed a whole lot. You take some flour, you take some salt, you take some Crisco, you take a little water, you combine them, and you bake them. And it's in this combine, where the magic is of that pie crust. And I was like totally oblivious to that. And so that saying easy as pie has always been really interesting to me. And our collaborative care model, it was kind of the same. What we were really doing, we absolutely did not get it right in this, what we were writing. It took the multiple insights of this research team to point to what was actually shifting in our environment. And one of the most interesting moments of that insight was there had been a new heart surgery program created at by the Mass General in a little town of Salem, Massachusetts. They got a certificate of need, started a new program. They actually physically built a new, all the new operating rooms and the ICU and so forth, and they hired all the staff. And they got out of sync between the construction and the hiring. And they had hired everybody, but they didn't have the building open. And I can't remember how it exactly happened, but their entire team came up and worked side by side with us in Concord, about an hour north of Boston, for about almost 2 months. And then their program opened and they went off and started their new program, and we sort of lost touch with them. And now 2 years later, we have our research team and we're trying to think through, where can we go to see people who are beginning to work in this different collaborative way? And we suddenly went, oh, what about those people from Salem? And so we called them up and they said, oh, we would love to have you come. And we started looking at their outcomes and talking with them about that. And they had blown us away in terms of outcomes. They had this brand new program. By the time we visited, they'd done 322 cases in their first year and a half. Half of those cases were ordinary CABG, but half were more complex cases. CABG valve, double valve, redos, and they had 15 circuit arrest arch or MI arch replacements in that group. And they had one death, 0.3% all case mortality in this brand new program. So we were so excited to go see them, and it's just like incredible. And Tom Vandersholm was the surgeon, and I was visiting with Tom when we first arrived, and I said, Tom, we cannot wait to see your collaborative rounds and how you're achieving these wonderful outcomes. And he looked at me and he said, our collaborative rounds? I said, yeah, I think you're doing that, aren't you? He goes, yeah, we're doing it. But Paul, do you think that's the reason our outcomes are so good? And I said, well, I thought so. And he said, well, yeah, we do it. But Paul, it's all the other things that you taught us. It's the weekly team meetings and looking at our data and getting everybody together, building this cohesion among everyone. It was just like, oh my gosh. It was just like all these things that my grandma was doing that I did not see. And I was the one doing them. And so the research team took it forward from there. And so there's kind of a model now. We call it the social field model of collaborative care. And so here's a little illustration of some of the things that we think that we've learned. That really high performing clinical environments, and we talk about teams, but it's really the environment itself. That grows over time, almost like a garden. If you set a set of preconditions in place, and then people start to interact and reflect, and team level learning starts taking place, and these capabilities of reliability and resilience start to grow. Now, there are certainly some individual skills and some individual skills for teamwork that can be taught, things like team steps and so forth. But our research suggests that these really high level skills of truly having shared mental models, of truly developing trust and psychological safety, of having a shared capacity to act and monitor and predict and respond, and then the highest level of all, the shared capacity to break the rules, to create new rules in unique situations, that all of these are really team level capabilities, collective capabilities that grow. And so we coined a term, we call it social fields. And we're using the same little thing here that we had over an individual, but now we've got over a group of people. The living collective intelligence of a care team, consisting of memories, wisdom, emotions, patterns of interaction, arising over time from shared experiences, reflective conversations, and team learning. So mastery at this team level, it's still the same. It's rich tacit knowledge, but it's of the team itself. And this is the thing that is, we think, missing in most environments and is so possible to create in your own environment. And so we use this little phrase, where to put the wrench to create these things. And these are the things that we kind of boiled it down to, is organizing for teamwork. And I'm going to take just a minute to talk about each one of these very briefly. So organizing for teamwork is like, you can have an environment, let's say that you've got a great big ICU, and maybe there's trauma, neuro, and heart, general surgery, whatever. And maybe you've got a huge post-op floor, and so you've got all these different nurses. They have different skill sets, different interests. You've got a social worker who tries to help with this, and you've got this pharmacist or that. And in many environments where I've worked, it's sort of like a random pairing. You get wherever there's a bed available, you get that nurse. Whereas in Salem, for example, they built one unit. It was an acuity adaptable unit. They changed it from an ICU to a floor, depending on what the patient needed. And they had the same little team of people caring for every patient that the heart program cared for. And they were ICU nurses today, but it was the same social worker, same pharmacist. So they took this potentially a great big random universe and they shrunk it down into smaller, more relational groups. It wasn't always the same people every day, but it would be one of these 15 nurses or one of these 2 pharmacists or one of these 2 social workers, so that people were actually able to get to know each other and understand the patterns and the interactions and capabilities. So this we've found it to be like huge. Also the leadership styles. Many of us were trained in kind of a command and control kind of leadership. Heart surgery lends itself to times when that is required. And yet for many of these other things, a much more collaborative kind of leadership, not just one leader, but multiple leaders across professions with that leadership flowing to whatever the expertise need is at the moment. It's a very different kind of thing. It's about giving away one kind of power to gain a different kind of effectiveness, a much better kind of effectiveness. Weekly team meetings. Now, none of us like to go to meetings, but actually in the places where we have created these sort of system meetings, those become some of the most happy times of the day. Again, thinking back to the earlier talk, opportunities to actually connect and know the people that we're working with in a different way. And it's much less structured. It is a time together to connect, to reflect, to think about change. We found that it's better to not have the like the designated leaders like the surgeon or the nursing manager running those meetings. It's better to pick somebody like at University of Cincinnati when we were creating this kind of replicating this work. It was our chaplain who was just like natural at running this. In several places, it's been nurse practitioners who are awesome at running it. In one place, it was a physical therapy assistant, and that was at Wesley. I'll talk about that in just a minute. A daily collaborative rounds process. It doesn't necessarily need to be collaborative, but some sort of a routine for the daily care. Now, if you're in the operating room, that's one kind of daily pattern. If you're on the floor, it's a different daily pattern. If you're in the ICU, but something that everybody can know and count on in terms of the time and what their responsibilities are and where everyone will be. So often it's like, well, whenever the surgeon comes, I guess I'll know what that person wants to do. So actually changing so that that becomes consistent and predictable. Active engagement of patients and families. Something that we call down and in data. So like we all live in data worlds, but it's usually up and out. It's like at the end of the day, we turned this data in and went to the quality department and we never heard about it except that 6 months later, they got mad at us about how come our costs were too high or whatever. This is like, what are we really interested in? And can somebody bring that to us in real time so we can sit down this week and talk about it? It's a really kind of fun thing called glitch process. And then I'm going to come back up to both of these in just a minute here. But then intentional, strong connections with the large organization. Because if you build this frontline thing like this, you're going to get out ahead of your environment. So what this is really about is setting a stage for ongoing cycles of action and reflection. So here is the team at Wesley that I'm going to talk about where we basically replicated what we did at Concord. And here is different people, pharmacist, here's the physical therapy assistant, former Wichita police officer who had a midlife change of heart and career and took his schooling in physical therapy assistant, but he had this natural affinity and respect of everyone, and he became kind of our rounds leader. Many other different people, nurse practitioner, a couple of the floor nurses, cardiac rehab, nurse educator. And here are those same folks now in the weekly meeting. This meeting doesn't exist in most places where I go. This does, kind of, but this doesn't. And so they're constantly moving from, what are we going to try this week? Let's try it. Okay, how'd that go? Okay, let's change this. Let's do this. So these cycles of action reflection set this up. And then this down in data informs things we're curious about. And it's available in near real time. And then this little thing that we call glitch, gathering little insights that can help. It's a pause every day at some point in the care process to sort of say, hey, Mr. Smith, hey, team, how did everything go today? Was there anything at all in our systems and processes that didn't support us the way that we wanted? Here are some examples of glitches. Medication orders being faxed to food service instead of the pharmacy. Okay, let's in our meeting, let's talk about it. Let's move the speed dial button on the phone so they're at the opposite corners because they were right next to each other. People were mistakenly hidden. The light in the shower is dim. Okay, we put a brighter light bulb in the shower. We gave one patient's insulin to a different patient's. Why was that? Well, the printer label was broken, the test was mislabeled. We've ordered a backup printer. Cool. Blah, blah, blah. It goes on and on. When we put a brighter light in the shower, we could see there was mold there. Oh my, new cleaning routines in the shower. So you can see how every day at every interaction, pausing and asking about glitches and then bringing them back to the team meeting, which we never had before. And you can see how all these little broken things that we were living with start getting better. And then other things. Here's the team at Wesley trying to figure out how can we include patients and families and keep a record of what we do. And so let's try this whiteboard. So it's not like the whiteboards that say your doctor is blah, blah, blah. This is like on Sunday, we're on epi, norenone, and amio. We're going to stop the CRRT and remove the catheter. Oh, by the way, he wants an egg McMuffin. He's eating really well. We got him on some cefepime. Platelets are okay. We need to watch it because we're on heparin. Stools are better. Yay, activity. So we would create this in the rounds process with the patient and family. Routinely, we would have family members, when the next family member arrives, walking over to this board saying, okay, they're going to be weaning this norenone stuff off, and they're going to stop this kidney stuff. This became, and then tomorrow morning, that would still be on the wall, and we would go back and we would take up from there as we were doing the rounds. And then this would help me remember this was Kathleen, and the patient's name was Ron, and he's an archer. So there's just all these little things that we do. And then we developed a little safety checklist, again, in ordinary language. What are we doing for blood clot prevention? What are we doing for blood sugar control? Lines and tubes, skin and wounds, nutrition, labs and cultures, what medicines? And we would go through this every day with the entire team, with the patient and family. And tons of stuff, that we thought we were doing, we were missing. So this is kind of show things. So basically the journey at Wesley started in about 2009. I'd come back to Wichita by then, and I was doing some quality stuff at Wesley, which is one of the HCA hospitals here in Wichita, a much larger hospital, 450 beds, at that time around 250 hearts a year, with about 6 surgeons. And the chief medical officer came to me and she said, oh my God, Paul, I just look at our STS data. We've been putting, information into this thing for years, but nobody's ever looked at it. I said, okay, well, that's not unusual. She said, yeah, but you know what our percentile is for our composite quality score for ChemEng? We're 8th percentile in the country. 8th, like bad. She goes, we thought we were like maybe 80th. And she goes, do you know how to fix this? And I said, well, yeah, I think I do actually, but it involves a lot of folks and it should be kind of fun. She said, well, what would it take? And I said, well, why don't I become the medical director and let's start doing it. So we just went to the same patterns that we worked before, organizing for teamwork. So at that time, patients were going to a large SICU. They were going out to the post-op floor, wherever anybody had a bed. So we created some specialized units, a CVICU in the ICU and a PCU out on the floor. We developed specific cohorts of nurses who were interested in heart patients. We provided special training for them. Every one of those was a relational challenge. Oh, I don't want to just do hearts. I like to do trauma, blah, blah, blah. All these things, everyone. I was the new medical director. There was a nursing director I knew and encouraged her to sort of help with this. We started weekly team meetings. Well, we had no time for that. There's no way we could possibly do that. We started this daily collaborative rounds. Well, you've got to be crazy to do this. We went to the quality department, began to ask them about some of this down and data. We talked about doing the glitch process. No way am I going to talk about mistakes or errors in front of patients and families. Are you crazy? Every one of these was like impossible. So here's kind of where we started, and I just want to go through this. So we had great individual knowledge and capabilities. And I'm going to skip down here. We had a fair amount of active engagements of patients and families, kind of the normal amount that you might get. We had really not very well organized stuff. We were in an ICU, that there were some people that knew hearts. We did have some pretty good leadership, but we didn't have any of these things. And we had some support from the organization. So I put our team level capabilities about here. And this is what we were achieving, 1 star. And so over the next several years, we started making these changes. We started getting the CVICU up, and then eventually we got the PCU up. We started working on the leadership. We were able successfully to get the weekly meetings going. It took a while, but we were able to get the collaborative rounds going. The quality department really kicked in and started giving us the data that we were asking for in these rounds. The glitch process was a bridge too far at first for everybody. But I stayed really close touch with the people that were creating and authorizing these environments and all the different leaders. And because of the rounds process, our patient family engagement started to move, and our team level started to move, and our STS numbers started to move. And then we continued that. We got the PCU up, all these things steadily improving, and we're solid 2 stars now. And then we continued. Now we had special training programs for the nurses. The weekly team meetings have really kicked in now. We made them over lunchtime. People loved coming to them. We started distributing the meetings and minutes and so forth. And everything is really coming well. And we're just on the edge of 3 stars. And then at that point, a really interesting change happened. And that was that one of the surgical groups in town decided that they wanted their own person to be the medical director of the unit. And they threatened to take their cases away from the hospital. And so the CEO called me in and said, gosh, you've been doing great work, but we're going to have to make a change here. And it was so socially destabilizing for all the work that we'd done. We still had the units and the training in place, but people were unsure about the leadership. People started trying to figure out if they should go to these weekly meetings. The surgeons had been going to an M&M that we created, but they had none of them had been going to the weekly meeting. I was the only surgeon who began doing that. The rounds continued for a while with a nurse practitioner that we had hired, but the other surgeons didn't think that was probably the greatest idea. And so we started losing these things, and the outcomes fell back significantly. And then under the new leadership, they expanded the nurse practitioner program that we had started, hired several additional nurse practitioners. And so basically these same goals were being achieved through the nurse practitioners who were now providing a different kind of leadership. The weekly meetings continued for a long time, but less participation. The daily rounds was now primarily nurse practitioner led, and the collaborative part of it began to diminish. But they were nurses. They were doing a great job of including patients and families. And everything started improving significantly. They developed some wonderful kind of data collection tools that standardized the way that they were working with the abstractors to be sure that they were getting everything exactly right that was needed. And bang, they achieved a 3-star. I mean, it was beautiful. And so over the next, but it didn't sustain. These nurse practitioners are basically now the glue that holds the system together. They have 3 and they're getting ready to hire a 4th, but they're getting exhausted. And of course, this last year was a terrible year with with ECMO, and they're just, working like crazy. And so, whereas we were initially kind of building a structural glue, they showed that a nurse practitioner glue could work really well as long as you could sustain them. Also, they had a lot of leadership changes. And each leadership change, there's basically new orientation. So losing some of that connection, losing some of the leadership. And so they're hovering now. If you go to the current thing, you will see it as a 2-star program. But they said they just got a 3-star that hasn't been published yet. So throughout all of that, almost nothing changed in the operating room except the use of mammary arteries. And that was a slow thing. I'll show a little bit of data. I love this in one hospital where they had a little data closet and they put data on it. But so here's where Wesley started. 8% overall composite quality score, 15th percentile for inpatient mortality. All of the process measures just really, they weren't bad, but they were bad compared to everybody else. The STS stuff is clearly a curve, and it's for cabbage, it's 98% certainty that you are distinguished from everyone else. And so there were a few things, the outcomes that weren't so terrible, but this is where we started. And then here, just like to show, as we began doing this and focusing on these things and looking, so here were all the fallouts that just went away on discharge beta blocker, discharge statin, discharge aspirin. Eventually, we even quit reporting on these because they were just constantly 100%. And here's the journey of the percentile. Here's the setback when there was a leadership change, and then here's the setback. Actually, this was our kind of journey, and then here's where the leadership change happened, and then they achieved this. Kind of long term, it was interesting. Almost all these changes are relational accomplishments. We were able to get the team that managed beta blockers together and working pretty well pretty early on. But the things that required a surgeon to actually change practice, it took much longer. We had to actually start the morbidity and mortality conference. Gradually, they would let the anesthesiologist come, then they would gradually let perfusionists come, and finally they would let nurses come. And by about this time, everything was really going well. But it took longer. So just a few lessons. It is inevitable that you will be uncomfortable if you open yourself to learning. We all kind of we've worked hard to get to the place where we are and the patterns that we know. This wonderful quote from Paul Batalden and Don Berwick: every system is perfectly designed to get the result it gets. If you want a different outcome, you need to change something. And that change process is very much a relational accomplishment. One of the things that I found really helpful is always assume positive intent. This is a beautiful phrase that I learned from a group of folks in an interprofessional clinic in Omaha. And this is kind of my little corollary, which is 90% of the time you will be right. People really they were trying to do the right thing. And the other 10%, you will still do better that way. So that's good. So I found this to be extremely helpful rather than get mad at people just going, I know you're trying to do the right thing. I also think there's a lot of efforts to mandate collaboration, and we're going to roll this out in our unit or whatever. People have to choose collaboration for themselves, but you can certainly invite them in. So these really function through invitation. This phrase I just love: if you want to predict the future, look at what you're doing right now. So if you want to know what your outcomes are going to be, if you are doing the same thing that basically you were doing, you're going to have the same outcomes. But if you start doing something different, you're going to get something different. And then this is a friend of mine who has been just a mentor and coach the whole time. She says, I will do something, and I'll say, oh man, I just created a nightmare. And she'll go, so Paul, what did you think would happen when you did this or said that? I go, oh yeah, I should have seen that. So, these things are kind of predictable. If you're interested in these things, there's a website a group of us have put together. It's called createmettercare.org. And under a little tab called Helpful Resources, you can pull down a little book that outlines kind of how to do these things, and then also some things that we call a toolkit, a little called activation inventory and a resource inventory, and a little thing we call Team Finder. Here's an example of the resource inventory. Resources are like these capabilities that you've created among your team. Here's one, knowing what to do and what to expect to do. This is really from our research, from these high-performing teams. We have a collective intelligence from our experience working together. We've developed a deep knowledge of the situations we usually encounter. This can kind of go, you can say, okay, read this, team, and does this make sense to us here? And can we do this? And does this matter to us? And from when people begin, they'll kind of say like, that's not what we're like, and it would be impossible for us, and really it's not relevant to us. And then further down the journey, they'll go like, yeah, actually this makes total sense, and it's not totally in our control. And so you can watch the growth of these capabilities using this inventory. And then this is about these preconditions. For example, this is this organizing for teamwork. The care environment can be intentionally structured, staff and management teamwork in mind. This means organizing around a particular kind of care and establishing cohorts of people across professions. We're able to work together as a stable team with consistency and familiarity. Now, when you first hear this, you may go, "Oh, it's impossible," but it's not. And so this just offers a way for you to, kind of rate yourself. And then if you rate low, you can go back, and each one of these is actually an action step that you could take. Our system is organized so that patients are always cared for in specific areas based on their needs and our skills, not randomly set where space is available. I'm not saying these are easy to do, but every one of these can be done and has been done. And just this wonderful little closing phrase that if one program can do it, you can do it too. So that was my talk for you. So I'll stop sharing.
Thank you very much, Dr. Udig. That was wonderful. I had great memories sharing that program with you when you started that up. And just the collaborative meetings and stuff that we'd have lunch together with all the different entities that helped with the patients is very nice to be able to see what everybody was doing to attribute to the patients and all. I think some of the things that the best parts of it, I think, was the collaborative information, the rounds that we did in the ICU, and the patients and the family members all participated in this. I thought that was so special, very appreciative. Whenever we could try to make the rounds, they loved that. I'd never seen that before at any other places I've traveled to.
And we loved having you, and the patients loved having you there too.
I know one thing also that we did in the operating room, when they wheeled the patient into the room, you had everybody introduce themselves and kind of tell what they were going to be doing in the room and how many years that they have been doing it. So I remember one time we gathered up all the years. I think we had 130 years of service in that room, and that patient goes, "Whoa," that was really fun days. Yeah.
There was one airline pilot, we did that, and he said, "Hey, Doc, really great pre-flight briefing." And there was another guy that was a coach. He goes, "Hey, Doc, great pregame." So it was kind of fun. But it was kind of taking the briefing to a little higher level of involving the patient family and or the patient in this case. And like all these things, it was weird for people at first, and then it became much more normal.
Absolutely, yeah. And even the glitch sheet that we did, that was fun. I think now a lot of perfusion programs use the failure mode effect analysis, the FEMAs, to fix their problems before they happen. And this glitch sheet was kind of something similar to that also, but just writing down the things that happened today that just made your day not go as smoothly as you wanted, but it really, really helped move the day and the next procedure more smoothly, I think. But
the glitch is tied to that meeting. If you don't have the meeting with everybody there, then the glitch, what it's going to go to some manager and be one more sticky on his or her computer or whatever. Whereas if you have everybody there, you can talk about it and fix it right on the spot. There's a researcher who talked about type 1 and type 2 problem solving. Her name's Anita Tucker, and she's at Harvard Business School now. And she embedded with nurses and watched them solve problems. And type 1 problem solving, you basically push the problem down the road. and type 2, you fix it at a root level. And so this is really an infrastructure for that kind of root level problem solving in real time among a group of people. And again, that infrastructure, you can build it. And when you do, your life gets amazingly better. So happy to answer any questions or whatever, and honored to be here with you all. David Norris, I saw your name pop up here. It's delightful to see you. So.
Dr. Uling, terrific lecture, and we wish we had one of you in every one of our institutions.
You do probably, actually.
We do. We have to identify them or do, what are they calling now? Some reprogramming, I guess. But is there your data showing better medical care, the statistics, is that shared with the AMA? And is there any way to kind of push that agenda into the residency programs or to medical schools to try to spread the word that if we can instill this as a root within the training, that perhaps more individuals might practice that once they're out and being leaders within their own teams?
Well, it's really an interesting, I've spent 20 years trying to build these environments, and that includes education and so forth. And there's definitely receptivity and interest. Last several years till COVID, I was working for the ACGME doing site visits and so forth related to residency programs, and I just love that. And even so, almost every one of these environments that we built flourished, produced extraordinary outcomes, and usually doesn't exist in the same way anymore. And the loss of that was really painful for me at first. And then I began to understand differently. We've done an extraordinary job as a society and as health professions of standardizing around an old model. And it's in our payment processes, our education processes, even our research processes, as well as our practice processes. And so you painstakingly move a practice out, but all these other things will snap everything back to where it was, how our organizations function, our expectations of leadership, all these things. And so those of us who do this work have become at peace with the fact that we will probably have short-term successes for a while, and that it's almost going to be like a field shift, that the education will change, the practice will change, the research will change, the payment will change, and then suddenly pop, will be in this, what some of us call the second curve of healthcare, this exciting new paradigm. Many of us are still in curve one, and it's a time of sadness and loss, because we know that these ways are no longer meeting the needs. We've devoted our lives to them. But an increasing number of us have moved beyond that, done that grieving, let it go, and are now actively engaged in building these new ways of working. And it's like, the birth of the new. It is thrilling. Your skin will tingle when you are with people that are working in these ways. If anybody's interested, I'd be delighted to visit more. I know you all are doing a great job of staying right on time. Thank you for the privilege of sharing these things here. So.
Are medical societies as receptive to having talks like this? It's probably society specific based on my experience, but what is your receptiveness there?
It's actually, there is a receptivity. When I first started doing this 20 years ago, there would maybe be 5% of doctors would find this really interesting, and they'd come up and talk to me afterwards. It's now 35%. It's not a majority, but it is a significant minority, and there is definitely a shift. And we're expanding this collaborative approach now outside of cardiac surgery. I've had the privilege of working most recently with several internal medicine resident teams in San Antonio and other places in Michigan. And so the approaches can be transported outside of cardiac surgery. It's this creating team learning. So, but thank you for asking these questions.
Quint Studer has a book out called The Busy Leader. He's written about 5 books, and he basically uses it in the hospital setting. He used that same philosophy for years. Now he's expanded into communities, into businesses, to every part of he's found that, these programs like this not only thrive, but they basically bring everybody together in a collaborative world. And, you know, they can iron out problems when they have them much easier by doing it this way than they do others. It's a book I think we're using with our program now called The Busy Leader with Quint Studer. I don't know if you're familiar with that. He's actually from the...
I'm not familiar specifically with that book, and I appreciate knowing that. Thank you for that.
Thank you very much, Dr. Ulig, and your leadership in this role. Appreciate it. Thank you for joining us.
Privilege, and thanks for what you all do every day for every patient, every team. Thank you.
Thank you.
Bye-bye.
Bye-bye. I want to remind everybody about the visual exhibits, virtual exhibits from 2 to 5 today. If you want to log into those throughout the afternoon.
It's 13 hours.
And our next speaker is a practicing anesthesiologist who is dedicated to improving the business intelligence of all healthcare providers. When he's non-clinical, he serves as a consultant and educator, helping practices survive and thrive. He's completed the medical school at the University of Kansas School of Medicine and anesthesia residence and fellowship in cardiovascular anesthesia at Vanderbilt University. He was always interested in the business side of the healthcare and medical practices and has spent several years studying those fields. He earned an MBA after he realized that he was not adequately prepared to operate a business. He shares his knowledge via writing, teaching, speaking, and his podcasts, The Financially Intelligent Physician with David Norris, which is available not only on Apple Podcasts, but also Google Play, Spotify, and Pandora. His first book, which is The Financially Intelligent Physician, What They Didn't Teach You in Medical School, was published in 2016. And his second book, Great Care, Every Patient, A Physician's Guide to Process Improvement, was released in July 2020. Please join with me in welcoming Dr. David Norris, presenting Team Burnout and Symptoms and Treatments, and following up on the Implementing Change talk also. Thank you, Dr. Norris.
Well, thank you very much, Susan. It's great to be back. Let me share that there. There we go. All right. You can see my slides, right, Susan? Perfect. All righty. Well, let's go ahead and get started. Today, this first talk is going to be a little bit about burnout. And there's things I've learned about burnout over the years in my own life, personally, professionally, as well as working with others. And now, burnout is becoming more of a problem, and I think it's something that we're all beginning to talk about. Recently, Deloitte did a study of 1,000 respondents, and they said about 77% of their respondents experience burnout at some point in their current job, and 91% said that it was the unmanageable stress or frustration that would impact the quality of their work, and 30% said burnout negatively impacted their personal relationships. So they were bringing that stuff from home, from work, and bringing it home. Even those who were very passionate about their jobs still felt stressed at work, according to the survey, with 64% saying they were frequently stressed at work. And I think I see this a lot when I work with physicians, nurses, other healthcare providers. They're feeling the same thing. They may love their job or they may love what they're doing, but they still feel the pressure and the stress. The same survey found that nearly 70% of professionals felt that their employers weren't really doing enough to prevent or alleviate burnout. I have my own thoughts on that I'll share later. And then 25% said that they didn't use all their vacation on a timely basis, probably due to the fact that they felt they had so much to do that if they leave and come back, they just have more work that's piled on, and it just is a never-ending cycle. And then many felt that there was not enough recognition or support from their leadership in their organizations. So, what are the top causes of burnout? According to that survey, job expectations that are unclear, working too many hours, workplaces, dynamics that are dysfunctional in nature, social support that's lacking, never taking a vacation. They feel as if they have a lack of control over their work or work area or their work product. And there's a lack of workplace communication. And I think that the last two are real important. As we face, particularly with professionals who kind of do what we do every day. And really all of these, I think, boil down to poor leadership at the top, but I'm not going to get on that soapbox today. So organizations can get burned out as well. And if you're in an organization and, you're feeling burned out, you might not be the only one, because some signs of organizational burnout is the team's more aggressive towards each other. They begin to fight more with each other. You got more people are using sick days just because they don't want to come in and deal with everybody else or the team. There's a lack of vision for the future. They feel like there's a sense amongst the team like this is never going to get better. The status quo is what it is, and there's too much inertia to affect change and improve things. And people become inflexible and they don't want to change. And they don't want to change processes, or they don't want to change procedures. The group's not as functioning as well as it used to. Maybe you're firing on all cylinders, and now it doesn't feel like that. And then there's an isolation. It becomes kind of an us versus them. You may have these little factions that occur within the organization or within the groups. And, I see this in healthcare. It's like, oh, it's the OR, or it's anesthesia, or it's internal medicine, or cardiology didn't do that, or it's the unit team. And they all begin to kind of bicker rather than coming together and trying to do what's best for the patient. And when you begin to see signs like that, you may be facing organizational burnout. Now, why is burnout important? Because when you're burned out, you can't lead. Trying to lead when you yourself are experiencing burnout is like pouring gasoline on the flames. You hurt not only yourself, you're going to hurt those you work and lead with, and then you can also hurt your organization and the patients. So why can't we lead when we burned out? Well, because we are social creatures and we pick up social cues. So if you're working with a team, or you're a team leader, or you're a member of the team, your teammates are going to pick up on your stress. They're going to pick up on your fatigue. And it's going to affect their morale, performance, and quality. And, you got to lead not only others, but first you really need to lead yourself. And the problem with burnout is it's a slow process, and its symptoms are visible if you know what to look for. And if you catch it early enough, you can kind of try and prevent it. But burnout can be very slow and insidious, if you will. So I'm going to go over some symptoms. And, these by themselves are not indicative of burnout, but as they pile on top of each other, one on the other, they can become more of a constellation of burnout will begin to reveal itself for you. So the first symptom is you just go through the motions, okay? You don't really enjoy what you do at work, and you just kind of show up to collect the paycheck, and or you may quickly forget the patient's name, their complaints, problem lists, or other reasons why they're there to see you. You just kind of putting one foot in front of the other just to go through the motions. Symptom number 2 would be the engagement interaction of your team is low, particularly with you. If you feel that others are not engaging with you, it could be that the staff avoids you, or they don't engage with you like they used to. It's probably not them, but you, if it's happening with more than one individual. If your nurses don't really want to come talk to you as a physician, or they don't bring you the problems, or people are afraid to approach, the problem might be more you than them. And that's pretty good clue as to you may be facing some burnout. A touch of grumpiness, aloofness, or simple apathy that you've displayed and that they've picked up on over time. They'll just say, okay, he's grumpy or aloof, and we don't want to mess with it because we don't want to catch it, if you will. And you can, when you begin to feel others behave differently around you, the thing to do is ask why. and then really focus on yourself and try and figure out why that is, and are you responsible for it? So the third symptom that you might want to think about is others or you yourself, you're growing more concerned about protecting your space rather than growing it. And this comes from a fixed or negative mindset. And I think that's real important. A key concept when we're talking about burnout is that mindset's real important. Okay. If you're here a year ago, you taught me to talk about mindset and negotiation, but it's also important for other aspects of our life. And so our mindset is the way we think or feel about a person, place, or event. And the reason why that's important is because the way we think and feel, that determines our actions and behaviors. All right. So and it doesn't matter what it is, every action we have has a preceding thought or emotion. And if we have what we call a fixed mindset, a negative mindset that says, things aren't going to get any better. The world's fixed, the pie's fixed, the ability's fixed. This organization is as good as it's going to get. If you have that fixed mindset, you're going to get kind of stuck in that rut. And I do think that is a symptom or a condition that predisposes you to burnout. Whereas if you have a growth mindset, and a growth mindset says everything in life can get better. I can improve myself. I can improve the organization. There might be better ways to do this. I just need to look at the problem differently. If you walk into it like that, I think that actually is a nice preventative thing that will prevent burnout for you. But the good news is you can work on changing your mindset. The way you think and feel, you can change that about your person at work, the place you work, or the organization. That is more of it's a choice that you actually have to make. Most of the time, folks who get burned out, they kind of accept, they make that choice, and then they don't really fight it, readdress it, and it just kind of lingers and smolders. Whereas with the positive or more growth mindset, it actually takes a little bit of effort for you to say, no, I recognize some of these negative emotions. I really need to figure out where they're coming from, why they're there, and then how I can correct that. So the fourth symptom is you just hope to make it through the day. If you show up at work and you're like, oh, I just hope I make it through the day. Just hopefully this day will end soon. Now, this is similar to going through the motions, but this has a touch of dread, fear, and anxiety. And this is a little more severe of a symptom because once you begin to add in those powerful negative emotions to the mix, it can really amplify what you're feeling in a negative way. And it can really amplify your feelings and your progression to burnout. So if you just it's different, like I said, different from going through the motions where you just put one foot in front of the other. This one is, man, I hope something bad doesn't happen. I hope I don't have to deal with so-and-so. Or you get anxious. Maybe you may even have physical manifestations of that anxiety. That's a far worse symptom and something you really need to take some time and address. Symptom number 5, you've lost a vision for your work. When it becomes hard for you to remember why you dedicated your life to taking care of others, I would argue you've kind of lost your vision. And then from there, it can become an easy downward spiral towards despair, depression, and burnout. So if you have a hard time when you think about it, I used to know really why I enjoyed this job and why I went into it. But now it's harder for me to vocalize that. If that's you, you might have lost the vision and you really need to work on rediscovering that. The 6th symptom is you fake enjoyment and work or enjoy at work. Now that's, you do that all the time. Now there's always those patients or those colleagues that just seem to suck the joy and excitement out of your day. That's different. This is you fake it all day long rather than, I'm just going to get through this surgery with this particular surgeon. I don't really care for him, but I can get through it. That's different than if it goes all day long. Because, you know, if it's just a colleague or, you know, a particular patient or patient type that, you know, mine are the folks that just talk and they never answer the question I ask, but I hear everything else. They kind of suck the joy out. But that's just me, and I know that, and that's a brief momentary event. But you should rebound from that pretty quickly. As soon as you get out of that situation, you get out of that operating room with that surgeon or whatever, you should rebound if you're not burned out. Now, the seventh symptom is your communication response is slow, if it even occurs. So as we get burned out, communication becomes harder and harder. And we begin to shut down because we just want to be left alone, and we don't want to be bothered by anything. And when we're burned out, we tend to answer our emails a little more slowly than before, if at all. You know, we answer pages, but probably not as promptly because we're just tired of being bothered. You know, sometimes you might even avoid telling the full truth because, you know, if you do, it's going to involve a much longer discussion and you just don't want to deal with it. So your communication and the quality of your communication declines as we become more burned out. The eighth symptom is we tend to focus on our failures, right? And we actually magnify our failures than what they really are. You know, what we need to do is we need to accept a reasonable metric of success and failure. You know, and we got to realize that success isn't always binary. Okay, it's not yes or no. There are gray areas or shades of success and failure. And when we're burned out, we tend to magnify those failures. You know, the question you need to ask yourself is, if you're being really hard on yourself, and say, if I had more energy, if I had more livelihood in me, if you will, would I view this shortcoming any differently? Because burnout can contribute to that downward spiral of our self-image, and it becomes kind of this feedback loop in a negative fashion, and it just reinforces, I failed, I'm getting burned out, this is horrible, and it just begins to feed on itself as you tumble down, if you will. It becomes a negative loop that is feeded. So it is an insidious problem, and remember, it doesn't happen all at once. It's nice and slow and insidious at times, and if ignored, when the symptoms grow worse, I mean, it can actually do a lot of damage. So, you know, one thing you would do is ask yourself, how many of these symptoms do I have or do others have that I work with? And if you have more than a few of them, then I would suggest you get help, you know, begin talking with others about your feelings and your symptoms and maybe what you can do to rectify the situation. Now, Robert Coles wrote a book called The Call of Service, and he discusses a progressive 5 steps or progressions towards burnout and depression. Those 5 steps are weariness, cynicism, anger and bitterness, despair, and then depression and burnout. And each stage has its own identifiable traits that can be helpful in discovering if you or a colleague is kind of headed down that path of burnout. And we're going to go through these, what these traits of each of these stages are. So the first one is weariness. Now, and Merriam and Webster defines weary as one being exhausted in strength, endurance, vigor, and freshness. It means you're completely used up. And if you're feeling that way, like you have no energy for anything in life, you're going to, you know, if your hobbies aren't really, you don't get jazzed about anymore, you know, going, you know, seeing family or spending time with friends, if you don't have enough energy and strength for that, you're going to fit that definition of weariness. And, you know, weariness goes beyond just feeling. There's a difference between working really hard and you're tired after being up for 24 hours versus just a general lack of physical energy that you never get back after appropriate rest, what would be a normal night's rest, okay? It involves that lack of a mental, emotional, and spiritual energy. And you typically feel empty of vigor and strength. And you know, physical fatigue from those days and nights, that's very different from what we're talking about in emotional and mental fatigue. So questions you would ask to determine whether or not you or a colleague is in this first stage of burnout is, do I enjoy my work? Do I look forward to the day's work? Am I tired before I even set foot out the door to go to the hospital? Do I ever really feel rested or restored? And am I happier away from patients than I am helping them? Now, and if you answer yes to a couple of these, it might be a good indication that you're in the weariness stage. Now, the second stage is cynicism. Now, cynicism, if weariness continues for too long, the mental and emotional fatigue that can lead to cynicism. And again, it goes back to a fixed mindset that holds that things won't get better, things won't improve. And remember, like I said, our mindset dictates our actions. And if we don't think things are going to get better, we're likely not going to look for ways to make them better. Our mindset is a choice that we make about how we think and feel about things. And yet it can also be a choice that we elect not to make and not to allow circumstances to push us to a fixed mindset. So some questions you might ask yourself or colleagues in the cynicism stage would be, what are the problems I see, and what really makes them a problem for me or for the organization? Ask yourself, what is my mindset? What am I really thinking and feeling about this person, place, or event or organization? And is it fixed? Is it more of a growth mindset? If I believe things won't get better, why won't things get better? Sometimes that question alone can help prime the pump and hopefully kind of help you get out of a fixed mindset as you begin to think about, well, it actually could get better. And if we do this and this, and maybe I could take the lead on that. And what can I do to make things better is another great one. And then how can things improve? What's necessary and required? And it really gets you thinking in a more positive way. And it can be, by working on those exercises, can work towards a more growth mindset and hopefully begin to move you out of the cynicism and out of the road towards burnout. So the next one, the third stage, is anger and bitterness. Now, if cynicism continues unchecked, anger will slowly creep in because deep down, you shouldn't be feeling the way you do. And then you become angry at others, the environment, and obscure entities, and you look for somebody else to put blame on and somebody else to put some fault on for your weariness, fatigue, and happiness. And that then turns into anger because you begin to attribute that someone else's or something else is making me feel this way. And then that anger then grows into bitterness. And again, that comes from the fixed mindset of cynicism. Which can be empowered and dramatically reinforced with bitterness, and making that emotional emptiness these folks feel even greater. So some questions to ask when you're about anger and bitterness is, why do they feel anger, and what are the reasons? And just write them out. It doesn't matter what they are, just get them on paper. Then you can begin to discuss them. And ask yourself, do I feel anger to any person? Well, why is that? Do I feel anger to any entity, organization? Well, why do I feel that way? Or why do they feel that way? And am I unable to forgive for wrongs that I think have been done to me? And I think that's real important, because if you can't get to the point where you can't forgive, you're going to have a hard time recovering from that, because you're going to get stuck in a rut of anger and bitterness. And people owe you things, and they're responsible for this, and they need to be own up for it, and they need to pay for it or whatever. And then you just kind of get stuck in that rut of bitterness. And once you get stuck in that rut, it's an easy downhill slide further down into depression and burnout. So the next phase is despair. And if that bitterness continues, despair occurs. You're going to feel like it doesn't matter what I do; things aren't going to get better. So what's the point of doing anything new or trying to make things better if I can't change it? Again, that comes from that fixed mindset. So it really begins with how you think and feel. That's really your mental health, in a way, is really what's going to keep you from becoming burned out, and being cognizant of that and working on that on a daily basis. You feel like you're not making any progress in any direction in your life, and then you begin to kind of give up on other things outside of work. You may give up on home life. You may give up on hobbies. You may just give up all the way around when you're in this stage of despair. So questions to ask is, is all lost? I mean, is it really a lost cause? Is that the way you really feel, or they feel? Do you feel that there's hope for tomorrow? And, can I improve myself, and can I improve the situation? And you got to be real honest with yourself, and, talk these over with a good friend, colleague, someone you trust, a spouse, somebody who you can really confide in when you're trying to work through these questions. Or if you're working with a colleague, these would be questions you might ask yourself of them before you approach them, and then eventually ask them these questions. Then the final one is depression and burnout. So depression, your despair, when allowed to continue, leads to burnout. And it's that general sense of hopelessness, and the fatigue and the tiredness and the sadness become unyielding and always there. It never goes away. And that feedback loop has become created, and a downward spiral progresses even further. And questions to ask in this stage are you experiencing any thoughts of suicide? Are you using drugs or alcohol to help cope or manage your mood? If you begin to see that a loved one or a colleague's beginning to use, they've exhibited other stages or symptoms, and now they're beginning to maybe drink a little more, or they're using, or you hear of those things, this is when they really need help. Do you feel that you're more irritable now? And have your eating and sleeping habits changed? Or do you lose your temper? Those are some great questions to ask, if you, unfortunately, hopefully never enter, but if you see a loved one or colleague maybe enter the depression and burnout stage, are we seeing those symptoms in them? And then once we've identified that, then we know we need to help, at least try and intervene. Now, burnout, it seems to be growing in healthcare providers in every specialty and in every sector. And my question is, I don't really know if we're better at detecting it and better at discussing it. I don't know if the younger generation of physicians are less, they don't have that, there's that miracle worker reverie, which says, folks who are in highly specialized areas like attorneys, doctors, physicians, or people who have special knowledge, they can never be wrong. And when they do become wrong, they have a hard time accepting that, and then it can set off a downward spiral. I don't think the younger generation necessarily buys into that, and I don't think they also buy into the fact that it's just part of the job to work as many hours and make as many sacrifices as previous generations did. Now, one of my passions is flying. And there are many lessons that I've taken from my pilot training, and I've applied to medical care and anesthesia, from checkout, checklists, and prepping and making certain, the anesthesia machine's ready versus same checklist I do before I take off my plane, But the other day I was watching a National Transportation Safety Bureau, FAA thing on, situational awareness and keeping up on your skills. And they talked about this pilot who really didn't have a lot of hours. He was flying in the clouds. And you could kind of tell in his voice things weren't quite right. And so ATC noticed that he was having some erratic path, and they asked him if he needed help, and he kind of, no, I'm good. I just need time to figure things out. Well, he's the one at the controls of the airplane. ATC, if you listen to the tapes, he kept saying, 875 Alpha, are you okay? Hey, you want to take a turn to the right? It looks like skies are clear over there. Maybe, just give up where your destination is, where there are clouds, and, just head back home. And he's like, I got it. I can make it. And you can hear ATC again and again. Hey, buddy, are you okay? Eventually, the guy's blip on the radar screen disappeared because he unfortunately crashed into the ground and he perished. So when a pilot crashes into the ground, there's not a lot air traffic can do to prevent it. They can see it, they can try and help, but it's ultimately the pilot who has to take ownership of that and take corrective action. It's the pilot who has to fly the plane, and I think burnout's a lot of the same way. When we see burnout in colleagues, when we see burnout maybe in ourselves, it's really us who, the person who's experienced it, who really has got to take control of that situation and rectify it. We can try and intervene all we can, but much like ATC, there's not a lot we can do because we're not at the controls. Now, so when I was training as a pilot, I learned to recover from what we call unusual attitudes in an airplane. It's either a very nose high attitude or a nose low attitude. You're not wings level, so you're climbing really fast, you're losing airspeed, you're at risk for a stall, or you're crazily driving towards the ground. The thing about an unusual attitude is you got to recognize it and you got to correct it immediately. Otherwise, you're going to lose control of the airplane as you stall, or you'll go smashing into the ground from a nose low attitude. And I think that's really important when we talk about burnout, is that the word attitudes used both in burnout and in flying with unusual attitudes. They both, if not recognized and tried to rectify immediately and properly, can lead to devastating consequences. And as we're seeing, physician suicides on the rise. And I think it all starts with that attitude. Remember, attitude comes from mindset, and mindset's the way we think and feel. So the most dangerous attitude when we fly is a nose low attitude. It's where you're racing to the ground without the intent to land in an uncontrolled manner. And if not corrected, you're going to wind up as a smoldering hole in the ground. And the key to saving your life in that situation is recognizing your attitude. Now, bear with me for a minute, but so this is, was you're racing to the ground, you're spiraling left or right, and if you don't recognize that particular situation in that picture, you'll wind up hurting yourself and whoever else might be on the ground if you hit them. So when we recover in an aircraft, our goal is to get straight level flight and then work on returning the plane to where it was. And so, and I think with burnout, that's the same thing. Burnout is, we want to do what we can to get to straight and level flight in terms of your mental status. And then once we get it corrected, then we can slowly bring you back up to where you were before. It's possible, but we don't want to, the goal is not just to get right back where we were before. The first thing is to stop the descent. Okay. And so once we recognize our predicament in a nose low attitude, we're going to pull back our throttle. We're going to get our wings level and we're going to pull the nose up. So when we pull the throttle back, because we want to stop any thrusters that helps us race towards the ground, we want to get our wings level so that when we pull our nose up, the airplane is made to take the maximum amount of stress when we pull the nose up when they're level, okay, when the wings are straight level with the ground. If you're at an angle and a bank angle, you can actually, rip a wing off if you're too steep. So we want to slow it down. We want to get things level so that we can take that stress. And then we want to pull our nose up to stop the descent. So recovery from burnout is once we've recognized that we're tired and exhausted and burned out. We want to pull back on our throttle. And to do that, that might be taking self-care time, family time, golf, hobbies, whatever it is. You just want to slow things down. And maybe you don't see as many consults or see as many patients for a while. Then we want to get wings level. To do that, we want to evaluate and cut back obligations and duties. Maybe we're overextended. Maybe as part of that, we need to reduce some of our other obligations so that we can take that stress as we bring that nose up, if that makes sense. And then I've noticed a lot of times our duties are self-imposed because we seem to have a save the world attitude in healthcare. And sometimes in order to do that, to get your wings level, you got to say no. You got to say no to some things. No, I can't make that meeting. No, I'm not going to do that. Just to kind of reduce that stress on yourself as part of getting your wings level. And then you want to pull your head up. All right. You want to lift your gaze. you don't have to look up high. You just want to get focused on the horizon and get your bearings. Okay. There's a thing in martial arts that the body will go where the head goes, and your head goes where your eyes go. So really, wherever you're looking, in all honesty, is where you're going to go. So all we want to do is, figuratively, is lift your gaze up just a little bit. Don't be looking down thinking that everything's horrible. We got to change that mindset. We got to change those attitudes and those thoughts, that behavior. One way to do this would be focus on the reasons you went into the healthcare profession. Why are you doing this? Probably is because you get a lot of enjoyment and a lot of satisfaction from treating and helping others. So lifting your gaze is going to help keep you from crashing into the ground and being a fatality, a burnout. So, when we discover that we're burned out, we're going to pull back our throttle, get our wings level, and then slowly lift our gaze. Once we get stable, then we can work on getting back to where we were before. So I'm going to talk about some practical steps to recovery of burnout. Now, these are just some things you can do to adjust your unusual attitude of burnout that you or a colleague might be facing. So step one is remind yourself of your real purpose every day. Keep a reminder of not only, your business or your practice's mission and purpose, but what your personal mission and purpose is. And your mission and purpose is what it is you do and why you do it for the benefit of others. Sometimes, if you just review that every day, that can be a dramatic way to recenter yourself and get you on the path to recovery. The important thing is that, remember that the benefit that you have on others, for your staff, for your patients, for your colleagues, and just realize that don't buy into the thought that if you put your heart into your work, you should get something back from it. I think a lot of people kind of see that and they kind of lose sight as to why some of them went into healthcare, because it's to help others, yet putting all this work in and I'm not quite getting it out. It becomes a transactional thing. And just, I would encourage you to consider it a sunk cost. If you put your heart into your work and you're not getting anything back, just consider it a sunk cost. It's gone. You're never going to get it back. But if you recognize that, it'll go a long way for helping in that first step of recovery. The second one is to ask yourself lots of questions. Don't be afraid to challenge the status quo. In fact, the status quo might be contributing to your burnout, faulty processes, too much paperwork, whatever it is. Ask questions, really dig into that. And don't be afraid to ask those questions. Do you really need to attend all these meetings? Do we really need to do all this? Does this paperwork really need to be completed 3 times? Or is there somebody else that could do it? Who could help offload some of this work I have to do? Is there another way we could do it? And so what you want to do is in this step is, do what you can to get your wings level so you can take off, unburden yourself, if you will. Now, the third one is don't equate your work and work environment to your personal value. All right. You are more than what you do 8 to 5 or however long you work. And sometimes toxic environments exist in healthcare. And it's sad to say, but quite true. So what you need to do is you need to realize that your worth as a person doesn't equate to what you do and where you do it. You're more than that. And if you buy into that and you're working in a toxic environment, then you buy into the fact that you're a toxic or bad person. And that's not the case. It's the environment. So you want to buy into the fact and believe that you are worth more than what it is you do or where you work. And balanced thinking is what we're talking about. And it's, not, practice of non-judgment and not judging yourself or others. We all are great some days, and other days, they don't go as well. That's just part of being human. No one ever does everything perfect 100% of the time. But as long as we're doing our best effort and we recognize that, and we don't beat ourselves up too bad when we make a mistake, that is a surefire way to avoid burnout. So this fourth step is don't sacrifice home life for work life. If you find yourself losing touch with children, siblings, spouses, parents, friends, it's best to call a timeout at work, step back, slow down, pull that throttle back, and redirect some energy and time towards those relationships. Okay. Because this is what I've seen this in older physicians who retire and they didn't quite get this. But you got to remember, when you retire, those are the people you're going to be spending time with, not the people at the hospital, not the people at the clinic. As soon as you retire, another replacement's coming in, their preference cards, yours are thrown out, theirs are thrown in, and that's it. And they're moving on. All right. The organization's like, hey, great. Thanks for having you. Bye-bye now. It's really your family and your friends, that are going to be there when you retire. So focus on those things. And those things not only will be there for you when you retire, but they're going to be there as a support network while you're going through some of the stresses we go through in healthcare. Step 5 is control what you can, but recognize what you can't control. And try not to worry about what you can't control. Just say, I can do this, I can't control that, and I'm going to only focus on doing what I can control and do my best at that. Letting go of those things you can't control, it's going to help relieve a lot of that stress and those negative feelings you feel. And remember, those negative feelings are going to insidiously contribute to your feelings of burnout. The 6th step is, get a support group or a mentor to help you go work through your feelings and emotions. Sometimes it's hard to talk with family and friends or even colleagues about our burnout. So find somebody that you can confide with, that they're going to have your best interest at heart, and they'll keep your confidence, okay? And they'll give you what would be good, solid advice as you try and work through this burnout. And sometimes it might be somebody in a completely different field. Maybe it's somebody, you have a friend who's in manufacturing and not in healthcare. They may give you different perspective and insight. So don't when you're looking for networking in terms of that or help, don't just stay with just healthcare providers. The 7th one is keep and schedule time for you. Okay. Whether that time is by yourself or loved ones, actually block that time out. If you do that regularly, it's gonna really help you work at pulling that throttle back and slowing down, and recharge your batteries, if you will. And really, I think this is a must. You really got to slow down. And to do that, keep time for you. And whether that's your alone time or with friends or family, make certain that you actually plan that out a week in advance. And then at the end of the week, look back and say, how much time did I schedule and keep for myself? Or did I give it all to the organization? That's real important for you. The 8th step, don't be afraid to hit the eject button, okay? Sometimes a transition is needed, and it's actually curative of your burnout. Sometimes you just gotta separate yourself from whatever culture or environment you're feeling this in, and that change in and of itself can be enough to help you recover and get out of burnout. If you can't change the culture, or if you can't change yourself, perhaps it might be the best move to make would be to move on and go on to another organization or do something else. So I see a lot of folks, they kind of feel like I just can't quite hit that eject button. Well, if you're careening into the ground and you've got to shoot, you might as well hit eject and do what you can to save yourself. And if that means leaving an organization that you thought you always wanted to work at, but now it's not quite what it used to be or what you thought it would be, it's okay. Pick up and move on. Your mental health is far more important than the organization, okay? And then step 9, pick a podcast to listen to, read a blog to help you with some of these things, pick up a book, stimulate your mind, and do things that energize and recharge you, and give you pointers and practical advice. Network with folks, get a mentor or something, and really look for ways to enrich your mind, enrich your soul and your heart. Some qualities that promote resilience. If you have a good sense of humor and you can laugh at things and yourself, that's always a great way to help ward off burnout. If you have the ability to accept the circumstances, then they can't be changed. And if you have the ability to really have realistic goals and you move towards them on a daily basis, and I think finally, really having meaningful connections with others. If you have those, a sense of humor, and you know what you can and can't control, I think that goes a long way towards fighting and preventing burnout and despair. So in summary, these are just a few things you can do to fight out burnout. Remember, reduce your stress, get your wings level, pull that throttle back and look up. That's how we recover. And perhaps the most important thing is to find someone you can confide in and get support. Once you recognize you're feeling burned out, you're feeling a little bit of despair, find that person that you can confide in, or that organization, or whoever it is, and help you adjust your unusual attitude, get wings level, and then work on soaring again. If you go to my website, davidnorrismdmba.com/Sanibel, I got a couple articles there. And then probably later today, I'll put the copy of these slides decks on there for you that you can download. If you want, copies of the questions for the symptoms or the stages, that you can either, use for yourself, use for your organization, and God forbid, use for a colleague. So with that, I will open it up to questions or discussion.
Well, thank you, Dr. Norris. I have missed working with you.
Oh, thank you, Susan. That's very kind.
Very good. Very good. Hey, I just wanted to have some questions here for you, or a comment too. I heard one of our other colleagues within anesthesia also would say, I wish I would have, that you'll never hear him say, I wish I would have worked more. So, before, more longer hours and stuff. And you brought up, make sure that you pay attention and stay close to your family and that sort of thing. I appreciate that. I think that's very important. And I've had to, kind of take things off of my table too and say, hey, just can't do that. Because, we're so used to saying, sure, I'll do it. I'll help you out. But then, you get too many things on your table and you just need to learn to say no. But I'm glad you brought that up and all. A lot of different comments and stuff on the chat box. And also, wanted to see, one of them asked, how can we identify these signs and symptoms in our colleagues before they choose to leave the organization? If they're not somebody that wants to share their thoughts or visions, how can you focus on that?
I think if you were there when they came on board, or you've known them for a while, you can see a change in their behavior, a change in their attitude, the change in the way they act. If you begin to see that change, say they become a little more irritable, they're becoming a little more grumpy, they become a little more rigid or inflexible. No, that's not the way I'm going to do it. I don't care what they say. Those are signs and symptoms that could be leading towards burnout. And if you like them and they're skilled, and you want to try and keep them within the organization, then I would recommend running through those questions. And if you hit some positives, or you get some yeses to those questions, then with the symptom checker, then pick somebody that is level-headed in the group and in a non-accusatory fashion. Just say, hey, we've noticed there have been some complaints, or it seems like you're not quite as happy as you were. It seems like something's bothering you. Don't say you're behaving badly or you're getting more irritable or something. You don't want to make it accusatory. You just want to say, it seems like something's going on. I mean, you want to talk about it. Is there anything we can do to help? And just try and broach that subject. And then you can, if you know them well enough and you're good friends enough with them, just say, look, we're concerned that, are you feeling burned out? Are you feeling depressed? Are you not loving your energy or your job anymore? And what can we do to try and help you revitalize that? Because when you showed up, you were all gung ho, and you're doing a great job. So, I mean, that would be something you would want to do in a skillful, non-threatening manner, but you'll usually see those changes. The only time you wouldn't is if, they were really happy and go when you hired them, and then the day one they're miserable. That's just a bad hire.
And a lot of times in today's world, I know my wife is a cardiac ICU nurse, and she's been having to work a lot more hours, a lot more stressful times, working with COVID patients every day. They don't have that, and same with everybody in the healthcare industry. Right now, you can't really step back like you're saying. I mean, how do you, it's a very stressful time. You can't say, well, and you can see it on a lot of people's attitudes where they need to step back, but they don't have the opportunity to step back. You know that things are going south, but there's no way to avoid it. They can't walk away from that job. They can't walk away from that patient. A lot of people don't have that opportunity.
Well, then what it would come down to, that would be what can we do to offload the stress? Are there other duties, other functions that we can kind of shove out, or are there other people we can bring in to help manage that, some of their duties, or there's things we can hand off? But that comes, if you're a big organization, that comes from leadership. And if you don't have good leadership, sometimes you hit the eject button.
Yeah, but I mean, in a lot of situations, they're taking care of a much heavier caseload or patient load than they were before, because a lot of the nurses are more or less like you said, they're walking away, they're going traveling, and now they're left alone. They're getting, so it's really a tough situation. I can see it. I can see it on her face when she comes home at night sometimes.
Yeah, I think there's as has been pointed out in our chat session, there's that added problem with being in lockdowns, or no places to go when you do have time off, or no friends to see face to face, person to person, in many of the situations in the world, not just this country, obviously. So there's a lot of things. There's a lot of hurdles there, man.
Yeah. And I think, and some of it also happen to be your personality style. If you're very task oriented and you're not very outgoing, the COVID lockdowns probably aren't that hard on you from a social aspect, because you don't recharge your batteries from that. My daughter and my son are two different personality styles. My son's very reserved and very task oriented, and COVID hadn't, the lockdowns and not going to school didn't bother him. He's like, yay. Whereas my daughter was like, oh, this sucks. I don't get to see friends, and they both handled it differently. And I think that's in large part due to their personality type. And I think there are some personality styles that might be a little more predisposed to having burnout and depression as a result of that. But it is hard. And I think one of the fastest ways to cure it is, open things up as soon as we can. And get that. We're social creatures, let's face it. We don't do well by ourselves, and we need that. So organizations should be doing what they can to encourage that social interaction, but at the same time, keeping things safe. It's a challenging time, I will say that.
We have a comment or a question from one of our younger members here, and from Lorraine Flores. She says, how are perfusionists or somebody in the medical field with families able to balance work and life? As someone hoping to start a family in the future, I find it hard to even imagine having time to spend with family and friends with our busy work schedule. I guess it's not really a question, it's just a comment, maybe how you've done it,
How, me personally, how I've done it?
Yeah.
I 2 years ago, I made a transition. I left my very busy practice and I slowed down. I went to a smaller practice. I just made that decision. you got to do, for me, I just did that balance of, all right, my kids are now hitting high school. They're only in my home 4 more years, hopefully. They leave when they turn 18. That's the goal. But I really want to be there for them when they're going through those high school challenges. So I made the decision to hit the eject button, if you will, offloaded some things, pulled the throttle back. So while they're home for those years of high school, I can be there for them. And then honestly, once they leave the nest and they're in college, I plan on ramping back up a bit. But that I just that was the decision process and the values that I used to make that decision. I realized won't make as much, but I don't care. It's more important that, I form a solid foundation, because these are the people that are going to take care of me when I retire, not all my old colleagues.
Mm-hmm.
So it is hard. It is hard. I'm not going to deny that, but it just takes a little bit of soul searching, and really, I don't regret it. Let's just put it that way. I don't regret that decision, but I valued that time with my wife and kids, and I really want to pour into that. And I think it's paying dividends. I would like to.
Absolutely. Okay. Is there any other questions or comments or anything from our panel or from our YouTube's chat?
No.
Thank you very much. We'll go ahead and just continue with our next one, with implementing change.
Oh, okay. All right. Let me pull that up here.
While you're changing that, I want to share with the group too that you've been flying a lot with your son, and he's a pilot also. That's so neat.
He and Addie, he and his sister are both on their way to getting their license.
Oh, both of them. Oh, wow.
Yeah.
Let me
My
tell you-
daughter was a little, huh?
Go ahead, sir.
No, my daughter was a little hesitant. And then once she realized that it would look good on a college application or scholarship application, she's like, I'll go ahead and do that. So that's.
Let me just tell you, with your talk, it just lit up the chat board with many, many, many individuals that are experiencing a form of stress, depression, feeling trapped, all the things that you mentioned. And what's cool about it is there are people helping people on the chat line too, offering to talk to each other and to call each other and email each other. So
that's what you need.
Yeah, man, you don't get to see that, what your effect is, but it's really positive, I believe, to bring this to light.
Thank you for that. All right. Okay. All right. We ready for the second one? All righty. Oh, wait, I got to share screen here. Give me a second. Sanibel Keynote share. There we go. All right. Now I do things simply because I'm a simple man. So I'm not going to talk a lot about Six Sigma or anything like that. I'm just going to talk about simple ways to improve processes to make it easy so that you make things bigger or easier in your organization. And the first step to any process improvement is you can't control what you do not understand. And if you don't understand what's going on in a process, in a system, in a service, you're not going to get anywhere. And it's very similar to going through med school or any other education. We start with the basics, and then we add the things that are wrong, and then eventually we learn how to detect problems and treat them. Now, Robert Humphrey, who was one of the early minds in process improvement, said, an undefined problem has an infinite number of solutions. And when you have an infinite number of solutions, it becomes really hard to choose. But if you have a defined problem, then it becomes much easier to figure out how to fix that problem. Okay. And Albert Einstein, I liked what he said. He said, if I had an hour to solve a problem, I'd spend 55 minutes thinking about it, the problem. So, and then 5 minutes thinking about solutions. again, Albert's saying, work on defining the problem in the system, in the process, and then we're going to spend time working on the solution. Because what I see a lot, and at the organization I'm at now, they are trying to fix a problem, but they don't know what the process is, and they're just slapping Band-Aids up, and things aren't really working. And then they have these hour-long meetings, and everybody walks away like, well, that didn't solve anything. And I'm like, yeah, it didn't solve anything because you don't know what the problem is, because you haven't gone through the simple steps of figuring out what the problem is. And once we do that, then we can get to the solutions. So processes can make you money or they can cost you money, and processes are critical in service industries, and efficient processes are going to cost you time and money because poor processes lead to low quality outcomes. You may have to do rework, things like that. And then proper processes are going to be efficient and improve quality. And really, that's what we want to do in healthcare is we're nothing but a big process, and we want to deliver the best quality of care we can. So some characteristics of or aspects of services. What we do is basically intangible. Okay, what I do as an anesthesiologist, it's intangible. Yeah, I got drugs, but the thing about a service is that it's simultaneous production and consumption by the patient, if you will, and the service, what we do is always very close to the patient, if not to the patient. What we do can't really be inventoried. You can't say, oh, I got 15 anesthesia. Well, I'm sure some hospital administrators would like to say I got 15 anesthesiologists sitting on the shelf back there, but you really can't inventory service. It's intangible, and what's important to recognize is that there's simultaneous production and consumption of it. So what is service? Well, service is when we take materials, we take equipment, we take knowledge, technology, facilities, and we use them to create what we call a customer experience. And that's through the personal interaction we have with the patient. It's the ease of use, it's the interaction with other customers, and the responsiveness of the company. And we use all that together to create services and benefits. We create feelings and judgments in the minds of our patients or our customers. So why manage your service? Well, it's better for the company. It's better for you. It's better for your staff. And most importantly, it's better for your patient or your customer. Now, when we talk about service, we got to realize there are two perspectives. There's the inside out, which what you think is going on, and there's the outside in, which what your customer thinks is going on. And what we really want to do is we kind of want to work on merging those two so that we understand what the customer thinks is going on, and the customer begins to understand what we think is going on, and we're both on the same page. Because when you're not on the same page with that way, that's how you get poor satisfaction scores. Okay, so the company, as the company or the individuals who are delivering the service, we have our inputs, we have our processes, and then we have our outputs. Whereas the customer, they perceive the experience, they perceive what we would call our product, which is our processes, and they receive the benefits of what we do for them. And so, in this example, we might say the company is a hospital, and in that hospital, they have emergency rooms, physicians, OR nurses, they got ORs, wards, physical therapy, radiology equipment, and stuff to fix hips, right? And the process that they use is they make diagnosis, treatment, and therapy. And the outcome might be, in this case, if a person fell and broke their hip, they're going to use all those inputs, they're going to go through the processes and eventually get a fixed hip. Now, for the patient, their perspective is not that. Their perspective is, do I get empathetic and timely care? The service is the fixed hip, but the benefit to them is being able to ambulate again and return home. I think a lot of times in healthcare, we get focused on what we do that we lose sight of why we're really there. And that's really that bottom part, which is the benefit to the patient rather than, oh, we're just going to fix their hip or fix their knee. it's just a work order. No, we're doing it. We're putting all these pieces of this puzzle together to benefit the patient. So what you got to do is you got to know your processes. You got to know every little bit of the process, every step. And the best way to do that is to diagram it. So what I recommend is you sit down and you draw out in a diagram what you think is going on step by step. What's the first step the patient does when they call the office, or they call or they step into the hospital? What's the first thing they do? What's the second thing? What's the third thing? It's not until you begin to diagram it that you begin to understand every little step in that process. And once you begin to understand the process, then when you identify a problem, it becomes much easier to fix. What I see a lot of times is nobody has a diagram for what's going on. In the outpatient surgery center I work at, with pre-op calls and approvals, there's no diagram, there's no flow diagram. We don't know what's going on. And that's why they're having as many problems as they are. And they keep slapping Band-Aids on, yet those things do nothing but create more problems. So like I've told them, you got to diagram it out before you begin to try and solve it. And the other thing sometimes is for you to actually go through the process as a provider as well as a patient. Take it from their perspective. Actually walk through, what is it like for me to roll in from the holding area on a gurney? What would it be like for me to then hop on the bed and they slap a gazillion little EKG leads on me? They're all cold. It's freezing in here. It's sterile. Everybody's wearing these blue masks and they're in these gowns, and it's, and then what's it like to wake up in the ICU, or what would it be like, to spend the day in the ICU? How easy is it to talk to other folks while I'm there? Those sort of things are going to give you great insight into the services that you provide the patients, as well as give you ammo that you can use to impact satisfaction scores and increase the patient's, which is really nothing more than increasing the patient's perception of the quality of the service you provide. So what is your process? So the service concept is really focused on knowing what it is you're doing. And once you understand the nature of it, you can share it with the customer. And more importantly, you share it with the staff. So if you're able to explain it to the customer, the patient, exactly what they're going to experience, and you can share that with the staff. This is exactly what you as a staff member will experience, and this is what we expect the patient to experience. You can go a long ways towards improving patient satisfaction scores. This is what Disney does. Disney, they have that whole thing planned out from the time you step on the property to the time you leave. They have in their mind's eye what they want you to experience, what they want you to feel. And the staff all understand it, and the staff all work together towards that goal on the behalf of Disney. So there are a couple of components when we're talking about improving any service that we really got to start off with and identify before we really dig into the weeds. And that's our mission and purpose. We always want to start off with what's the mission and purpose of not only the organization, but what's the mission and purpose of the of this particular process for this organization. And the mission and purpose is what it is we do and why we're doing it. So for the benefit of the patient. So the mission is what we do. That would be, the patient's got an aortic valve. We do is the process of putting them on bypass, replacing that valve and sending them out on the other side. And the reason we do it would be the why, and that is so that they can regain mobility or regain some normalcy in their daily life. They have more exercise tolerance, and we prevent a heart attack or something. How we do it, that's the service that we provide. All right, and what it is and how we do it, that's the how. So we want to ask, what is it we do? Why are we doing it? How are we doing it? And that's when we put all those pieces in line and send them through the process, combining all of our talent from our people, all the equipment. And then what? What is it? The last question would be what? And what is it that we want the customer to experience? What do we want the patient to experience in terms of, actually getting a new valve, but also how do they feel about that? How did they feel about that emotionally? And then what are the outcomes that we want them to have? We want to be able to, you want to write these down and be able to speak to them, because we're going to use these answers to these questions are going to help define how we improve processes down the line, because these are going to be our guiding light, if you will, because we're going to refer to what it is we do, why do we do it, how do we do it, and what do we want the patient to experience. That should be the questions we start off with before we try and solve any process, whether it's the process from checking the patient in to getting them to pre-op. That's a process. But we're going to ask these questions. How does that process support the mission and purpose? How does this process, what's that particular service? How do we get it done? And then what do we want the patient to experience during that? And then the next phase, we'd ask the same questions. And the next phase, we'd ask the same questions with the next process. I hope that makes sense. So for an example, for me, my mission and purpose is to help physicians and healthcare providers have the practice they desire by raising their business intelligence through business education. How do I do it? Well, I do it through online education, books, seminars, and consulting. What is the experience I want them to have? I want to make it easy to understand and use, and I want to take these concepts and explain them so that they can easily learn them and then apply them. And I do that, and when I work on my courses and my books, I try to make it as simple as possible for them. And what's the outcome I want? Well, I want them to be financially intelligent so that they are empowered to create the practice they desire. And then anytime I would start a new service, or when I have a hiccup somewhere in this company, I would refer to my mission and purpose and what it is I do, what experience and outcome I want, before I would begin to redefine or redesign that process. The same thing happens in the clinical world, I think. And what is we deliver healthcare? Start with that mission and purpose, how, and then what experience and outcome do we want them to have. Now, there's also, we also have many customers. Our customers can be many things. They can be the patient, they can be the hospital, they can be other physicians, they can be health plans, they can be employers. They can also be a patient's family. We have many different customers that we're going to need to think about as we have patients go through our organizations, other physicians and other healthcare providers. So we got to be cognizant of how our processes affect them as well. Now, service is a two-way street, and the information flows between you and your customer. And that information leads to changes in the service provided, and hopefully can lead to changes in your customer's expectations. Because what we want to do is we want to do what we can to influence and manage their expectations, such that their expectations are, we don't want them unreasonably high and we don't want them unreasonably low. We want them to be reasonable. And by sharing that information flow between you and your customer, you are better able to affect that. So how do we manage our customer satisfaction? Well, their satisfaction is the overall assessment of their perceptions of the service. Okay, it's not whether or not how good you did, it's how good they think you did. Okay, and their processes are their experiences and their outcomes. The expectations, then they experience your service, and after they've experienced your service, they have the perception. And whatever expectations they walk into that service with are going to directly influence and impact their perceptions. Okay, and those perceptions and those expectations kind of feed off each other. And what we want to do is we want to design a service landscape, if you will, that broadly and boldly states what their expectations should be, so that hopefully we can influence perceptions. So we have expectations. Sometimes when we get hiccups, Sometimes the expectations and the services don't add up, and then we get poor customer satisfaction. That could be poor service design. They don't really understand or really know what they're expecting, or you may have inadequate resources. Or sometimes we just offer the wrong service, and that service is wrong, and that will dramatically impact their perceptions. So some influencers of how do we influence their expectations? Well, one is going to be the price of our service. There are going to be alternatives in the marketplace, marketing of our organization, our reputation, could be word of mouth, their previous experiences with us, and their current attitude and mood at the time they're experiencing our service, as well as our confidence. I think those last two can be big influencers on their expectations. If they walk in with a bad mood or a bad attitude, that can unfortunately put us behind the 8 ball, if you will. Also, the degree of confidence that we portray can also affect that. So we don't want to be overly confident, but we don't want to instill any sort of doubt in their mind as they go under. So the patients have a zone of tolerance, if you will, and all customers, doesn't matter. You have a zone of tolerance when you're consuming someone else's service. And that zone of tolerance is based upon your expectations, okay? And as we design our processes or we're trying to improve them, we need to consider our patients' expectations to develop that zone of tolerance. So overall satisfaction factors, those are the points where we can actually influence our customer satisfaction. And the research out there shows that satisfaction is heavily influenced by the peaks, either the best or the worst, and how they felt at the end of going through our process or our service. So what we want to do is we want to design our process with the experience and with the end in mind, okay? So that's what Disney does. Disney, they want you to have a certain experience, and they design all their processes to lead you to that experience, that feeling, we don't control results, we control processes in life. If a truck rolls off the line on Ford and something's wrong, they go back and tweak the line and try and get it right. Same thing with a service. They have a design, they want the F-150 to look this way. When we have a process, we want our patient to have this experience. And that's the way we should be designing our processes. So, if you were to look at a graph like this, the blue or the green line represents, complete satisfaction. Our zone of tolerance is between our blue and our yellow line. And if you hit negative red, that -5 or that red line, you're not doing well at all. So our patients, depending on us, their zone of tolerance may be, they don't have a wait. They're recognized that everybody's friendly and empathetic. And then when they get in there, they may have like a 10-minute wait, and they get meaningful explanations. And, if it's below that low zone tolerance, it may be a 20-minute wait, a cold room, or incorrect diagnoses. And as our patients go through our processes, we can actually influence their overall perception. So let's say our first patient, they wait 10 minutes. The staff is friendly. We're within that zone of tolerance. The physician is on time-ish. Well, we didn't actually hit that mark, so they're still within the zone of tolerance. The staff and the physician are very empathetic. Instructions are given. They understand them. They know what's wrong. The checkout process is easy and quick, and follow-up is completed as promised. Now, if that's that patient's expectations, we've met that zone of tolerance, okay? Because we designed our system that way. This other example is if they wait less than 10 minutes, the staff is friendly, but they were expecting a longer wait. Well, we've exceeded that. The physician is on time. The staff and everybody's caring. Instructions are given and understood. The checkout is quick and easy, and follow-up is completed. And maybe they have expectations with other physicians or other hospitals or whatnot. Nobody follows up. Well, they're going to walk away very satisfied and very pleased because, their last experience was, they did what they said they would do. They followed up. I wasn't expecting that. So They have a couple high points and some, and then everything else is within the zone of tolerance. That actually is what we're looking for. Now, we can look at my wife's latest visit to a physician. I'm not going to talk about why or who it was rather, but she had to wait more than 45 minutes. So that was outside her zone of tolerance. She was not happy. The staff was very friendly, which she wasn't expecting. But then she had to wait another 30 minutes for the physician in the room. She kind of cut the physician some slack, but bumping along that lower level of tolerance. Then the physician kind of poo-pooed her concern and reason for visiting. Not good. And then he delivered the findings and said, these are the findings. Everything's okay. That was relieved. The checkout was quick and easy. But they said they would follow up with her and never did. So my wife's satisfaction, very low. 3 very low points, and the last one was very, very bad. So but I think they designed that process. They didn't do it intentionally, but their process is designed to do that, to yield unsatisfied patients. And guess what? She has a choice of places she can go, and she's never going back to that place. Whereas if they would have designed their processes or maybe set up different expectations for my wife, she might not be as dissatisfied. But this was her first visit, and they did not do a good job. Now, if she were to go back and still had to wait 45 minutes, that might actually shift her up into the zone of tolerance, because she says, I've been here before, they're slow, I'll tolerate that, okay? But it's all based upon experiences and expectations that are set up. Word on the street was that, they get you in and out real quick. And that didn't happen for her. And the fact that the physician kind of poo-pooed her reason for visiting, huge. I really should have made that like -10, but I didn't want to mess with my graph. But just be aware that when we design and deliver healthcare, this is really how our patients determine whether or not we deliver good care. So what are some factors that affect your quality? Well, access, aesthetics, helpfulness, availability, concern and empathy, cleanliness, comfort, communication, staff commitment, competency, flexibility, friendliness, integrity, and responsiveness. Those are all some things that we can use to think about as we're designing services. There's a Robert Johnson in 1995 released a study in the Journal of Service Industry Management, and he was actually looking at banks in Great Britain. But this really applies to all service industries, and he used a Herzbergish, what I call Herzbergish model. Herzberg was a leadership gentleman who did a lot of studies on organizational behavior and leadership in the, I think it was 60s or 70s. And he had a theory that said we have either hygiene or how to motivate an employee. You either have hygiene items or you have motivational items. And he said you either have he said for hygiene, you need a nice workplace. You meet some of these metrics. Pay, you pay them well. They won't be dissatisfied, but they'll be satisfied, but they won't be dissatisfied. But he said you needed these motivational things in order to move them from a satisfied to a motivated patient or a employee. Well, Johnson, he took that model and applied it to service. And he said, satisfaction is not the opposite of dissatisfaction or delight. Rather, it's just the absence of it, of satisfaction, but it's not the opposite. And there are some things that will delight a patient or a customer, but it really, you can't really delight them unless you satisfy some other things. Now, there are 2 types of factors, he said. He said there are hygiene factors. He said these have to be in place to satisfy the client or the customer. If they're absent, they guaranteed you will dissatisfy that person. And then there are enhancing features or factors. These would be the motivational factors in the leadership one, but in the customer service they're enhancing, and that says these can delight if present, but if absent, they will not lead to dissatisfaction. And then in their study, they looked at a bunch of different things, and they looked at, excuse me, attentiveness was a big way to delight people. Responsiveness, about 50-50. You really got to be responsive to satisfy. And if you're uber responsive, you'll delight them. Care, whether you treat them with care, more of a delight. Availability. If you're not available, you'll dissatisfy. But if you are readily available, you're not necessarily going to delight, but you will satisfy. Reliability. If you're unreliable, that will greatly dissatisfy. But if you're reliable, it's that's what I expect. That goes back to those expectations. Integrity. If you don't have integrity, notice that, if you don't do what you say you're going to do or act with integrity, that is a huge dissatisfying thing. And in no place does integrity delight anybody. So I think that speaks to a common innate human expectation. Friendliness. They expect you to be friendly. That will delight them. Courtesy, communication. They expect more to satisfy. Competency, functionality, commitment, aesthetics, and cleanliness. So the essence of that study says if you want to dissatisfy people, be slow to respond, don't be available, don't be reliable, don't have integrity, don't communicate, and don't be competent. If you do those things, you're guaranteed to dissatisfy people. But if you do those things, you're not necessarily guaranteed to delight them, but you may just satisfy them. To delight them, you want to be very responsive, very attentive, demonstrate that you care about them, be very friendly, and communicate with them frequently and openly, and be competent. And you can actually, in your touch points with the patient, as they go through your organization, you really want to focus on those. Everybody in that process is showing them attentiveness, is being responsive, is showing that they're caring about them, they're being friendly, they're openly and readily communicating with them, answering all their questions, and everybody's competent. If you do that and you make sure that every touch point is hitting those things, that's a surefire way to at least set yourself up for delighting the patient. So when we design our customer experience, you really got to make a map. There's no other way around it. You can't. This is not something you can just think is in the ether there. I recommend you draw it out. You write the process out. And so first off, for this would be like taking a patient in PACU. For a high level, patient arrives in PACU, we assess, we treat, we identify the next appropriate place they go, either the floor home or the unit, and then we provide report to that place, and then we transfer them. That's a high level process, but we're beginning to set up steps that happen in that process. And until we do that, we're not going to have much success at making change and affecting good change when we don't draw these out. Now, the next step would be after you do that, you would sit down with some folks and make a detailed list, right? The patient arrives in PACU and we create an algorithm similar to this. Get a little more granular detail, if you will. And then after, we sit down with our team, everybody that's involved in the process, we sit down as a team and we'll work on this together. And we include everyone, and we get everybody's input. After we've created a list like this, then we can create what we call a swim lane. And the swim lane is where we look at who's responsible for what, where are the information handoffs, because usually it's information handoffs and stuff like that where things go awry. So as you can see, the nurse has quite a bit of tasks to do. The CRNA arrives, provides that transport and that report. There's a handoff there. That might be an area where we would expect to see some misinformation or gaps. And then the nurse, the PACU nurse, would then follow an algorithm similar to this. Sometimes they might need to contact the physician with abnormalities or whatnot. But this then begins to delineate roles and responsibilities in that process in the PACU. And then we can begin to really hone in on, okay, where are the problem points, and in whose area and domain is that? And does it need to be on that domain, or do we need to shift it down to somebody else's domain? But it's not until we write these out and we make these maps that we're able to really do that. I mean, and that's what, like I said, with my outpatient surgery center, they're trying to make these pre-op screening calls easier, and they're making them harder because they don't have a map. If they would just, we're doing that next week. We're meeting, and we're going to make a map of the process so people understand the steps, and then we can begin to better understand where the information and the mistakes are coming. But you can't do that effectively until you draw these out. So when we're doing these process improvement initiatives, some questions we want to ask is, does this particular process support the mission and purpose of the business or the organization? And like I said, that's where we start. We start with the mission and purpose, what it is we do, why do we do it, how do we do it, and what do we want for experiences and outcomes for the patient? And then we ask, does this process help that? And if not, then why do we have the process? Or if it's not, what do we need to change in it to make it do that? Does each activity add value? There are some that will add value that don't touch the patient, and then there are some that don't add, and that do add value that directly touch the patient. But we need to make certain that each activity is going to add value in some way, shape, or form, whether it adds value in terms of information or knowledge to the providers providing care to that patient, or it's actually, delivering medicine to the patient. Each activity in the process should add value, and who's responsible for this process, and that's easier to determine once you map that out and you create those swim lane charts. Once you create those swim lane charts, then that becomes a little easier to understand who owns it and who's responsible for it. Who's the boss? Is this process in control? How many errors are we getting? And then how efficient is the process? And how can we make it better? How can we improve it? And is it possible to develop a standard for this process? The best thing to do is you want to create a process that will apply to many different people. That way you don't have to have a bunch of individual processes, but you just know that once they enter this process or they enter this unit, I know that things are going to go this way. And everybody in that unit knows how things are going to go. And the patient should have an idea of how things are going to go because everybody else does. And, does this process need to be made part of, does it need to be moved up, back in line? Or do we have bottlenecks that we got to worry about? Or does it need to be shifted somewhere in the overall process? So who's involved it's going to take a team effort. And what you want to do is you want to identify all parties involved in the process. And I mean everybody who's involved in the process, not just a few select people. You do want you want to pick a champion or two. But I also suggest, it's kind of contrary, but I suggest a negative Nancy always sometimes provides insightful data as to why things are bad. And they may actually give you good information rather than Pollyanna-ish, everything's going to be great. You want to gather all the facts and data in the material, and then sit down and work with those members to create a process map. I did this at my old hospital for a pre-op clinic. We had a pre-op clinic, and things weren't happening. And so what we did is we had a meeting. It was probably a 3-hour meeting in the middle of the afternoon. We shut the clinic down. We had everybody in the room, and we walked through and we created maps very similar to what I showed you for how do we get a patient preoperatively cleared for the hospital. What are the steps? Where is the data handed off? Where are we seeing bottlenecks? And when we had everybody there, we had a better understanding of what their individual tasks were in that process, what sort of hurdles they needed to overcome to make it better. So start simple. First, make an overall map, and then make a detailed map. And then finally, like I said, create a swim lane map. So what you want to do is, after you've identified the roles, is you want to validate the map. You want to sit down and go through the process, maybe implement it, see if your map really is working like it's supposed to, and then identify quick fixes, things that you can really see good improvement on with relatively little effort. So start with the mission and purpose, begin with the end in mind, identify all the processes, and rank them according to how well they work, the number of complaints each process has, and after you create that ranking, you're gonna also want to make certain everybody agrees on their start and finish points. So when's the process start? When's it end? Make sure everybody agrees with that. And then after you rank your processes, it'll give you an idea of where to look. So what you want to do is you want to pick processes that are what we call quick wins, right? They're high impact but low effort. And if you understand all the processes and systems, and you know which ones have a lot of complaints, but it really wouldn't take much to tweak it, that might be a quick win to get that. The next one you want to maybe work on are the low impact, low effort, which are the fill-ins. And then major projects are going to be the ones that are a lot of high effort, but they have a high impact. After you've taken option 1 and 2, go to option 3 on your processes and really work on those areas that are going to be a lot of work, but they're going to have big impact. And then you focus on those because you've already cleaned up all the little stuff. And then avoid thankless tasks. Okay, those are the ones that require a lot of effort and they don't do much. Don't do those. Don't waste your time. It's gonna demoralize your staff. So avoid, if you can, those thankless tasks. Start with one, do the fill-ins, and then also work on your major projects. So questions to ponder as we analyze our maps or our processes is, where are the bottlenecks? What might be causing delays? I mean, how much rework is required? Are we having to redo things? I know for a while, one of our centers, we kept having to redo the consent forms because they weren't quite right. And then that delayed patient going to the OR and stuff like that. Well, how do we fix that? Where are the errors occurring? Is there any role ambiguity? Do people not understand what they're supposed to be doing and what they're responsible for? I find that happens quite a bit. People don't really understand, or they haven't had to explain to them what their role is. And that might be due to the fact that the organization doesn't understand the whole process. Are there any steps that are duplicated? What are steps are unnecessary, and can we eliminate them? You always kind of, as a continual process improvement, you always want to be thinking to yourself, what step can I eliminate in order to make this thing more efficient? And then where are the handoffs? And in healthcare, that's where we have a lot of errors, handoff errors. So where are those, and what do we need to do to be extra vigilant to ensure that errors don't occur at that time when we're handing off work? So what I like to do is, when I'm doing workshops, is we start with a simple exercise. We're gonna, I have folks outline a process, and that's just to make a cup of coffee, right? And it's a good exercise because it's something silly, but it demonstrates the value of drawing out these maps and making these processes on paper. So you want to define, have the team define where the start and end points are, and once we do that, have them develop the process. And you got coffee, coffee grounds, coffee maker, and then have at it and figure out, I want you guys to map out for me this. And then after we do that, then they can begin to, once they understand what the goal is, it makes the next session and making the processes maps a lot easier and a lot faster. So during this exercise, you want to, did everyone discover and understand the importance of a process map? Does everyone did everyone agree with and determine start points? And how did you guys determine that? If there were disagreements, how was that dealt with? And how might these types of disagreements be handled in the future? Because you're going to have disagreements on either start points, stop points, what's a bottleneck, what's important. And how you deal with that as a team is going to be incredibly important to your success. And then, did everyone participate? That's important. If you've got somebody in the room that's not really participating, why? Why aren't they participating? I mean, if they are a part, they're part of the process. You know, if they're delivering care, they're starting an IV, they're pushing meds, whatnot, they're part of the process. We want them to be involved. I would want them to speak up. I want to know their point of view. And if they're not doing that, I'd like to know why they're not. Because is it a leadership thing, a personal thing? Is it the personality? But at least understand where they're coming from and why they're not engaging. So once you got your map, use it. And what you do is we take these maps and we show them to everybody who's in that process. So like in the PACU, we would have this map and we would share it with everyone in PACU. Or in pre-op clinic, you know, we shared the intake in that pre-op clinic. We shared it with the scheduler. We shared it with the RNs, the PA, and the residents that worked in the clinic, so that everybody knew what the processes were. Everybody could refer to it, so they'd know exactly what step they're on and what the next step is. And we were able to improve efficiency and really drop number of rework and delays because everybody used that map, not just me as the pre-op clinic coordinator. But what you want to avoid is don't interview just a handful of people when you're trying to do process improvement. Don't make maps of the processes you wish you had rather than the one that exists. It's good to know where you want to go, but you really got to know what you have. And then that's your starting point. And then you can tweak things to get where you want, but don't make the pie in the sky. Make the one that you actually have so you know where your problems are. Don't ignore the opinions of those who actually probably know the process the best, who live it every day. Really listen to them. They would be the subject matter expert. Listen to them, take their advice, and do not put the map on the shelf or in a drawer and never look at it again, because this really becomes a map for you to, as you're going through it, and then maybe you revisit it in 6 months, 9 months, a year, and say, how has this changed? What needs to be changed? How do we get better? And you continually refer to these maps as part of continual process improvement. So there are 4 steps to process improvements: planning, and then we execute, we do, we check, and then we act. And then we go back to the plan stage. That's the whole cycle of continual process improvement. So in the plan phase, what we want to do is we want to begin with our overall mission and purpose. What it is that we do, what service do we provide our patients, and why do we do this, and what are the problems that we hope to solve. And then we want to define the current situation. So what is our current situation? That's through our own personal observations. We want to interview people who are actually involved in that process, and through that we can identify key people and get their input, maybe hopefully make them champions. And then we want to create the visual map of the process. Sometimes when we walk into process improvements, we're going to bring problems. Some of those problems are going to be broad, they're going to be vague. Some are going to be really defined issues, and others are going to be low priority. But we're going to want to rank each problem accordingly. Is it a low priority? Well, guess where low priorities go? They go at the back. If it's really defined or something that can be easily fixed, maybe we're going to make that an option 1, a quick win, and we're going to define that. Then we're going to set SMART targets, right? Specific, measurable, achievable, realistic, and time bound, for each of our process improvement changes we want to make. And then we're going to do root cause. What should have happened? Why didn't it happen? Who could have, what could have prevented the problem? And ask why at least 5 times when you're trying to get to that. Why didn't this happen? Why? And eventually you're going to get down to the real cause of the problem. And it might be a bottleneck that you can't overcome, or maybe you can move or can't. But what you want to do is you want to get down to the nitty gritty. You want to solve the real problem that's impeding your ability to deliver good care. So then we want to do, and that's where we gather ideas. We're going to bring our team together and we're going to brainstorm. And there's no such thing as a bad idea. When I do these things, we just, and Chad and I, we throw everything on the board. It doesn't matter. And then after everybody has their ideas up there, then we go through as a group and we narrow down the choices that we think are probably the best ones to maybe test or go on with further detail. But at least everybody, hopefully you get everybody brainstorming things, and sometimes you'll get ideas from people that you never thought would have a good idea. I've had that with some old partners of mine. Like, wow, that was a really good idea. I'm sorry I thought that you would never have a good idea. But I won't tell you who it was, Susan. But anyway, just be open to other people having good ideas. Then you want to revisit. You want to re-examine each issue and test it, and go back and say, does this support the mission and purpose? Does this eliminate any complex, make it less complex? Is there less confusion? And are we going to meet our goals? And does it really address the root cause problem that we identified? And does it pass a common sense logic test? Does this make sense, what we propose? Define your countermeasures. Your countermeasures, who's responsible, who supports the responsible party, what are the steps needed to implement this countermeasure or this fix for it, how are we going to measure our progress in terms of getting towards our fix? And then when do we think where this is going to get done? We want to generate buy-in with folks. And the best way to do that is through communication. And we relate the problems or the fixes. We always relate that back to the mission and purpose of the organization. So this is why we're making this change. I know it's not going to be fun and maybe, but we're really doing this because of what we're doing and why we're doing it for the benefit of the patient. That's a great way to generate buy-in for folks. You want to consider the financial impact of the problem and the financial impact of this fix, make certain that you've really laid out timelines and metrics and reporting processes, and everybody understands maybe their new role in whatever you're implementing. You want to build and brief your implementation team. And make certain everybody knows. Again, this is part of that communication, is make certain everybody knows what their new roles are, who's responsible for what. That way they know what they're responsible for and they can help hold others accountable. Be willing to answer questions and be willing to defend the reason why you're making the change. And if you're not able or willing to do that, then maybe you're not the one who should be doing it. Then you want to execute your plan, and don't focus on perfection. Change is the path to perfection is little baby steps at a time. And as long as you keep putting one foot in front of the other and you keep getting better and better, that's really what we're working on. Because really we'll never hit perfection, but we always can get better and better and better, just like Toyota did. And be willing to adjust your course when needed. What you want to do is adjust as little as possible during a trial implementation, but after you've been trialing for a while and you think you need to make an adjustment, be willing to do that. Don't be married to this change or the decision you make. You can always make a new decision, and we hopefully are collecting data and we're looking at our metrics or our guideposts and say, okay, we're not going to hit it doing this. I think if we make this tweak, we can get there. And then don't be afraid to implement that. And then we check. Always analyze your metrics at each milestone. Are you meeting your goals? Are there any adjustments that need to be made? Are we having morale and attitude issues amongst the people inside the process? Why is that? How do we fix that? And then do we need to make any adjustments? I think that morale and attitude thing is real important, particularly since people are the folks that deliver service in healthcare, and how they think and feel impacts the quality of care that organization delivers and that perceived value by the patient. So be real cognizant of that. Revisit and document each countermeasure. and ask yourself, was the patient experience really improved after we implemented this change? Did we reduce complexity? Did we reduce confusion in the users? And did we hit our target? Was the root cause addressed? Did we have positive change, and what were the financial impacts? Did we save money? Did it cost us money? And are we better off now than we were before? And you want to write those down and then act, roll it out across the organization, distribute create a document, distribute the diagrams to everybody, create maybe a step-by-step guide. So that's another thing we can do is when we onboard people, if we have these processes diagrammed and we have these processes written out, when we bring new people on, they can get on board faster. Training can go down because we have it documented, like this is how we do things and this is why we do it. And then review your progress at 6 and 12 months and track your metrics on a monthly basis. If you want to contact or connect with me, there's my podcast. But if you go to that Sanibel, you'll have a list or my checklist for I use a checklist for every process improvement I use based on plan, do, act, and all that, and check and act. And I have those questions and some worksheets that you can download if you go to davidnorrismda.com/Sanibel. You can also get that there. My clients have found that to be very helpful and very useful as they begin to really sit down. And if they want to make good change, the ones that have used it said it's been easier making change by using that checklist. So that's yours for free. And with that, I'm done. Excuse me.
Thank you, Dr. Norris. That was fantastic. You and Quint Studer have a lot in common. We did exactly the same thing. And basically all the way to the notes, we brought in managers from every department, even the cafeteria, valet parking, everybody in one room, physicians that sat with these people. And then we did posters, little notes on the wall. And then we kind of condensed them down to 4 things. We actually found out that patient satisfaction in this area was, we found out from one time we were getting very poor scores. We went back and we traced those steps. We found it where we had just hired a valet parking company, and they were really kind of rude to the people when they initially came in the hospital. So therefore that rolled all the way over to the patient satisfaction and the hospital scores just from valet parking. So therefore it affects everybody, not just the physicians or the patient care people. It's from the food they get from everybody in there. He pretty much he's been doing that. And I learned from him that same satisfaction score and how we set up a roadmap. I like your swim lane attitude. We said one-stop shopping, more or less, and thing. It was really good. And thank you. I think that's what every organization and every company ought to be doing at this point in time. But thank you very much.
Yep. No, thank you. Yeah, that's it was my service operations class in my MBA program that I learned a lot of this and really made it like, oh, never really thought of it that way. I always thought good service was making the diagnosis and, treating it. Well, it goes much beyond that. And the bigger the organization, the more variables and touch points you have, I think the more you're at risk for not meeting those patients' expectations or meeting their satisfaction. So,
Dr. Norris, I excellent presentation. And again, the chat board has lit up with comments, and appreciate all the information you're offering. I think that, we are a service industry, and even though as perfusionists, we spend a lot of time in the OR, we're still walking from the parking deck to the changing room, and we're still going to come across, clients or families that need help with directions or just a friendly hello. I've also, hear from patients that, they just don't get communicated, families of patients that are maybe sedated, they just don't get communicated to as much as we think so. And we think that the other person might be doing it, but not us. or not that, whatever. We would forget that sometimes they're not being communicated to in the way they're supposed to. Now, I know there's certain limitations on what we, as maybe say perfusionists, should say to the patient's families. But on the other hand, I think if we can assist in any way possible to make their experience at our institutions favorable, obviously that's like you say, it goes from the janitor to the CEO or whatever. I'm not putting the janitor on the bottom, we're all important, but just to go ahead and make that an important. So how did you get so passionate about this? Because I've seen that comment in many compliment in many.
Well, so my journey started in my MBA class. So I surveyed every physician in my county. It was about 1,000, 1,100, and I snail mailed these surveys. And it was part of a quantitative analysis class. And I said, what problems are you facing in your practice? What do you feel good about? What do you feel bad about? And the first thing was financial reports. The second one was negotiations. And the third was improving processes, or why isn't my clinic running right? And so I said, well, those are all the same questions I had. Maybe I'll start working on those and making educational material to help them, make little steps to improve things. So, with process improvement, if you're in the process, you can either get bitter and angry that it's not working, and that can lead out to burnout and depression, or you can say, I'm going to help try and solve this, and this is how I think we can solve it, and I'm going to try and make it better. And for me, that's been the best way for me to avoid that bitterness and anger. Is all right. Well, I have a few tools I can use. Let's see if we can't make this better for everybody. So that's how I got started.
Very good. Hey, thank you very much, Dr. Norris. I have one more question too, or thought for you. When you were implementing change, which is tough, it's very tough to implement change, I'll just say. But how do you get everybody to drink the Kool-Aid to agree on these changes? Because a lot of them say, I don't want to do that. That's how we've always done this. How do you start with that type of, attitude and stuff?
For that, what I recommend is you start with that mission and purpose. What is it that we do as an organization, and why are we doing it? Because I would assume that your mission and purpose as a provider in this organization should mesh with the organization's mission and purpose, right? And so I would start the argument there saying, well, we both are kind of on the same page. We both want to do what's best and improve. And then I would take it into, well, how's the current situation working? We're not making it. We're not hitting it. However, I think with these steps, if we implement this, I think we're going to get there. And isn't that what you want to do? I mean, don't you want them to get better? As long as it meshes up with the companies, and then the other thing is the organization has to live the mission and purpose every day. You can't just say it and not do it. You actually have to live it. And that's come from leading from example. And if you're not leading from example, you're going to have a hard time getting buy-in. So the organization have to lead by example. They have to really live that mission and purpose. And if they don't, then you're going to get pushed back. And I can't say that I don't blame them a little.
Well, you're a breath of fresh air. Thank you very much for your presentation today and presentation.
All right. Well, I hope you guys learned something. I appreciate the time.
Thank you.
All right.
Okay.
Thanks.
Bye-bye. At this time, we're going to take a short break for 15 minutes. We'll be back at 1:15. And also be sure and go visit our virtual booths. They're waiting in there for you. And I think this is a great time to go in there and tell them thank you for supporting our meeting. So we'll see you in 15 minutes.
Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, You have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The Invos 7100 Regional Oximetry System. Because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO. The first to combine the function of an oxygenator with the convenience of integrated monitoring, the Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position. As a convenience, pressure sensors are pre-zeroed and no further action is needed to ensure pressure sensors are zeroed prior to use. The large blue ring on the inlet side of the device and the red ring on the outlet side match the colored caps on the blood inlet and outlet ports. The colored rings help confirm the inlet and outlet side of the device once colored caps have been removed. Blood sampling can be done at the lure ports located on the blood inlet and outlet. When Nautilus Smart is first powered on, the Ready screen will appear. Measured values are displayed, but alarms are not yet active. A press and hold of the play icon activates alarms. Alarm limits can now be set, alarm notifications will occur, and the Nautilus Smart ECMO module is ready to go. Simplify your circuit with the first oxygenator featuring integrated monitoring. Nautilus Smart ECMO module, designed for ECMO.
Seconds. When it comes to perfusion management, seconds are more than a measure of time. They're the moments that make up a person's life. Seconds are also the advantage you need to create the best possible patient outcome. They're what matter when you need to intervene during surgery. Seconds can change a person's life. The new Invos 7100 Regional Oximetry System is the responsive first alert system for when seconds matter and timely intervention is critical. Created in collaboration with clinicians from around the world, the advanced Invos 7100 system provides innovative, next-generation improvements over the Invos 5100C system, while having the same reliable trending response you've come to depend on. Now, more than ever, you have the confidence to intervene when your patient needs you most. The Invos system is the clinical standard, with more than 600 peer-reviewed publications showing it can help reduce the risk of adverse events, such as stroke or renal failure to the patient. Backed by clinical and economic evidence, the INVOS 7100 system is meaningful innovation put into action. It is leading medical technology that helps you provide better patient care. Designed for improved performance, the intuitive system responds to each individual's unique physiology, so you know when to intervene. From the cardiac OR to the ICU, you have a reliable first alert for a change in perfusion when an informed, rapid response is vital. Confidence in your response. Innovation and commitment to individualized care. The INVOS 7100 Regional Oximetry System, because seconds matter.
The Nautilus Smart ECMO module is designed for ECMO, the first to combine the function of an oxygenator with the convenience of integrated monitoring. The Nautilus Smart ECMO module improves long-term gas transfer while providing real-time device performance data. Integrated sensors in the blood inlet and outlet ports measure pressure, oxygen saturation, and temperature. Monitored values are displayed on the touchscreen. The touchscreen also allows for SO2 calibration. Utilize the touchscreen to set alarm limits. The module gives you audio and visual alerts when alarm limits have been exceeded. Here, the oxygen gas flow has been disrupted. The light bar provides at-a-glance assessment of oxygenator status and is visible from at least 4 meters. When gas flow is restored, the module recovers from the alarm state automatically. The Nautilus Smart ECMO module is designed for long-term performance. The circular shape eliminates corners, areas known for clotting and stasis. The guided inlet design reduces velocity changes at the inlet, where low flow and stasis may also occur. Finally, the filling vanes aid in even filling and even flow distribution across the fiber. The circular shape, guided inlet design, and filling vanes work in combination to create the Nautilus Smart ECMO module's circular flow path design. This flow path technology results in improved gas transfer. The module is used with the Nautilus oxygenator holder, which allows for versatile positioning. Nautilus Smart can be powered with 4 AA batteries that are included. Battery life is 120 minutes or greater. Alternatively, AC power can also be utilized. To power on the module, flip the switch to the on position.
Welcome back and good afternoon. I hope you guys were able to get in the virtual booth. We appreciate you supporting our vendors this way. So we're in for another treat here. We're going to have our next speaker is a pulmonary critical care specialist at MedStar Washington Hospital Center, where he oversees the management of mechanically ventilated patients and the clinical practice of the pulmonary services department. His adult critical care practice interests include patient ventilator asynchrony, esophageal pressure monitoring, ARDS management, organ donation, and ECMO. He sits on the interdisciplinary ECMO, ARDS, and organ donation and critical care practice committees. Please join with me in welcoming Eric Kreiner, the speaker today on the fundamentals of mechanical ventilation and its use while on ECMO. Welcome, Eric.
Thank you. Thank you so much. I am going to bring my screen up and we will get ourselves started here. Here we go. Okay. All right. I super appreciate the opportunity to speak with you guys. It is my first perfusion conference. So pretty excited about that. You know, I speak at probably 20, 25 conferences a year and have yet to hit a perfusion one. So this is pretty great. I am going to be talking about fundamentals of mechanical ventilation separately, and then that mechanical ventilation and its use while on ECMO. All right, so it's a pretty big topic, and we're going to try to lend some time to each part of it so that we can kind of hit everybody's interest here. Conflict of interest and disclosures are here for you. Travel expenses honoraria from Ingmar Medical Medtronic, and I am also a consultant for Vyaire, and everything here are my slides and content and you know, my thoughts. All right. This is my other disclosure. I really think I love putting this quote up when I talk about, these kind of topics. If you are unfamiliar about the primary author here, unfamiliar with, his name is Luciano Gattinoni. He is a titan of ARDS and mechanical ventilation research, as well as mechanical ventilation while in ECMO research. He practices in Italy as well as in Germany, and has published 300 some odd papers. So he wrote this, really review article in 2017, and I will let you kind of read through here that first sentence, which is probably the most classic. If you read a lot of journal articles, I'm not sure that you would ever find this in an introductory sentence. But he kind of hits the nail on the head. So if you were tuning into this talk, hoping to find some sort of evidence-based answer about how to set up the ventilator while the patient is on ECMO for ARDS, you can stop watching, but don't do that. All right. We'll talk about all the stuff that we do know. Okay. And we'll apply that physiology and that pathophysiology to these patients that are on ECMO and what on earth we do with the ventilator. Okay. So I got 4 big objectives that we'll try to get through here. I'm going to quickly go through some of those fundamentals with the different modes of mechanical ventilation, just so that we can all be kind of on the same page as we go through, the duration of the talk, as we talk about the different ways that we ventilate patients and the different ways that we hurt them, right? And so that's what we'll talk about second. It is called ventilator-induced lung injury, and just because we put the ventilator on them doesn't mean that we do not harm them, all right? And so there's certain concepts and things that go along with that, and we'll discuss those. We'll also discuss in such ways to prevent them, and then we'll roll all of those ideas into, well, how on earth do we manage the ventilator once they get cannulated and are on ECMO? All right, so off we go. Okay, so first part, fundamentals of mechanical ventilation here. So in terms of mechanical ventilation, the ventilator really can only do 2 things. It delivers 2 types of breaths, right? It delivers a spontaneous breath and it delivers a mandatory breath, all right? Those are the only 2 types of breaths that it actually delivers, okay? How we set up those breaths is where you get into what you may hear called or be familiar with modes mechanical ventilation. So this is how we're gonna organize ourselves here. All right, so once we understand that fact that the vent delivers a mandatory or spontaneous breath, it is up to the clinician there to set whatever or to choose what type of breath they want. All right. And so we're going to stay here as you're facing the screen on the left. We'll talk about the mandatory ways. All right. So a mandatory breath, the first step is selecting the breath pattern. And this is what I mean by that. So here we have breaths being delivered here, right? There's 3 of them across your screen here. We'll call this a scalar. Pressure, specifically airway pressure, is on the vertical axis. Time is on the horizontal axis. And what you see is 3 mandatory breaths. So the ventilator is turning on and delivering these breaths. And we'll make up the story here that the patient's apneic and has no respiratory drive. The ventilator will deliver these breaths even in the absence of that patient's apnea. And that is based on a timing criteria. That timing criteria is specifically based on your respiratory rate. So in short, what that means is if your respiratory rate is set at 10, 60 divided by 10 is 6 seconds. So every 6 seconds, the ventilator will turn on. And that way it evenly spaces those 10 breaths out over the course of a minute. All right. Once that vent is time triggered to start, it delivers the mandatory breath here. All right. So the question is, though, well, what happens if the patient wants to take a breath, right? In between here, denoted by that little V that I have there for you. And so that's the question. Well, what does occur if the patient wants to take a breath on their own? And what that is, the answer for us here is the patient or the ventilator doesn't ignore the patient's efforts, right? It doesn't lock them out, essentially. That would probably be cruel and unusual punishment, right? So what the ventilator does do, though, is sense that patient's efforts, and what it will deliver to them is the same exact mandatory breath as it was delivering when the patient wasn't triggering. And so what you have set up here is what I had termed first the pattern of breath delivery, essentially, in that every single one of these breaths, whether it's turned on by the machine or whether it's turned on by the patient, is a mandatory breath. So they're all mandatory. And that pattern of breath delivery is called assist control, or AC. And so we're starting to parse together what, the components of a mode of mechanical ventilation. Some ventilators call this CMV, or continuous mandatory ventilation. I'll give you a little tidbit. There are 298 modes of mechanical ventilation registered at the FDA. There are not 298 modes, there's 298 names for them, because there are no rules for the proprietary naming of modes, right? So there's no generic naming or anything like that. So it becomes really difficult in practice, in teaching, and even in communication, because we can be speaking about the same thing, but in a different language, all right? So we're gonna go with assist control here, all right? And call this assist control, meaning all mandatory breaths. The next thing that the ventilator essentially asks the clinician to do at the bedside is, how do you want me to deliver all these mandatory breaths? I know that you want me to deliver them all in a mandatory fashion, but how do you want me to actually deliver them? And so you have a couple different options here. And I'll give you option number one, is that you can set each one of these mandatory breaths to be delivered with a set tidal volume, all right? So let's just make up that we will deliver 500 cc's or milliliters per breath. So each one of these breaths, again, whether triggered on by the machine or whether triggered on by the patient, will be 500 milliliters, okay? And so in such, we have a pattern of breath delivery, which is called assist control. And then we have what's called the control variable, or how you control each one of those mandatory breaths, right? And that's volume. So what you come up with is the mode of ventilation is volume control, assist control, all right? I will lend this kind of tidbit to you here, is that this is typically shortened, right? It's a mouthful. It is the actual generic name for the mode, volume control, assist control, because it's telling me exactly the control variable and the pattern. But, in taking care of patients and in rounds and in the hospital, we typically shorten this to just say assist control with a understanding that is volume. And I will say that is in a hospital that uses volume as its conventional mode, okay? So we have to be careful about how we talk about these things. I always speak about them in longhand, volume control, assist control, because it's a complete nomenclature, essentially. I'll then give you another option that exists, and it looks the same. It's so similar. It's very, very similar, except that each one of these breaths, instead of being delivered with a set tidal volume, is now delivered with a set pressure. And so lending the kind of the same pattern, instead of volume control, assist control, we would call that pressure control, assist control, all right? And so again, these can be shortened depending on the conventional mode of ventilation that you use at your particular institution, but these are the longhand names to them. Each of these ways to ventilate them, meaning whether you use volume or whether you use pressure, carries certain advantages as well as they carry certain disadvantages, right? And so in the world of critical care management of mechanical ventilation, there is no one mode that works for every single patient. There just isn't. There's also no data that proves that any one mode is better than the other, right? And so it is a matter of leveraging the advantages and disadvantages. And really those advantages stem from the physics of what's going on. Because if we control volume, then the pressure that is generated when the ventilator pushes that set volume into the patient's lungs is completely variable and dependent, right? And so that can be particularly advantageous, right? That you lose control of the pressure that's being generated. The advantage of it would be that you have, a set amount of volume going in and out of the patient every minute, which is called a minute ventilation. And that advantage lies in gas exchange, that you have a direct control of the patient's CO2. And now I'm speaking off membrane, okay? The advantage of using pressure is kind of clear. that you would then control the pressure that is going into the patient's chest or into the patient's lungs. And so, that definitely has a set of advantages, right? That you're trying to protect them from any sort of pressure, injury, or overstretching or something like that. But it also has a distinct disadvantages in that if you control pressure, then you do not control volume, and it is variable and dependent. Right? And so therein lies kind of a basic philosophy of mandatory ventilation. Okay, so further breaking this down into some granular details, and we'll talk about VCAC here. This is what a typical waveform looks like, and you can see each of the breaths are delivered, and they look pretty much the same here, right? They're all mandatory. This patient happened to be passive, and so wasn't, for lack of a better word, fighting the ventilator. And so they all look really, really similar, right? And so if we kind of break this down into granular pieces, you have really two primary ideas or controls when you're setting up the ventilator. And that is control of oxygenation, in which you control oxygenation by setting the FiO2 that you're going to deliver to them, as well as setting the PEEP, which stands for positive end expiratory pressure. And what you can see here, I think, on the scaler is that when the pressure comes out on exhalation, the green part here being inspiration, the yellow part being exhalation, it does not come all the way back out to this stark line baseline here. So the lung doesn't completely empty at the end of exhalation, thereby keeping it open. You don't want your lung to completely collapse on exhalation. So those are your two oxygenators. That PEEP helps your oxygenation by maintaining lung stability, maintaining the alveolus in an open position so that you have surface area for gas exchange, essentially. The other side of your brain, essentially, would be ventilation, right? So you have two sets of controls, one for oxygenation and one for ventilation. Those sets of controls that control ventilation are the respiratory rate and the tidal volume that we had kind of alluded to earlier, all right? And so those are your four settings, really, that you think about and talk about with mechanical ventilation. The FiO2 and the PEEP, the rate and the volume, and then the fifth one, there's the mode of ventilation, all right? As we move down into pressure, it looks really similar, super similar. The only thing I'm going to switch out here is how I'm controlling that breath. And instead of setting the volume, I'm setting the pressure there, okay? So nothing fancy, it's just a different way of delivering that breath there, okay? So that's really kind of summing up the mandatory side of things. We're going to jump over to the spontaneous and kind of make sure that we cover those and kind of understand what's going on with that. So with the spontaneous breath, clearly the patient has to have a respiratory rate and a respiratory drive because you don't set one. By definition, this is a spontaneous breath, right? And so the ventilator is waiting for the patient to take their breath. It's not going to deliver anything to them in a mandatory fashion, right? And really, when we kind of break this down and think about it, the ventilator has two options, and it's either to help them or not to help them. And so we'll take the latter first and kind of talk about, and what this is the ventilator chooses not to provide any inspiratory assistance to the patient, right? Doesn't help them take any additional volume in, doesn't push any pressure in. All it does is feed them an FiO2 and keep their lungs open with a certain amount of PEEP. And what we call that is CPAP, okay? So there's no assistance with that. The patient is essentially all on their own. We're just giving them a little bit of oxygen. The other option that I kind of had posed was the ventilator sees that particular effort on behalf of the patient and decides to augment their inspiration with a little bit of push or a little bit of inspiratory pressure to help them take a bigger volume that they wouldn't otherwise normally be able to take on their own. And that's what we would call pressure support, okay? So pressure support, what we end up doing and kind of breaking it down, you have the same oxygenator controls. You feed them oxygen, you give them FiO2, and you're setting a PEEP so that the lung doesn't collapse. And on the ventilation side, notice that I lose my respiratory rate, but I'm setting a little bit of inspiratory pressure. And you can see this on the scaler here. If I was on CPAP, I take away the inspiratory pressure, and what you would have is just a flat line all the way across here on which the patient is essentially breathing all on their own, okay? And so therein lies the difference between CPAP and pressure support. And then as you attempt to organize this from 298 modes of mechanical ventilation, which we could have spent hours and hours talking about, we've kind of whittled it down to what you need to know about 4 of them. Volume, VCAC, PCAC, and then CPAP and pressure support. And those are the, what I would say, I guess, conventional modes of mechanical ventilation, mandatory being on the left-hand side, spontaneous being on the right-hand side. And what we're going to talk about now, maybe it's commonplace in your particular institution. You've heard it talked about. We certainly use a lot of it, and that is what's called APRV, which I'll be honest with you, is a little bit of a mix between the two of them. It takes the same ideas for that each of those mandatory and spontaneous have, that they kind of mix it. And so let's kind of look at this. This is the same kind of scalar graphic that you see, pressure being on the top, flow being on the bottom. We won't worry about the flow. I'll kind of direct your attention to the pressure waveform. And you can see that the ventilator puts pressure in, but it does so, kind of a little bit differently, right? Because it puts it in and it holds this for a really long time, right? So it puts the pressure in, and then that holding promotes lung recruitment and opening of what would be collapsed or atelectatic alveoli. All right, and so in such, you have 2 settings that speak to that idea. Putting pressure in, which helps to open the lung, and then putting it in for a long period of time, which helps to open those stubborn portions of the lung that are much more time dependent, right? And so what you have is what's called a P high, which is the pressure that I'm up top here, and I'm holding it for a specific length of time, which is called the T high, right? And so that you have a P high and a T high, and you leverage those for lung recruitment. At some point, though, you have to exchange fresh gas into the patient. You can't just hold this infinitely, right? And so you have to let bulk flow come out of the lung and then replace it, right? And so you then come to these other discrete settings here, which go right along with it. We're setting the time you spent up at the top pressure or the P high, and then I'm going to tell the ventilator, I want you to come down to a certain pressure, which is called the P low. Nothing earth-shattering or fancy there. And I'm asking the ventilator to hold it for a certain amount of time, which is called the T low. And what's happening here, again, is the bulk flow exchange of fresh gas into the lung. Notice here, though, that time frame is extremely short with APRV. And that is because what you're doing here with this P high and the T high is you're fighting for lung to open up really dense atelectatic areas of the lung, and in so you improve gas exchange. You do not want to then go down to this low pressure, risk the lung completely collapsing on itself, and then having to do all of that work all over again, right? So decreasing this pressure to the lower pressure is done for an extremely short period of time. And what I'm talking about is 0.4 seconds, 0.5 seconds, something very, very, very short, as opposed to the time up at the top, which is more like 4.5 seconds or 5 seconds. And that short time frame doesn't give the lung an opportunity to completely empty when it drops down to that lower pressure, okay? So essentially you have 4 settings with APRV, the P high and the T high, and the P high or P low and the T low, okay? Now here comes the mix, and the next layer is that each of these pressures that the ventilator is holding, that P high as well as the P low, what the ventilator allows the patient to do is actually spontaneously breathe at each of those pressures. What typically doesn't happen is breathing down here at this P low, because it's so short. They can, and you just don't typically see it. And it's fine if they do, but you typically don't see it. What I've pointed out in each of the arrows is a case in which the patient took a breath on top of that P high, essentially. And so a lot of people describe this as 2 levels of CPAP. I'm holding pressure steady, and the patient is allowed to take those breaths. Every once in a while, I release the CPAP to a lower level in order to exchange fresh gas. Okay. And so, that in a nutshell is what APRV is. All right. So we have 5 modes of ventilation, and some of them we definitely use on ECMO, but some of them I kind of threw in there, like CPAP, just for an understanding and fundamental purpose. We're going to kind of shift over to these prevailing concepts of lung injury now. All right. And so I hope the rest of my graphics, these are a little messed up, but that's okay. I'm on a different laptop, but we'll keep going here. So when you are mechanically ventilating a patient, and we'll say under normal circumstances, right? Just typical non-ARDS type of patients, I think your probable primary goal is to make sure that they exchange gas, right? You certainly are worried about hurting them, right? Putting too much of everything in or too little of something in, right? And damaging the lung itself. But I think your primary goal is to correct ABGs. However, as patients get sicker and sicker and sicker, what ends up happening is that your focus and your main goals shifts. And now preventing lung injury becomes the primary cause for mechanical ventilation, essentially. We'll get by with gas exchange, but we better make sure that we don't hurt them, right? And so in preventing ventilator-induced lung injury, I think it's important to understand how we hurt them. There's a couple different ways. I put up 3 words there. I'm going to apologize for some of my graphics that look funny here. All right, they looked awesome when I last saw this on my other computer. But in any case, you have a couple different ones, and these are what I would describe as the well understood ones, right? The ones that have been studied the longest, have the widest dearth of evidence underneath of them, right? And that is volume trauma, something called adolect trauma, and oxygen toxicity. Those are the 3 big ones, right? There's some emerging ones as we start to understand better and better how we're hurting the lung, and we'll get to those. But these are the 3 biggies, okay? And those are our primary concern now. In correcting these ABGs, I'll give you an example here and why we kind of shift our goals here. So in terms of volume trauma, really what that is, let's just kind of make up the example and just play off of the word, is that you're putting too much volume into the patient, right? And their lungs can't expand and accommodate that volume without overstretching themselves. And in such, you cause injury and inflammation, and you perpetuate what may be going on systemically, right? To correct that, you're going to clearly stop doing that. And so you would turn the volume down. When you turn the volume down, you will not ventilate the patient as much because you're not putting as much volume in and out of their lungs. And as such, their CO2 suffers. You stop ventilating them and the CO2 becomes hypercarbic. As they become hypercarbic, they also become acidotic, and we expect that. We, in fact, allow that to happen. It's called permissive hypercapnia. And this is what I'm speaking to here. In an effort to prevent lung injury, we make accommodations to the settings that we just talked about. But those accommodations have a cost to them, right? It costs too much to put the normal volume in, so we'll decrease it. But this is what ends up happening, is that we become more hypercarbic, or we have to turn the oxygen level down because we're just giving too much to a toxic level. So we turn it down, and therefore their oxygen saturation goes. Both of these are allowed. We let them happen. And so we rearrange our goals of ventilation and oxygenation here to stop making them normal. I've been doing this for 24 years, going into my 25th year, and I'll never forget one of the first things I ever learned, like 2 weeks out of school. I had all of these grandiose ideas during rounds. I wanted to do this and do this and do that. And the attending that we were rounding with just looked at me, and he looked at the patient, he looked at me, he's like, come here. And we walked over to the door of the room, and he's like, Eric, look at that patient in there. And we all looked at him. It's quite embarrassing. The whole team was there. And he's like, Eric, are you looking at him? I'm looking at him. He said, Eric, is that patient normal? And I said, no, Dr. Phillips, that patient's not normal. And he said, then stop trying to make him normal, and you're going to kill him if you do. So I'll never forget it, 25 years. And I still tell the story to whoever I'm teaching kind of on this fundamental level. They're not normal. So they will live with these particular goals of ventilation and oxygenation. So let's kind of expand upon this and kind of draw some pictures. What you see on the vertical axis is lung volume, and I put lung volume in, right? And we'll say in this case, we put a little too much lung or too much volume into this patient's lung. And now we're overdistended. We're overinflating the balloon. It's overstretching, okay? And so there's a line at some point when that occurs. You know, too much, the volume up here is just too much, but if we only put in that much, then we're below this demarcating line of overdistension. And so what we have there is this example kind of from a pictorial sense of volutrauma. We also have this idea of this opening and closing. I somewhat referred to it when I talked about APRV, and I also referred to it with PEEP. It is damaging to the lung if you let it completely collapse on exhalation. And it isn't damaging the collapsing part. What is damaging is when on the subsequent breath, it has to reopen. And it's not like this, you know, delicate like reopening of the lung. It gets shredded open essentially, right? And so that opening and closing cyclic injury every single breath, if you let the lung completely collapse on exhalation, is a huge source of injury. And that is what we call atelic trauma. It happens at a certain level, right? Just like a volutrauma happens at a certain level. And so when we're taking care of these patients, you have to somehow identify these levels, right? When does volutrauma happen and when is atelic trauma happening, okay? So we'll kind of back out and we'll kind of think about what these levels are. One of them, one of the issues is we're just putting simply too much volume. A normal mammalian tidal volume, every mammal, has a 5.4 milliliter per kilo tidal volume. And when we speak of humans here, especially here in North America, we have to speak of ideal body weight, all right? So with their ideal body weight based on their height and their gender, we know their lung volume size, right? And so we dose volume essentially approximately at what normal tidal volume should be. And so the volume should be 6 milliliters per kilo. If you go above that, and we typically allow a 6 to 8 milliliter range in non-ARDS or injured lungs. But if they become injured or they smell like they're becoming injured, you have to reduce the volume because it's not normal to have that much, right? And so you would decrease the volume here. And we alluded to this. We have our kind of first word that I want to introduce in terms of terminology. And the P, the capital P, stands for pressure. The subscript there is plateau, all right? And so a plateau pressure is a pressure in the lung at the end of inspiration. And it's not during inspiration, which can be quite high depending on the size of your endotracheal tube and the resistance and everything involved. But that's all occurring in the machinery and the conducting airways. What we're really worried about is the pressure in the alveolus, which we refer to as the plateau pressure. And what we know pretty solidly, right, is that you will start to overdistend your lung if the plateau pressure goes above 30. And so we do two things to prevent this volutrauma issue from happening. Two things that define this red line. We reduce volume to an operating volume of 6 milliliters per kilo, and we try to maintain that pressure, that plateau pressure, less than 30. And so we would reduce this volume, right? Now, speaking of this, the atelic trauma, what prevents atelic trauma is PEEP, right? If I increase the amount of pressure in your lung at exhalation, not inspiration, but exhalation, what ends up happening is that your lung will not completely empty, right? Our lungs don't completely empty, not intubated. We have surfactant, and we have what's called a functional residual capacity. So you and I walking around town have a built-in level of PEEP. As soon as we intubate somebody and that airway goes through their glottis, we negate the patient's ability to maintain their own PEEP. So we have to dial it in for them. And finding the right level of PEEP is tricky, right? Finding the right level of PEEP for that particular patient is tricky. So we have to set the right level of PEEP at this moderate level. And your idea here is you're painting the picture in your head is do not let the lung collapse and become atelectatic. And so you end up designing a breath or shaping the breath as it goes in. It is assist control, but those granular settings that we kind of referred to in the first couple of slides in terms of volume and PEEP become really important in preventing injury to the lung in these two mechanisms, volume trauma and atelic trauma. And so now, instead of letting it all the way out and then overinflating it, I have this nice tight little area in which I'm no longer injuring the lung. There's this third, this other mechanism of lung injury that is emerging. This paper here is 5 years old. This is affectionately within the critical care mechanical ventilation world called the driving pressure paper, right? And what this is, it was a fascinating study. It was an individual patient meta-analysis of close to 3,600 patients, all of which were enrolled in the historical ARDS clinical trials about how to ventilate these guys. And so the authors went back and looked at the ideas that built upon what are kind of bread and butter, that volume trauma and atelic trauma. And they said, what really does result or cause mortality in these patients? Is it that volume? Is it the plateau pressure? Is it the PEEP? Or is it any of these other things, right? And so they did pretty sophisticated statistics, well beyond my understanding of statistics, right? But what they did was regression analysis and tried to understand what is most closely associated with mortality in these particular ARDS patients. And all the things that we talked about so far kind of, didn't really closely associate. Even the biggies, right? That you would say, wow, if I'm giving my patient 100% oxygen, they're probably going to die, right? And even that wasn't the most closely associated parameter. Even the Apache 3 scores, they're just got a laundry list of problems. That wasn't. But what it was, the most closely associated variable was this thing called driving pressure, which is the difference between plateau and PEEP. And so if we go back and think about, and I should have a graphic here that shows us, I have one coming up, but the difference between plateau and PEEP really is, if we think about it, right? And you think about a rubber band, and if you stretch a rubber band out like 12 inches, right? That end stretch, we'll say at the end of the stretch is 12 inches, right? If I start from 0 and go to 12, that is your driving pressure. The PEEP, which we said is 0, to the end of the stretch or the breath is the plateau, that's 12 inches. And so if I go from 0 to 12, that's my number. But if I say, I'm going to increase my PEEP here, and I'm going to increase it to 6. Now I'm going to stretch from 6 to the same end pressure, the same plateau of 12. The amount that you stretch the rubber band is clearly different, right? And so if you think about just doing that manually in the dexterity of stretching, really stretching far apart a rubber band versus only stretching it a little bit, you can kind of get a glimpse of, wow, that's going to hurt a tissue if I keep stretching it in such regard, right? And so that's what the driving pressure is how much you actually stretch from beginning to end during inspiration. So I have cumulative survival curves here, and the tidal volume, which we think is pretty important. Like I showed you that, right? We gotta reduce the volume and we gotta reduce the plateau pressure. Actually, didn't correlate with survival at all. There was no difference between whether we gave them a lot of volume or a little volume by itself, right? And if we looked at that all-important plateau pressure that I had also alluded to in the same regard as volume trauma, that line lays right on top of each other. Patients with a high plateau pressure versus a low plateau pressure actually wasn't correlated with death at all. It was exactly the same. However, driving pressure, you had a clear difference, a statistically significant difference in survival. Those with a low driving pressure or low stretch had much better chances of survival than those with a really high stretch during inspiration. And so that how much becomes really important. This is a survival curve here. Anything above 1, you increase your risk of death, right? Your relative risk of death is anything greater than 1. And so you want the driving pressure, which is along the bottom here, to be lower than 1.0, and that is somewhere right around 15 when that relative risk of death curve crosses that 1.0. And so we have to then think about this and kind of throw another idea of injury into the mix. And this is the graphic I probably should have put earlier, is that difference between the PEEP and the plateau, how much you stretch, called the driving pressure, matters. And it actually matters more than all of them. All right. This is an associated injury. It is yet to be causal. There is no prospective randomized controlled trial yet testing driving pressure. There have been several retrospective meta-analyses about the importance of driving pressure, all of them coming to the same conclusion, that it is the most closely associated variable. So I put it on kind of the tail end because it has no PRCTs with it yet to make it guideline type of material. But I can assure you, we pay attention to this all the time. Every day, every hour. What's the driving pressure? What's the driving pressure? All right. And so what this ends up looking like is that not only do you have to protect against volume trauma, and not only do you have to protect against adolic trauma, you also have to reduce the driving pressure in some way, whether that's by even using less volume or using even more PEEP. But in some way, you got to scrunch up that waveform that I have there so that you have a lower driving pressure and a better odds of survival. And our goal is 14 or less. We got to keep it 15 fine enough. That's where it kind of crossed the line. So we say, don't go to 15. That's an equal risk of death or survival. We keep it 14 or less. All right. And so you have 3 primary big mechanisms how the ventilator actually hurts you: volume trauma, driving pressure, and adolic trauma. So strategies to prevent them kind of line themselves up like this. Well, like, all right, like, how do I set this up then? And, you know, we'll say that this is the roadmap. Speaker ahead of me talked a lot about a roadmap, and the roadmap for treatment or support, mechanical ventilation support in ARDS is dizzying. You know, like, what do I do? But I think we have some clear indication of what to do, right? At least in the beginning, all right? The American Thoracic Society, European Society of Intensive Care Medicine, et cetera, all the major medical societies got together and published guidelines on mechanical ventilation in adults with ARDS. They did this about 3 or 4 years ago now, right? So in 2017. And the 2 very strongly supported recommendations are on your screen here. The first being what we just talked about, low volume ventilation, and you have to limit your plateau pressure. The second one was the idea of prone positioning. And I'll kind of go through this really quickly. We got about 15 minutes left. So we'll kind of speed through a little bit, but this is a landmark paper in mechanical ventilation. It's 21 years old now, so 2 decades, but it is the paper that told us what to do and what these guidelines are. It was a randomized controlled trial of patients that received 6 cc's versus patients that received 12 cc's per kilo. Right, there was a statistically significant difference in mortality. Those patients that received the 12 cc per kilo tidal volume had about 39% mortality. If you just reduce the volume to 6 cc's, it went down to 31.8. All right, and so that's what we do. That's why we do it. And in such, because we decrease the volume, you have to accept a different goal of mechanical ventilation. All right. So in continuing to move forward with some pace here, that second recommendation comes from this particular paper, which was in 2013. This is what's called the Perciva study, right? And so that's what's listed down there. We had long used prone positioning. What the data prior to 2013 largely showed us that it improved the patient's oxygenation, but it had no effect on their mortality. All of those studies being flawed in power, in numbers, in protocols, in what they did on the ventilator when they proned them. They were all different and nothing could be made out of them until, excuse me, until this study, which was a huge multi-center PRCT, 26 ICUs in France, 1 in Spain. They enrolled a ton of patients for a critical care study, all of them having severe ARDS with a PF ratio of less than 150. They randomized them into 2 groups. One group was a prone group in which they flipped them over on their face for 16 hours a day. They then gave them a rest for 8 hours a day. The other group, they just stayed supine. The way that they ventilated them was according to that study that I just showed you. So the mechanical ventilation strategy was not the agent that they were looking for. In fact, they kept it similar between both groups. They were specifically looking at, does proning work or not, right? The primary outcome of this trial was 28-day mortality. And this is your Kaplan-Meier curve. You had a huge reduction in mortality, close to 16 absolute percentage points reduction, which is huge in a critical care study. Practice changing. It is why if you spend any amount of time in an ICU right now, you see every one of these patients that are really sick, you see them prone if they're following any guidelines whatsoever at all. And so that's why we prone patients, because you significantly improve their odds of survival at 28 days, and it was sustained all the way out to 90 days. So hence, those are the 2 big recommendations. And now we have some semblance of a map. We conventionally ventilate patients. We diagnose them with ARDS. And then at that diagnosis, we go into action, essentially. We use that low volume, 6 cc's per kilo. We limit the plateau pressure to 30, and you should prone them. All right. However, what ends up happening is you quickly run out of road in a lot of patients, close to 20%, right? 16, so 1 out of 5 patients, this bread and butter stuff, what we should do, doesn't work. You got to figure something out, all right? You got to figure something else out, unless you're okay with a 20% mortality, right? Which no one is, all right? And so that's why you kind of keep going and keep looking. And so this road ends in a bad position. And I would contend it is basically this idea that in protocolized medicine, which I am a complete proponent for, don't get me wrong by any stretch of the imagination, we have to use these protocols. But in using protocolized medicine, you treat everybody the same. You can't you're not going to get away from that if you use strict protocolized medicine. What the key is when to hop off of the protocol, right? When to say, this isn't working for this one patient. And so in particular, we have a little subset of patients, right? That this protocolized medicine of low volume, low pressure, prone positioning isn't going to work out for them. And so we have to figure out how to treat that one individual patient, how to individualize what we're doing with the ventilator for them, right? And maybe this works for some people and maybe it doesn't work for other people. And we got to figure out what their what that patient's plateau pressure is, because although this may work for everybody, that particular plateau, it may be over distending and too much for this one patient that's still really sick. And although this level of PEEP may work for everybody else, we may need a different level of PEEP for them. And so somehow you have to figure this out. And this is kind of one way to do it. There's a gathering evidence base about how to do this. And it's by using and measuring and then using the transpulmonary pressure to guide your mechanical ventilation in those settings. And so what I mean by transpulmonary pressure is the difference between the pressure inside of the lung and the pressure on the outside of the lung. And that pressure on the outside of the lung is specifically the pleural pressure, right? The pressure that we talk about inside of the lung is that alveolar pressure, okay? And so transpulmonary pressure, that difference between the two of them, is becoming more and more and more important, right? And this is just the equation. It's the difference between them, alveolar pressure minus pleural pressure. The way that we get that, though, we clearly cannot put a pressure manometer in their pleural space, right? I'm not sticking wafers in them and measuring the pressure somehow. I have no transducer to do that. What we do have, though, and it's a pretty good surrogate, is esophageal pressure. And so what I do and what we do in our practice is that we have a simple gastric tube that has a balloon on it, and we insert it into the esophagus. The balloon lies in the retrocardiac position in the mid-thorax, essentially. We transduce the pressure inside of that balloon, and that esophageal pressure has been completely validated to be a surrogate for pleural pressure. Now, there's lots of, beyond the scope of this talk, there are little holes in that concept, meaning your pleural pressure is different at the top of your lungs and at the bottom of your lungs. There are some differences, but this is a pretty good measure. It's better than what you have without it in, right? Without it in, you're just guessing and wondering why your patient's getting so sick continuously, right? And so this is why it works. So let's say that you have a PEEP of 12. You're doing what you're supposed to be doing here, right? And you think you're doing okay. PEEP of 12 is holding that lung open. But what if I measure your pleural pressure and the pleural pressure is 18? So the pressure around the outside of the lung is pushing in here, and that is being counterbalanced by the pressure on the inside of the lung, PEEP, holding it open. And what can be predicted here is that the pleural pressure is going to win, right? It's going to completely collapse the lung, right? And the lung will de-recruit and become atelectatic. And now you're set up for atelic trauma, even though you think you're doing the right thing here, right? And so in this case, the expiratory, because we're on speaking of exhalation, is that transpulmonary pressure is 6 or -6 here. And our goal here, just from my picture, is that you got to increase your PEEP here, right? You have to increase your PEEP to at least 18 in order to keep this alveolus open. And so that, in a nutshell, is how you use this transpulmonary pressure to guide mechanical ventilation. You have to have the ability to insert these balloons. You have to be able to transduce them. You know, you have to have that expertise, but, you know, more and more people are using it in this fashion. I'm going to skip this particular slide. So within the next 9 minutes that we got here, I can at least touch on some of these mechanical ventilation strategies and how we then put them onto ECMO. And I'll just kind of preface this. We don't change the rules. We don't change the rules. We become a little more cautious, but we do not change the rules. What injures the lung off of ECMO is the same thing that injures the lung on ECMO. So I think we've spent 50 minutes at least trying to build that foundation of volume trauma, atelic trauma, and driving pressure, the importance of those. And when possible, using that transpulmonary pressure idea, and then flip them over. It's the same ideas and same strategies. So this was a nice review about 7 years ago now about these things, these ideas that we talked about. What injures the lung? All right. And so it's the same thing as you look upon here. Allow the lung, just reduce the volume really, really low, limit the amount of pressure, make sure you have enough PEEP. Don't limit the amount of FiO2, monitor the transpulmonary pressure so that you prevent these sources of injury, right? And so what we end up doing is kind of rearranging this idea for that particular sick patient, but you have to individualize it. You have to customize it, right? As much as you can. So this is what exists out there now, right? Which I will tell you, there's a paucity of data. There's none. There's hardly any. I'm not sure that I'll get to show you the one randomized control trial, but this is what we got, which is a whole bunch of people throwing it at the wall and seeing if it sticks, type of thing. That's what's up so far, right? We're on to some things, but nothing guideline or earth-shattering quite yet, but I think we're almost there. So in this paper, the authors summarize, the strategies based on ELSO, based on REVA, and then the two big randomized controlled trials that had to do with ECMO, but really weren't testing mechanical ventilation strategies as much as other things. This is just kind of what they used, right? And so in the ELSO guideline, I've drawn these for you. You can see what I'm doing here. I'm using 10 of PEEP and I'm limiting the amount of pressure a lot. So I'm going ultra protective. Before it was that plateau pressure of 30. Now I'm not using anything more than 20. The amount of PEEP that you use though here, based on ELSO, I would argue does not necessarily protect this patient against adduct trauma. That's pretty low. It's pretty low. In the REVA, with H1N1, they recommended kind of a range, which was the same range to a little bit higher range of 15 of PEEP with no more than 25 of pressure. But the same idea is if I drew those red dotted lines, you're staying within that little nook, that little area of safe ventilation. This is the Caesar trial, same thing, same exact thing. And then this is the Eolia trial, right? This is the big one that a lot of people talk about. And these are the two mechanical ventilation strategies that they offered that you could use. And you can see they're the same, right? That they pull the pressure down as an option, or they use that APRV strategy that I talked about. But the pressures that you put in the lung are the same. So, whether you put it in for a short period of time or a long period of time, I'm still kind of following those rules. I'm going to quickly wrap this up because I'd like to leave you 5 minutes. I'm at the 6-minute kind of countdown here, but I'd like to, see if you have any questions. But I'm going to leave you with this. There's one prospective randomized control trial that was published last year, and it was well done. It was only a single center though. They enrolled 104 patients, and what they did is that they randomized them. They were all on VV ECMO. They randomized one group to get the ventilator settings guided by that esophageal pressure and transpulmonary pressure. That's how you set up your PEEP. You didn't guess at it, you actually individualized it versus what I just showed you. You guessed at it, you put it about 10 or 15 and, kind of hope for the best, right? Primary goal, successful weaning. Secondary goal, mortality. And I'm going to go forward here a little tiny bit, and we're going to get to the big endpoints, okay? So you can see transpulmonary pressure group here, proportion, this is the primary endpoint, the number, and then the percentage proportion of patients successfully weaned from VV ECMO. 37% successfully, or 37 patients, 71% successfully weaned versus that lung rest group, 20 of max pressure, 10 of PEEP, 48% reached a statistical significance. So did the 60-day mortality point, as well as the duration on ECMO, 11 days versus 16 days. So this is the first inkling that we have here, the first well-done prospective randomized controlled trial about what on earth to do with these patients on ECMO, okay? But in the absence of that, you have to follow the rules, essentially. We've been proning a lot of patients. You may see your ECMO patients being proned a lot, and that's because the literature is starting to be populated by such. There is no prospective randomized controlled trial yet. Hopefully there will be one soon, but I've just thrown 4 of them up here All right. All within the last several years. So we prone a lot, almost all of our VV ECMO patients, unless something is holding us back. All right. So that's what we get. All right. Mechanical ventilation on ECMO, prevent the lung from injury. All right. This is what we talked about throughout the course here. We'd go ultra protective, much lower volume, a little bit lower pressure, keep the driving pressure lower, and prone them. There's this emerging idea of a wake ECMO, which we've dabbled in quite a bit, where we just extubate them. But these, I think, are your two options. All right. So that is 57 minutes. All right. So I'm going to stop sharing and we'll open it up. Is there any questions?
Yeah, thank you, Eric. We just have time for a little bit, but the chat board was just wide open. I think the consensus is that perfusionists don't get enough training in their schools with respiratory therapy basics. And I know from being in the ECMO or the ECLS clinical manager for our company that we're lacking in that as a profession. So your information was well taken. One thing I want to ask is, you didn't really focus too much on FiO2. At one point, it was thought that 60% was okay, then 50%. Now we're seeing a possible difference between 30 and 40% FiO2 relative to the inhibition of the adenosine 2 receptors. Do you have any comment on that?
So yeah, you're right. It's all about reactive oxygen species, which accumulate. That's a big fancy word for oxygen free radicals, right? The higher the concentration, the more propensity you have to form these free radicals, which cause cellular damage and cellular death, right? And then end up in fibrosis. Hard human study. It's a hard human study to do where you isolate the FiO2. I don't think anybody's signing up for that. I'm not sure any ethics board is even going to pass it, right? All of our data comes from animal studies in which we give them 100%. And yes, we're slowly, less is better, right? And that scale is going down. The numerical value typically thought of is 60% for longer than 24 hours. You start to incur those oxygen toxicity issues downstream. Well, I think what we're finding is less is more in this case, right?
Comment. Thank you for that. Last comment. Why would you want to recruit lung tissue while you're on ECMO? So a lot of people are using even lower tidal volumes on VV, say 2 to 4.
Sure. And you know what? We don't know. I think there is this idea that you're either going to go one of two directions. And you know, in our practice, that's what we do. If the lung has any potential for remaining somewhat open with safe settings, then we go ahead and just gently keep it open, essentially. If there's no potential, the X-ray is a complete sheet of white, there's no aeration, we go away from the ventilator and we actually let the lung completely down. So we do a little bit of both. It is based on that potential though. I don't know that we know which way is, I know we do not know which way is better. All right.
Excellent.
Yep.
Thank you very much, Eric.
Absolutely. It's my pleasure.
Yeah. Thank you so much for sharing your information.
Absolutely. Do you need the slides? I'm
Sure,
happy to make them available.
That'd be great.
Yeah,
okay.
Happy to make them available.
Yeah, great slides.
Thank you.
Thank you.
Okay, absolutely. All right, guys, take care.
Thanks.
Have a great conference.
Thank you. Okay, I'm going to turn the meeting over to Ty with our Shark Tank. Take unmute.
Boom, 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 boom. We are now going into Shark Tank. Usually this is a poolside event. We usually have pizza, and Ben, hopefully you basically bought pizza for everybody at this point in time. But we want to thank Medtronic for making Shark Tank happen in a virtual way. We're looking forward to this presentation. And again, Ben is a senior principal clinical specialist from Medtronic in the structural heart division and brings 20 years of experience in anticoagulation management. He's routinely helps in programs improve blood product usage statistics utilizing the HMS, as well as refining protocols more closely monitor heparin consumption on bypass. Please join us in welcoming Ben. Also, I want to just let you know that, again, in blood management, I felt like the HMS. I worked with Linda Shore for years in the early processes of the HMS. We gave talks all over the country during that period of time. And I think it's one of those key puzzle pieces in blood management in the surgical arena. So welcome, Ben, and
thank you.
You're going to start us off, and we're going to basically, then we're going to open it up. We have panelists on board. We're going to open it up. He's going to show the questions that you need to be concentrating on, and we're going to then open it up for panel discussion. This is kind of like a fireside chat. So please, Ben, we welcome you, and thanks for Medtronic for sponsoring this event.
Thank you. I'm assuming everybody can hear me. That's the question of the last 18 months. You can hear me. That's perfect. Well, thank you. Thanks for having us. Medtronic is thrilled to be a part of this symposium and this particular initiative and component to the blood conservation puzzle that you all face. I'm going to go ahead and share my screen, and I'm going to run this. Sorry, Ty, I couldn't get that fancy shark, the shark photo as my first one. It wouldn't import right, so I'll have to work on that, more IT stuff. But I'd like to talk with you all about the anticoagulation management and the challenges today in 2021 that involve the more savvy use of monitoring your patients in terms of heparin and protamine, as well as an intraoperative dive into a look at heparin consumption that the ACT alone may not share. My name is Ben Smith. I am a senior principal clinical specialist, and this is my 11th year in representing clinically the Medtronic HMS device. I go east, west, north, south. I see a lot of different protocols in place. I'm fortunate to speak with a lot of different programs about that, about how they monitor their anticoagulation. And there's some things that are universal nationwide, and that's what I'd like to talk about. The first, sort of to step back before we get into the intricacies of the HMS, is let's look at globally what we're doing. And in terms of cardiac surgery, your goal is to suppress and quiet the hemostatic activation. And there are two main sources that this is happening. One is factor 12, which is contact activation. I think of that as your circuit. I think of that as perfusionist. Your oxygenator, your tubing, everything that you all do has a direct impact and a profound impact on factor 12, which is contact activation. The other piece, and this is as elaborate as I'm going to get on the coag cascade because it's a Friday afternoon, but the other part.
Ben, I just want to make sure, do you have slides that should be shown on this, or is this just the opening?
I'm sharing my screen right now.
We don't have any screens set up at this point in time.
Sorry. How about this?
There you go. There you go. Now go to full screen.
Do I get to repeat myself? That's fantastic.
Well, we'll basically.
How about that?
If I was a shark, I'd already bitten your leg off by now. Okay.
So is that, you can see now, great?
Yes.
Okay.
Correct.
Great. So that was me, and here we are about the very basic review of the coagulation cascade, and two sides that are really activating thrombin, and that's factor 12 and factor 7. Factor 12, I think of factor 7, the tissue damage, as the surgeon, the cutting, the sewing, the assault on the thrombotic system via tissue manipulation, vessel cutting, retrieving the IMA, retrieving saphenous veins. Those are the two most direct ways that thrombin gets absolutely ignited. And when thrombin is ignited, there's an elaborate process of things that sub-ignite, like platelet activation, complement activation. It just cascades down there and there. So the goal is to quiet the thrombin activation so fibrinogen doesn't form a fibrin clot cerebrally in your patient and in your circuit as well. How do we achieve this? By unfractionated heparin. It's raw, but it works. It's fast, but today is more of a challenge than ever in the way heparin metabolizes and the way we can get to a safe level to be properly and legally and safely on the bypass pump. The mechanism that heparin works is, as we know, is simply through the level of AT3 in the patient's body that inhibits thrombin. The variability of heparin in talking about what can rock your world in terms of response, what will throw you off as a perfusion team and as a CV group. It used to be a couple things. Good old 20 years ago, a couple things would throw you off. It was more reproducible. It was more predictable. That is not today in 2021. When I look at what causes the variability of heparin, the patient, I slot it number one because it really is number one. And the level of antithrombin 3 that the patient brings to you all is paramount in the ability for you all to proceed safely and legally and correctly in bypass. It's just huge. It's one of the main topics I deal with is, could Medtronic make an AT3 test? How can we glean some information from the current HMS about an AT3 level? We'll talk about that because you can. The preoperative exposure to heparin that the patient has, and really any antithrombolytic from the cath lab, from a heparin drip, from warfarin, from an antiplatelet drug, from Plavix, all those will really rock the way that patient is going to metabolize and respond to heparin when they land at your feet as your patient. The interesting thing that I see more and more, and a more discussionary point on the West Coast, is a lot of the over-the-counter supplements. The three big G's, ginkgo, garlic, and ginseng, all those also affect the responsiveness to heparin and actually make you more resistant to heparin. So that's the patient, and that's the list of what can make a patient a patient heparin resistant is very long. I really did a sort of a one-line summary of the three main pieces, but then we move into what else makes heparin variable, and it's the molecule of heparin itself. And the difference in chain lengths will also impact how well and how fast and how responsive that patient is. The half-life and the anticoagulation response is not what it is today versus 8 or 9 years ago. And we'll talk about that for a second, because that is a big challenge. The brand differences are also profound. And you're in a bit of a hostage situation when the pharmacy will give you a brand new lot of heparin that they got because the heparin rep came in and they switched it up on you without any really due cause or due notice other than price. That's something you all live with, and it's a challenge at best. So these things will make heparin themselves rather variable for you, and that's an understatement. And when we think about the longevity of heparin and the different points in time when it really threw a wrench into your ability to manage anticoagulation, back in 2004, we changed from bovine to porcine due to mad cow disease. Prior to 2004, it was a different day. It was a much different day. Bovine, just so much more reproducible. It's always the good old days of heparin of, remember prior to going to porcine, we could give 300 U per kg, which was common back then, and get near our 480 mark. Boy, is it different now. And then in 2002 or 2012 and 2013, we actually changed our source of heparin to a international source from China, from India, from overseas, and they all have a recipe of strength that matches the WHO's strength. So when we were used to giving 300 U per kg, sometimes even 400 U per kg empirically, and getting up to that safe 480, not the case. Not the case. That was a rough area for you all. It was a rough span of time to try to figure out what's going on. I'm not staying at 480. I'm dropping quicker. My bolus isn't getting me to target. What's going on? So our solution is to better get our handle around all these variables that are bombarding you is with the HMS. And the HMS is not a new device in any stretch of the matter, but we've never had a busier time with helping programs solve their problems of anticoagulation management. You would think that an instrument that has such a storied position within the cardiac market would sort of, stay steady or start to decline year after year. It's more market share, it's more impact on the clinical management that hospitals enjoy because they can't get their arms around managing that patient correctly and more thoroughly, as thorough as they need by running just an ACT. So the three tests we're going to do a quick review is the HDR, the ACT itself, and then the heparin protamine titration. Those are the three cornerstones of the HMS Plus. And when I think of, this is a Sanibel meeting, this is a Florida meeting. I know that it's attended internationally, but when I think of the amount of market share that is used geographically in the US, Florida has always been a leader in using this device. They have been a leader in understanding the challenges of heparin and protamine management and the need to go deeper and beyond what an ACT on pump can provide. So chances are the reach of my voice and the reach of this Zoom, I'm sure over half use this. So hopefully there's something for you all to learn as well. The challenge is when we go back to the heparin calculation piece and how instruments are going to respond, the first thing you're going to use on the HMS is the heparin dose response. People call it the candy stripe, the candy cane. I hear those very commonly. But what that does is that's going to calculate the ACT and titrate the ACT at 3 different known amounts of heparin. So rather than just doing a baseline and seeing if you're high or low, or if you're maybe on an anticoagulant or not, that's sort of where the baseline lives. We're going to test the ACT with a 6-point curve. It's a bull curve. And the 4 pieces of data that this instrument gives, I rank them in order of what I view as an important part of you knowing exactly what the case is going to entail. And the first piece is the slope. And not everybody uses the slope. Even long-term users don't really understand what the slope is on the strip. The slope is the increase in ACT with every unit of heparin per ml of blood. And in a perfect world, you might be in the 90 to 100 range. So my slope is 95. You give me 1 unit per ml of heparin, my ACT will go from baseline of about a 127 up 95 points. And it does that. It's very linear up to about 6 U per ml. When you get your HDR result, that's the first thing that I think you all should look at is the slope number. It's on the second page of the instrument, but it's also down about midway on the HDR strip. And that really sets the tone for the whole case. The lower the slope, the higher your level, or the higher the amount of heparin you're going to need, because you're showing a lack of growth and a lack of increase among those 3 levels. So it's calculating how responsive you are. And this has been a very good way for we talking about AT3 and AT3 deficiency. How can you use this device to help guide you, maybe to possibly give AT3? This is the number that will guide you to that. If you have a low slope, one of the choices you have of the typical 3 choices on how to correct a problem responder is to give AT3. You could also give FFP. You could also just go with the larger bolus of heparin. That's fully up to you all clinically. But I see more and more hospitals adopt sort of a hardline slope number as a time to give AT3. A common number that I put is 65. That seems to be a very common slope value to indicate that you are running far below your normal 90 to 100. One account in Charlotte actually uses a slope of 80 to give to give AT3. That's one of the higher amounts. That's one of the higher slopes that I've seen to give AT3, but they use that slope number. And if it is 80 or below, AT3 is given and they correct the response. The HDR will also give your baseline ACT. It'll give you your heparin bolus amount to achieve near whatever target ACT that you'd like, commonly 480. If you're using a TAVR, you can also channel 350 if you wanted to use this for the TAVR. It's the same cartridge, it's the same slope, it's just a different point of achieving on that slope. The last piece that this HDR gives is the heparin concentration to maintain on bypass. And we'll talk about that. There's the most amount of questions about that. And that's the one piece of this puzzle that is often confused. So we'll review that, and that will spur some great conversation. So this is the HDR. Just as a side note, these can be stored room temper in the refrigerator, and there is not external quality control required for this test. I know Perfusion, you love to do QC, right? Bring on the QC. I've never heard that ever, but there is not any external QC. All you need to do for those using this test in your program is keep track of your slope values to make sure that they don't drift. The average slope among maybe 50 don't drift beyond 12%. That's your only really legal requirement of what you all do on an ongoing basis for this test. So the way it works, you've got 3 levels of heparin in duplicate. And if we wanted to be at a 480 ACT, this patient would need about 3.7 U per ml. So on pump, we're going to maintain a 480 as well as a 3.7 U per ml. This is interesting. This is actually 2 separate real people, real responders that had the exact same baseline ACT of about 115. And you'll notice that one line takes off more and one doesn't. Well, who's going to need more heparin? Well, if we want both at 480, the top line is going to need about 3.7, bottom line 5.4. Same baseline ACT, same starting point, but did they grow different in response? So let's talk about some of the ACT itself. And this is the third test. And this is the one that we're all very familiar with, but I think we collectively as a clinical group understand the limitations of the ACT. The ACT is a global test of anticoagulation. It's global. It looks at all parts of the coag cascade. It's not specific. It's just going to look at the effect of heparin and the ability to generate a fibrin clot at the end of that. The problem with the ACT is it's not specific to heparin. If the ACT was specific just to heparin, that would be tremendous. We may not need a lot of these other extraneous additional tests, but every ACT, whether it's a hemocron, an iStat, or a Medtronic ACT, which is my personal favorite, they're going to get extended incorrectly. They're going to get a false positive due to the two main culprits, hemodilution and hypothermia. That's the world of perfusion. That's what you all are doing to the blood, is you're diluting it and you're most likely cooling it. Even if you drift a couple of degrees, you'll still have an artificial extension in the ACT. Coagulopathies, those will also extend the ACT as well. So in terms of the specificity to heparin, it's not great. And I think we can all collectively agree that it's not great. But what do we have? Well, this is what we have. We have a way to monitor the coagulation status above and beyond the ACT. We're going to monitor the ACT. It's vital information. And we're not anti-ACT. We just understand the limitations of what it can tell you all. So this was a rather long pump run. This was an ACT. And if you look at the time of the case, it was a very long pump run. And I thought this was a nice indication that despite giving the patient a ton of heparin, they sort of started off with a bolus of heparin. They wanted their ACT above 450. I think they had a coded circuit, but the ACT just drifted up. It just took off because that's what ACTs do. The blue line, the bottom line within the blue box, the green line in the blue box, that is your heparin assay. That is a concentration run in conjunction with the ACT that is a much more steady and indicative measure of heparin metabolism than the ACT. So when the heparin level is leveling out and then starts to decline, the ACT is still taking off. It's still taking off, beyond 700, almost beyond 800. So we see this commonly in surgery where the ACT is really growing without any heparin, and it's a function of what's happening in the perfusion side of things, temperature and dilution. And a question I often get from new users is, so what? I've got an ACT of 600. I'm fine. I don't see any clots in my reservoir. I don't see any microemboli. Why am I really concerned? And why am I concerned with anything beyond a high ACT? This is actually my favorite slide of my whole deck. And I think part number one is the most telling. This is what I consider the engine of the HMS. And that is, if you have a high ACT, but you're running actually behind the scenes low in heparin, you have a high degree of hemostatic activity and factor consumption that as perfusionists, you don't necessarily see. If you're just looking at ACT, you're getting a false positive from dilution and temperature. Behind the scenes, a more accurate test, such as a heparin assay, run at the same time on the same sample, is going to give you a different line to trend. And the particular line that you're going to see with that particular assay is specific to the metabolic rate and the consumption of heparin. So even though your ACT is going to drift high, we all know it does, that level of heparin in concentration form will give you a truer snapshot of how you are behind the scenes. And the goal is a dry patient. The goal is a long-term goal is to have a patient not needing blood products in ICU or needing to have a redo, a bring back to the OR. That's, your goal is to your patient be better, to live a better quality of life, but also not to have those downstream effects that happen if you've been under anticoagulated. So this is my favorite slide of the whole deck, because it really talks about how behind the scenes, unbeknownst, there are hemostatic elements in play. There's hemostatic responses in play that you just don't really see at the bypass pump, or the surgeon sees at the table, or anesthesia sees at their place, but it's happening. So this is our goal, is to maintain that heparin level on point as well in ACT. And we do this with the heparin assay. And the heparin assay, commonly called HPT, heparin protamine titration, it's going to give you that quantitative analysis of heparin level via protamine titration. So where your ACT is literally dirt and blood, important in generality, this is not dirt and blood. This is a heparin concentration test. And inside the cartridge is protamine sulfate, different amounts of known protamine sulfate. But the clotting platform doesn't get skewed like an ACT does. It's thromboplastin. And that is that particular clotting substrate does not get those extreme false prolongations with the things that prolong an ACT. Because you're looking at, in concentration form, you're looking at a certain number, let's say 350 U per kg. Despite what your ACT says, when you're lower, it knows and it recommends a rebolus amount. And the idea is that when you rebolus based on your heparin level, you're keeping your patient out of that hemostatic, thrombolytic active state where you're consuming factors. This particular test, we've got a 4-channel and a 6-channel, depending on what you all prefer. I like a 6-channel cartridge. It's like getting 2 in 1, but then you'd have to do your ACT right after. But if you, just as a side note for you users, is you do pull a full 3 mLs of sample and initiate a 6-channel HPT, there is enough blood with a proper 3 ml full to complete your ACT without having to redraw. Just as a side note, as you all look at managing your inventory and how to best manage the number of assays you use, I have a lot of folks that go from having a two cartridges to one single one. They still do it with every ACT every 30 minutes. That protocol doesn't change. It's just one less widget to manage and one less thing to QC. This test also determines the amount of protamine that's required at the end of the case based on the amount of circulating heparin that it detected. Protamine, the variance, I thought heparin dosing could vary. Protamine dosing varies dramatically. It's almost can be by physician. It's that dramatic. A common protocol that I saw probably 5 years ago, when we're just kind of getting out of the fog of the weak heparin and knowing how things work, was giving 400 to 500 milligrams to everyone. That is a lot of protamine. And the idea that you're overshooting your protamine is a huge talking point to the value of the HMS and how we can correct that. So what this will do is based on the titration is discover the amount of protamine needed to reverse that last part of heparin that's still circulating in the patient's blood at the end of the case. Because there's bookends of the case. The heparin it doesn't clear in a linear fashion. There's consumption at the front, there's a high degree of consumption at the end, and it seems to level out more in the middle. But as you warm up towards the end, you're really going to reduce your heparin. And to just sort of give a larger guess dose based on everything that you've given, I think you're really going to overshoot it. And when you overshoot the protamine, well, this slide shows you sort of the anticoagulation effect that excess protamine will have on your patient. This is just a visual of how the channel in the cartridge that has the matched amount of heparin and protamine will clot first. If you put on an all-channel detect feature on the HMS, you'll also get a run time of where the other channels that have excess protamine will also stop. And this particular graph shows that we discovered that the patient has 2.5 units of heparin per ml of blood. But the next channels of the cartridge, the 3 and the 3.5, had an extension in clotting time. And that shows that the more heparin or the more protamine that you have in relationship to current circulating heparin, the more of an anticoagulation effect you're going to get. So it can be profound. And what you'll often see is that globally, if you added up the amount of heparin that you're giving versus your maybe old empirical amount of 300 or 400 U per kg, you're probably going to end up giving more heparin throughout the case and more collectively, but you're going to really reduce your protamine. That's what most studies show in a collective summary, is that you do increase your heparin some, but you really reduce your protamine. So I'm a fan of this particular graph. It's not brand new, but I think if anybody repeated it, you'd get the same sort of data. And that excess heparin versus protamine will extend in time. And the same is true, excess protamine versus heparin will also extend in time. And what does it mean? It's like, well, so what? My patient might be a little oozy, but what if I went over the why care about going over on protamine? Well, these are the 4 main points. And I see it most when we get a PT and PTT back from the lab. I'll see the extension of the PT and PTT. And that's always sort of proof in the pudding that the protamine, we went way over and we're having an anticoagulant effect. I also see when we overshoot protamine, I see a lot of oozing at the end. I see those are the type of patients that tend to be oozy. Not so much the patients that had heparin, that had more heparin than we thought they needed. It's the patients that received more protamine than what we had suggested or what was needed. It has a tremendous effect on the inflammatory response too, but the anticoagulation effect of protamine can be very profound. And there's some really great journals that talk about this. So when we look at and when I'm sort of putting together the questions for the Shark Tank and what the main kind of topics to cover, they translate year to year. It's not brand new. We talked about how can we identify maybe an AT3 deficient patient. That's through our HDR and the slope value. One of the questions on that submission on the Shark page was, tell me about blood product utilization. Everyone's on, this is not new, and no one escapes that. No one escapes the goal of correcting the amount of blood products that they need to give. I haven't been to one account where they said administration is super happy. They're super happy. They don't want us improving at all. I've never run into that. So even if you're running at a good clip and you've got a rather reduced protocol with blood product usage, I think there's room for improvement. And this was a study done. This is one of the more recent, larger retrospective studies done by Dr. Khan at Summit Hospital in Oakland, California, sort of my neck of the woods, where they had issues with blood product usage and bleeding. And corporate asked them to take a multi-layered approach, a multimodality approach to help correct what ails. And they did. They changed a lot of things. They looked at their circuit volume. They looked at their oxygenator. They made improvements in a lot of different areas. This going ACT-based empirical protocol regimen and mindset to an individualized approach using the HMS really, really improved things. They went from, they are now using, again, they looked at sort of a hard stop date of when did they implement HMS before and after. So this, we didn't do the study, this is their data of before and after paradigm. 61% of a total RBC reduction and 56% reduction in platelets. Their ICU, they were giving a lot of platelets and they needed them. I remember talking to the surgeon about, you know, what's your trigger to treat? What's your trigger to give all these blood products? And it was a rather simple indication. When the patient's bleeding and they're wet, we're giving blood products. So they were able to get some very, very remarkable improvement in their blood conservation initiative. They also found, and when you look at this, remember I said you tend to give more heparin than you might. They actually went to a coded circuit. So they reduced their target from 480 down to 400, which is a common practice if you're using a coded circuit, to reduce your 480 down to 400 is super common. That's what explains the reduction of heparin. But the reduction, even though that they saved 23% less in heparin, they saved 46% in the protamine by taking that individualized approach. And the dryness of the patients is just extraordinary. I was in their ICU last year talking to the team about their challenges in managing the patient postoperatively and the impact that perfusion has. And it's remarkable. They don't really understand what you all do and how you all treating and managing the patient directly affects their world, because it's their patient now. So this has been a really great study. We're going to have some follow-up information this year on how things are going and how the blood product savings is trending. But I definitely wanted to address that. This is a more recent study. Medtronic has a library of studies about every issue we've talked about every issue, whether it's hemostatic activation by being under heparinized. We've got some key components, key anchor studies on that, whether it's cost savings. There's a further analysis on this study about the cost savings to the hospital as well. So that is sort of my kickoff to the Shark Tank. I was hoping this was like Shark Week. I like that. I like Shark Week on Discovery. I'm a big fan, but anything shark related, I'm all for. So I guess we can kind of open it up to questions and concerns.
Well, first of all, thank you very much. I mean, I think that's a great introduction. When I was doing my studies, I had 10 ACT devices in the back room monitoring ACTs. Every one of them was different. The only one that was consistent was the HMS, because it was patient specific at that point in time. And therefore, when we did the study, we looked at, it gave us not only ACT, which ACT is just a number. And really what you want is what's going on with concentration with that patient and being more patient specific. I know we have John Rivera on the line also, who is a guru and one of my tennis partners from years ago in this subject. But what we want to do is let's think about the questions and ask the questions. Do you encounter heparin resistance in your patients? How could patients with high ACT actually need heparin? What is the clinical impact of being under heparinized on pump? How does individual protamine dose benefit the patient? How can I identify heparin rebound after each case? And can I individualize heparin and protamine dosing really to reduce transfusions? And actually, we've proven that over the years. Linda Shore, myself, John Rivera, the studies are out there. I actually feel like This is the best tool, one of the best tools. And granted, it's another piece of the puzzle. Is it the only piece of the puzzle? No, it's not. So if you combine all the pieces of the puzzle in blood management, this is one of the major pieces. So I'm going to open it up for questions at this time. Thank y'all.
Thanks, Ty.
I'll start it off. Ben, somebody had asked, and I've seen this before, what would be the situation where you might have a slope curve, sorry, and it seems adequate. Now this is coming from somebody, but I've seen it, but your ACT is lower than 480, which I realize is an old bull number from the test long ago. But what might the situation be there?
I see that on occasion in two main types of patients where you do your HDR, pre-sternotomy at the line, but you don't quite get to that 480. Two main common scenarios if you had to sort of rank them. Number one would be a higher BMI patient. Sometimes there's a disconnect in vitro test to in vivo patient. It's not dramatic, but that can happen on the higher BMI patients when after the bolus is given, the heparin hides in the fat. The second and the most common type of procedure that I see is on a cabbage, where you get your HDR pre-sternotomy, and it's the harvesting of the IMAs, it's the harvesting of the saphenous vein that really floods the body with thrombotic activity, which actually increases the need for heparin. So that's the most common scenario case. In fact, I was just this past Monday dealing with an account where they had that exact thing, where they did the HDR. I think it dosed around 31,000 units of heparin. The slope was it was a bigger patient, but the slope I think was in the mid 80s, which isn't that uncommon at all. But they got around 430, and they need to be they're one of those programs that live legally at that 480 threshold. So it was a cabbage, and it was a teaching facility. It's a longer harvest, and it was an hour and a half. It was an hour and a half, but by the time they were done. So what they're going to do is they're actually going to increase on the cabbage patients. They're either going to increase the target ACT above 480, or they're just going to give a few thousand more to help get above and beyond. And part of the challenge is how literally are you to that 480? And some accounts are very, if it's 478, even though you've got 10 in the pump, they need to mark that they were above 480. And I like to take those people maybe up to 525. Let's get in front of it rather than be a little short. But those are the two types of scenarios where I see if the HDR is a little short, it's usually that.
So I would say it's a legal standpoint. In some instances, you want to protect yourself, that you probably are adequately anticoagulated based on the hemochrome, but you're reading an ACT that may be affected by a lot of things. But I would probably tend to think that legality wise, you probably want to stay greater than 400, 480 or whatever institution. So you would give it. Now you said in the beginning of the case, but I'm saying while you're on pump too.
While you're on pump two, it's not very common that the ACT is going to go below target, but your heparin level is on point or above. It's usually the opposite. So if your ACT is sort of taking a nosedive, but your heparin level is on point, the common clinical assumption is that you're declining in AT3. You're declining in AT3 because you've got a lot of heparin on board. You've got functional heparin. It's working, but your patient doesn't have the amount of AT3 to actually impact the ACT time as you would like. Because that heparin assay, remember, it's not an ACT platform. It's a thromboplastin-based assay. So it's not going to have the skew factor an ACT would. I heard you say, Bill, I heard you say hemocron. Is that the ACT you all are using?
It varies from institution to institution. If I said that, I didn't mean it that way. I was talking about.
No, okay. I get the reason why I ask is I started my coag career in clinical work for hemocron. So I'm well versed, and I often can guide perfusionists on the differentials between that system versus ours. So I just wanted to ask. Great question.
Ben, thank you for the presentation. This is Haz Mohammed. I work with
Hazra, how are you?
Not too bad, sir. How are you?
Good, good to see you.
The big HMS users, the Floridians.
Yes, you are.
We have some situations. I don't know if it's peculiar to my area. I'm in Lake County, Florida, middle of Florida, Mangdora, Tavares. We have patients coming in with ACTs that are extremely high, 183, 187, 170. And so we run their blood samples through the HMS and
at baseline?
At baseline, correct. And that's what they're coming in with. Either they forgot to turn the heparin off, or these patients have extremely high ACTs. So you run the blood through the HMS and as for the HDR and all that stuff. And it comes back, oh, their concentration of heparin should be like 1.24, 1.6. And you give these 110 kilos people 1.6, and right after you find out you go and bypass, or just before, you're not getting to that target ACT of about 480, the legal sort of sanctity we have taken at our hospital. And then you have to redose and redose and redose. And then you start suspecting, is it an AT3 problem or they're heparin resistant? And so we have this problem occurring very often, and people are losing faith with the HMS system.
So they're coming in. Are the patients on heparin, Hazrat? Are they heparinized?
They do have heparin when they're up in the ICU. Our patients don't come off the streets.
But they've already been on heparin, so they're going to have a higher ACT.
Right. You know what I would do? I would run a current heparin level and get a concentration, because clearly they're not at zero, right? Clearly they've got heparin on board that is affecting. It may not affect the slope of your HDR, but it's going to affect where you land to go to 480. I would run a red cartridge. I forgot what cartridge you remember when I was there a couple of years ago with Rod. I forgot what cartridge.
We have the 10, we have the red, and we have the 9.
Yes, I like that menu that you use. I would run a red cartridge and get a concentration value, a current level, and then I would add that to what the HDR recommends. Okay. So you get current added to projected. I think you'll be there.
Okay, because it's raising some doubts in our fellow perfusionists and the staff. What do they trust? And people just run away and give empiric formula. Oh, let's get 3.5 in this case.
Right. Then you're then you're slipping. You're like, why are we doing this? If you're just kind of guessing. Yes, I get it. But there are ways to take that data. You just need one extra step of running that red cartridge. And by the way, Hazrat, if your red cartridge takes a long time to clot, like over 100 seconds, you're probably above the red cartridge. You may want to go to tan.
Yeah, and we do that sometimes.
I see where John Rivera would like to comment on.
Yeah, jump in, John.
I tell people, think of this as a track meet, and we're running a quarter mile. This dude that only needed 1.6 is already at the 220. He has a big head start on me, and the machine doesn't know he already has heparin. It just says, how much more heparin do I have to give him to get him to the finish line? But the problem is, if you don't compensate for the head start, this dirt brain's going to stop 220 yards too short because he lost his head start. So as Ben said, number one, ideally, you want to run the red and identify a value, and then invariably round the hell up. People follow the math, but I get a 2.6. I don't have a 2.6. I got to go to 3. So next step is round up. Number two, there's the therapeutic clinical threshold of the perfusionist. And that is, no matter what this stupid machine tells me, if it's not my level, we're going to go to my level, or number three, and I think I did this with your guys when you were still in Philly, Haas, is
Yes.
that they would automatically add a meg per kilo. So I can give you a little cheater, by the way, with our ACT on a patient who hasn't been too messed up. Every 100 seconds of time over a normal baseline is 1 unit per ml. So here's this dude at 180 and normal's about 120. Dude's at about, he's already at 60 seconds high. So the dude's well over a half to 0.6 of a unit per ml. So I can sort of extrapolate that value mathematically, but that's only because I'm early in the case. Later on bypass, we're dead meat. So, but the key is if you don't compensate, there's no freaking way some fat dude's going to be 1.6. It's like, nay, they think the machine is wrong. No, you got to use that computer on your shoulders and say, what's going on with this guy? Because he obviously came in with a head start.
Correct. And then you look at the end of these cases, these patients are massive, huge. And so you would have given protamine based on the titration studies of the HMS. And then later on, you find the ACTs are starting to rise again, 15, 20, 30 minutes after the patient the operation is over and they're closing the chest. And the surgeon says, well, I don't know, give some more protamine. And
that's that. Do you run another red, Has? Do you run
yes,
another?
We run another red, but they seem to be very sort of reluctant to accept what is going on there. And they'll give another 30 or 40 or 25 of protamine, of extra protamine because of the third spacing and possibly returning to the vascular system. And maybe the half-life of heparin is not done, put it that way. So they get into that mode. And we have one surgeon who goes on saying, well, he's not giving any dirty blood from the cell saver because it has heparin that will cause bleeding. They call it dirty blood now, and they rather go to outside blood. And Dr. Spies this morning actually said that is wrong. But we have people who are old-fashioned who has not changed.
I got a question here from the audience. Basically, are most people using, this is Gary Lear, are most people using three per kilo on their HepCons, even with high ACTs?
I guess like people will use as 3.0 is a little high as your basement value. So if you, the default protocol is going to be rewritten by what the HDR recommends. So you could put in 3.0, but that 3.0 is going to be replaced by whatever the HDR recommends to get you to 480. So that default parking of a 3.0 or a 4.0 really is it gives you an idea of how different you are, how different you're being recommended off your ideal, but it's also the value in the event that you don't have time to run the HDR. It's an emergency case. You are slamming with heparin. Everyone's landing the OR and you are in no time shape to run the HDR. You're telling the instrument as a default ideal measure 3.0. I'm seeing more of a 4.0 because of this heparin is so much weaker. Right. So I see more 4.0 as my default than 3.0. I used to 3.0 before 2012 was more common. I see 4.0 now.
So if your machine says 2.8, you're saying that you can edit it to go to 4.0? Is that what you're saying, Ben?
No, I'm just saying if you park in the instrument parameters where it's going to ask you, your all your protocols, your target ACT, how much, all the height, weight, and sex, all that under patient, and then protocols. There's a default concentration that is parked there. And that number could be 3.0, it could be 4.0, can be really whatever you want, but whatever the HDR results at will replace and rewrite over that 3.0 or that 4.0.
Right, but you can edit it again, and I think some people may keep a minimum of 3, and I think that was the comment, whether or not they believe at 2.5 they're okay, but they're going to use at least 3 as a minimum anyway.
Yes. So, and that's another choice I think that John mentioned for Has, is that if you get something oddly low, like 1.7 or something, and you didn't have time to run that red at the beginning to discover the current heparin level, you can just, wherever you resulted on your HDR, you can hit the lower left button that says change heparin concentration, and increase up to 3.0, or whatever you feel is the minimal that you want to run as a group. And I see a lot of perfusionists will increase that heparin level. If you do get a 2.8, they don't want to be in the middle of 2.5 and 3.0, because that's how the instrument, that's the resolution of measurement, is by 0.5 mg per kg. So if you're running a blue, you're either gonna get a 2.5, a 3, a 3.5, or a 4.0. That's it. So if you're land in the middle of one of those two levels, a common protocol is just to adjust higher up to the even number. So a 2.8,
Yes.
a 2.8 to a 3.0 is super common.
I would like
That's
to
good.
point out, this is something that's happened both in the US and Europe. As of this week, I've been taking these phone calls, and again, as Ben said, everybody's moving it up, because MUSC did the studies. That student said 18% less potent. Nebraska did the study and they said 12% less potent. And you guys know that it's really running about 20% lighter. So 3.0 ain't good for anybody anymore. So you got to be at 3.5 and 4.0. But in autotransfusion, if you're using heparin and you're only using 30,000 units in a liter of saline, you got the same freaking problem. So you guys need to increase your heparin level to 40,000. 30,000 is too late. It's diluting saline. You need to get up to 40,000 on cell salvage, because I'm taking questions in North America and in Europe. How the hell am I getting clotting in a holding bag when I did all of this and I did it right? So we've increased heparin on bypass. Please increase heparin on autotransfusion.
And that's the other point. I mean, this is a great device for QCs or the autotransfusion devices. I mean, we use it routinely for our autotransfusion. It's part of our when we're looking at our autotransfusion devices in our two-step program. The one other thing I want to point out, and maybe John or Ben can basically hit on, I mean, when we're looking at ACTs, I don't care what device you're using, and you're just looking at an activated clotting time. It's just a number. And, it's not really patient specific. We need to basically look at the whole broad range of what's going on with the patient. And again, I actually feel like even in some cases where the tag can be incorporated with the HepCon device as far as monitoring heparin on board these patients. I think a good collaboration with both those devices is actually good. So,
I agree, Ty. That's well said and well explained. I think we play very well in the space together. We don't.
Absolutely.
A common question I would get is, are you competing? No,
absolutely not.
No, we're not competing. We're complementing. They're doing something different than what we are. And the combo of the two is very powerful.
Absolutely.
But bleeding post-operatively, or any bleeding, is a four-legged stool. So one leg is coag factors, that's ACT. One leg is heparin, that's HMS. One leg is platelet function. So it's whatever viscoelastic platelet function device you're using, which I think all centers have to have. So what's the fourth leg? If all of those are good and the patient's still bleeding, it's called ASD, acute suture defect, or hypoprolinemia. So that's when the surgeon has to step up. And you've told them in 15 minutes, hey, it ain't this, you need to sew. Otherwise, we're going to come back in 2 hours, we're going to get half the blood bank, and we get to crack the OR to the tune of $10,000 we ain't going to get paid for again. And that's some pretty crappy business. By the way, the first time I said that at the New York State Society of Perfusion meeting, I was the first speaker. Next speaker was a cardiac surgeon. And he said, I've been called a lot of things in my life, but I've never been called the fourth leg of a stool. But the good news was he agreed with me and told your colleagues they better freaking have that equipment to help them out.
That's
Always great. Always a great reply.
And for the record, that was probably the cleanest, most PC story John Rivera has ever told. So
absolutely, it was.
Hats off to you, John. Ty, you agree with that?
I definitely agree with him.
Yeah.
I mean, most of them are incredible.
Do you have a sense of how many people are, what percentage of the U.S. is doing heparin concentration? That's one of the questions on the list here. Is it 30%, 50%?
Close to more than 50 under 60, and
Okay.
I think a little more on the coasts. I see a higher concentration on the coast. I live out on the crazy West Coast, and there's a very high degree.
I just felt 75. Naked when I was a traveler, and I would go to institutions where they would have just an ACT. I absolutely just felt like I was kind of naked as far as heparin protamine titration in the operating room, and I just felt like, yeah, there's got to be a better way. I mean, these people have got to get on board, and I don't know how I can get them on board. But we were at the end of the case, and the patients are bleeding, and yet I had a normal ACT. Well, hell, I didn't know anything, and I just felt like if I had the right instrumentation, I could know a lot more of what's going on with the patient. So therefore, that's my deal.
John, you made
something we. Sorry to interrupt, Sub. I haven't said anything thus far. I'm really enjoying the conversation here.
Brian White, yes.
Hi, everybody. So at our institution for a while now, we've utilized pre-op AT3 level testing on anybody who's been in-house on a heparin drip before surgery, and found it an incredibly useful piece of information to have, just to kind of give you an idea going into surgery what you're going to be dealing with. And we created a protocol around it. It's not super common to have to directly replace before bypass, but we do, especially if they're below a 60% functionality for AT3. And it gives you kind of a leg up as opposed to giving your dose and then redosing and getting frustrated and waiting to go on bypass, perhaps not even, thinking the HMS is wrong or you're doing something wrong. And I think I'm a huge advocate for AT3 itself. And given the expense, I think it's difficult to swallow sometimes for institutions, but in the overall health of your patient, I think it's of the utmost importance because it is the reason that heparin actually works. So if we're not paying attention to it, then what are we really doing here?
Brian, how did that get involved? How did that become part of your clinical SOP?
I don't want to take full credit for it here. But
that's great.
So I kind of spearheaded the effort. I spoke with my chief, spoke with a couple of my colleagues. Everybody liked the idea. We tried to sell it across the board in terms of every single cardiac patient, inpatient or outpatient, and we settled on at least for the inpatient folks who are on heparin drips. I'm still pushing. I'm hoping we can add it to PACT pre-op labs for everybody coming across the board. I'd love to have that number to work off of for every case. I think eventually we'll get there. Our surgeons have been very happy, given that it's exceptionally rare that we ever have a situation that our dose isn't adequate to get on bypass, just because we have that peace of mind. And if we need to replace AT3, within minutes of them coming into the OR, we know that we need to do so. Anesthesia gives it in a drip form. Sometimes, they start it just after intubation, and then they are fully replaced and ready to go before we even touch them with heparin. My curiosity would be, sorry, John, go ahead.
No, keep talking.
I was going to say my curiosity would be before replacement of that AT3, say, for example, we have a 40% AT3 pre-op level. We get in the room and we draw baseline numbers, run our numbers on the HMS, then give our AT3 calculated replacement dose, then draw another baseline. I'd be curious to see what we come back with. And I think that's what you're probably getting at.
Well, yeah, your slope will definitely
change. It'll change.
It'll change. Sure. Your heparin recommendation will become much more moderate and predictable. AT3 is a big discussion point at Medtronic. Did you get any pushback? The pushback, was it because it's a new measure they didn't know? Was it a cost issue, or because what you're doing sounds very very smart and wise? Did you get any pushback?
I mean, we did get some pushback. I have an incredibly progressive team, an incredibly progressive chief in Candace Kalin, as you well know, and very supportive surgeons. So, I mean, the only pushback really was in the fundamental cost, because it is a little more expensive of the drug, but ultimately because we saw better results, quicker times, less wasted time in the OR in general. And honestly, you know, if you have your AT3 levels where they need to be, you're going to have better reversal as well.
So I wanted to chime in. If you go to pediatric facilities running the HMS, almost all of them are routinely running AT3 levels now, because we know kids are AT3 deficient to start with, and you get those really crappy slopes of 50 to 60 seconds. So it's great that you're doing that on the adult side. I think I can help you with the money. You know, you have two alternatives: thrombate or fresh frozen plasma. And issues with fresh frozen plasma: donor, liquid volume, and you have no idea how much AT3 is in there. Now, they say thrombate at $1,500 a bottle, and everybody puckers up and starts squeaking when they're walking. Well, remember Dr. Shander did that activity-based costing analysis and said that any blood component you buy from a blood center costs 3 to 5 times the acquisition cost to prepare it and get it to the patient. Fresh frozen plasma, of course, has to be thawed. Well, if you do it Dr. Shander's way, that means every FFP is $750. So for an adult, I'm talking 2 FFPs minimum, even up to 4. So the point is, Brian, there's your money. There's the $1,500. So like Jerry Maguire, I just showed them the money with a known amount of AT3. Now, the second part that I wanted to cover on the cell saver part, and I saw it this morning and I'm seeing it now, is this crappy blood, dirty blood from the cell saver stuff, which comes from people with a severe cranial rectal inversion, because that blood has removed 95% of everything that is not an intact red cell. It's beautiful red cells with plasma. And Dr. Hansen in Germany actually looked at mean cellular volume, and he found, compared to immediate hemodilution, donor blood, and autologous predonation, and he looked at the 4 red cell masses with 4 different radioisotopes, and he looked for survivability after surgery. Guess which blood had the highest survivability percentage? The wash blood. Guess which blood had the largest mean cellular volume? So to understand it, the difference between Brian and me: young, studly, muscular guy, great skin and beautiful hair, and I'm the bald-headed, overdressed street guy. Tell me which red cell you want. Well, that's what you're getting from the bank blood. And remember, Dr. Cook said, hey, the mortality of getting blood and cardiac doubles at 5 years from 1 unit. And that doubles again if it's a crappy unit over 14 days. So on this planet, the best red cell product you can give a patient comes from cell salvage, and all the devices remove all of the heparin. And what the load that's left is not even 25% of cath lab heparin, where they get 0 protamine.
And John, hey, John, please don't sugarcoat it any more than that, okay? If you could. And Jonathan Waters basically had a great presentation this morning on that same subject. So again, I love your enthusiasm. It always makes me just laugh consistently.
At my age, Ty, I'm just happy to be chewing my own food and not wearing a diaper.
Hey, well, Brian, Brian, I know you all are new to HMS. At Wellstar, I'll be there next month for Go Live, and it'll be interesting to see that if you're still getting that percentage of those percents of AT3, how that shows in that HDR that you guys will do. That'll be great info.
Absolutely, and we definitely have to talk as well. For a couple of years now, we've been using a very interesting. I've talked with Brian about this as well. A very interesting algorithm that I created that has some similarities to a little bit of how HMS functions, except for it's a little more of an educated, I hate to use the word, but an educated guess. So we'll have to talk about that. I think the HMS is going to complement, but I'm going to use over the next couple of years, use a little bit of the HMS data to draw some comparisons. I'm just really curious how it'll change things.
Yeah, fantastic.
What about advances in technology here? Is anything, can you talk about anything coming down the pipeline or? Or
we're actually going to put on a fax machine on the HMS in its current form.
That'd be great.
It'll be great.
John Rivera going to be on it?
Yes, yes.
You don't want that.
Does it come with AOL program?
Right.
However, for you
how
guys,
is it going to? How are they going to basically cut out a lot of the verbal information that he puts online?
Well, I tell people when you buy the HMS, I got good news and I got bad news. The good news is you get me. The bad news is you get me. So it's up to you, because Ben and I are actually available real time. I tell people, don't wait till after the case and holler at me. You got a freaking cell phone. I need to see all the tapes. Tell me what's going on. I'll put on my rumpled raincoat, my cigar, and my glass eye like Columbo, and I'll find something that you probably missed. And to answer Brian's question, at the upcoming perfusion meetings, for those of you who are interested and experienced, we're going to have voice of customer sessions regarding the development of the next generation HMS device. And in reality, we've been talking about it for 8 years, but I assure you, as you go to the meetings, please go to the booth, see Roger Matias and say, John Rivera said I get to talk to you, and tell you that I want a gum dispenser on my HMS.
Man, we thought COVID was a pandemic. Then came John Rivera.
That's
right.
Now, John, I know we had a talk 2 years ago where all of a sudden they tried to change my HMS protocol, and at one of our institutions, and I said, no, this ain't right. So you basically got to follow the right protocol for every patient and use the right cartridge for every patient, and be patient specific. It can't be just a routine automated what cartridge use on every patient type situation, correct?
Right. Well, that's the whole point of the exercise. It kills me. People buy an HMS. One example, they don't run an HDR. They use an empirical value. Number two, they run an HDR and then they never run an HPT cartridge. Number three, they pick an arbitrary protamine reversal ratio, which in the old days was 1:3 for bovine, beef lung, 1:1 for the good pig, and it came out as 1 with the current product. In reality, by the time you run your last assay and you come off a bypass, time has transpired, heparin has been consumed. So many people are dropping that heparin protamine reversal ratio to 0.8 to 1 or possibly even lower, because we're never instantaneously on bypass and we're never instantaneously off bypass. So, I tell people, you just bought a freaking Cadillac Escalade, and all you're doing is sitting in the driveway, listening to Sirius radio and having a beer, and you ain't driving it any damn where. Don't buy the car then. Buy a Volkswagen or a bicycle, and don't forget the seat.
Always a pleasure online with you. I just love it.
But John, in the line of what Brian just commented on the technology, let's say the patient is proline positive and you followed all the protocols and HMS and the rest of it, but the patient has a major coagulopathic problem. Is the HMS moving in that direction where they're going to start incorporating the tech technology or the Quantra technology, and you'll have a complete profile right in the OR as point of care?
You guys are going to tell us, Haas. We've been talking about that for a long time. Ben already talked AT3. So imagine running an HDR, Brian, and that not only tells you the patient's AT3 deficient, but it tells you how much on the spot. So for example, that would be one thing. So what I'm asking you all to do is please emphasize that, because like our oxygenator that you guys design, we're counting on you guys to design the next generation device. And that's what we're going to incorporate. So we really need you to advocate these questions and what you're looking for. And you may not remember, but some of the old timers in Thai, we used to have platelet function on the HMS, and it was a linear test with increasing levels of platelet activating factor. And you had to edit it all the time, but you know what? It worked. But the problem was we had no controls, and the FDA came back and said, you got to make controls. Well, the cost to make those liquid controls was more than 3 years worth of cartridge sales. So this was a pretty easy business decision. Medtronic said, Rivera, nay, moose breath, we're going to make that go away because it's too expensive. So yeah, people forget that. So in 99 to 2002, we actually did have a platelet function. So obviously it's something important to us, but independent of that, I still believe you got to have somebody's viscoelastic platelet function device because it's such critical information. But on the other hand, they're not a freaking HMS, and their heparinase channels tell you there's heparin on board, but they don't tell you how much. So that
Right.
ain't a heparin dose response, and it doesn't tell you how much, but doggone it, you got to have platelet function too. Now, whether we can do it and pull it off, we're going to have to see. But again, we rely on folks like you guys to tell them in the voice of customer sessions.
I see on the scroll that Roger Matias, he's our global product manager for HMS. Like he's the man. And I see him saying that he's happy to capture feedback about next gen things. So, hey, we'll put you on kind of the list to circle back when it's time to understand, the type of tests you all would like and would use and all that. So.
Sure, thank you.
Well, first of all, I want to thank everybody. Thank Medtronic. This has been an outstanding Shark Tank presentation. Hopefully we'll be poolside next year, and hopefully y'all will attend that. We'd love to have you out by the pool, having a nice drink and having a good slice of pizza. So again, thank you very much. And we can't just, these things are so valuable to our institution. So John, I love seeing you. Ben, thank you very much for all you do. And
Thank you. Thanks, everybody. Thanks for the feedback. Brian, see you at WellStar soon. All right.
Bye.
Bye-bye.
I guess that concludes us for the day. So
That was a great session and entertaining.
You get John Rivera on, it's always entertaining.
Oh, yeah. Thanks, Haas, for joining us.
Thank you for the offer to come in and say hi to you folks. Yeah. But good questions asked, John. Get him going.
we're still getting 1 million comments coming in at this point in time.
Yeah, I see that.
It's just like they're flooding the whole daggum internet.
It's a great conference, great topics, great speakers. I say good job, very good job by everyone.
All right, we're offline.
Take care.
All right.